Have you ever experienced any difficulties because of implant fracture, screw loosening, or dislocation of abutment? The brand new KS system is designed to avoid potential issues for implant placement. With 1 to 2 paper drilling sequence, now it is ready to place implants. The KS comes with a abutment holding system, which is located in the lower part. When the implant is connected to the abutment, it holds these two parts firmly without using a screw. At the moment of loading prosthesis, the KS system prevents dislocation of abutment, which may cause by gingival elasticity. Also, it is more convenient for clinicians because it does not require to see X-ray after loading. For conventional abutments, clinicians are required to select between mini platform and regular platform. However, KS abutment is compatible with all different diameter of implant, so the selection of prosthesis becomes a lot more easier for clinicians. The abutment screw of KS system is designed slimmer, and the space is being used to reinforce the inner wall of the implant body. The KS system is aimed to reinforce abutment by thickening the walls and implant wall as well. In addition, the depth of connection between implant and abutment is increased. As a result, structure of the KS system disperses masticatory pressure effectively. By the reinforced structure, the external force which may affect on the screw stays minimum and eventually minimizes the screw loosening. As of the diameter of 4.0 implant, the KS system secures the degree of strength at 4.5 with the increased depth of connection, reinforced walls of abutment, and thickened implant body. Find your key solution. Introducing the last kit, the lateral approach sinus kit that safely raises the sinus membrane without perforation. The patented drill designs, both dome and core drills, feature rounded cutting edges that minimize direct contact with the membrane. In this way, lateral windows can be created safely. The dome drill in the last kit helps lift the sinus membrane safely while collecting autogenous bone particles between the cutting blades. By creating bone chips between the blades, the core drill's rounded cutting edge reduces the chances of direct contact with the membrane. The last kit's dome and core drills are specifically designed to create the lateral window safely. Last kit allows for more precise control over drill depth. The last kit features drill stoppers in 0.5 mm increments. 6 different lengths of drill stopper allows for more precise control over drill depth when creating a lateral window. All these last kit features contribute to safer sinus lifting surgery and reduce the chances of sinus membrane perforation. Let's go over the advantages of our last kit. It is specifically designed to help surgeons to create lateral windows safely with the patented drill design. 6 different lengths of drill stoppers with 0.5 mm increments allow for more precise control over drill depth. Try the last kit specifically designed for clinicians to perform a sinus lift safely in a short time. Introducing the CAS kit, the crystal approach sinus kit that safely lifts the sinus membrane with a hydraulic lift system. The CAS kit reduces the chance of membrane perforation. The patented CAS drill creates a conial bone lid that keeps the drill edge from direct contact with the membrane. CAS kit ensures safer drilling by preventing sinus membrane perforation. Using the drill stopper makes it easier to adjust the drill depth. The CAS kit features drill stoppers in 1 mm increments. It is possible to control the drilling depth precisely by using the stopper, which ensures safer drilling without the risk of perforating the sinus membrane. The hydraulic lifting technique of the maxillary sinus can facilitate the blood supply of the surgical site. The CAS kit's membrane lifter is using hydraulic pressure to elevate the maxillary sinus membrane higher and wider. Consequently, it facilitates blood supply, which encourages the formation of new bone and the healing process. Try the CAS kit that reduces the risk of membrane perforation to ensure safer surgery. Introducing the Esthetic kit for narrow alveolar ridge split. The Esthetic kit uses expansion drills able to expand the bone buccally and lingually, even in the case of severe alveolar bone resorption. Eliminates the use of a mallet. A safer and easier buccal plate expansion is achievable when minimizing the risk of buccal fracture. During the final stage of implant placement, the implant can secure a strong initial stability in the narrow ridge without tilting. The Esthetic kit allows regular size implants to be placed in narrow ridges with a low risk of buccal fracture. You can try it out. Introducing the 485 kit, the kit for placing short implants. The 485 kit has drills with round design apex, which minimizes damage to the inferior alveolar nerve when performing surgical drilling. The 485 kit allows you to place 4 to 8.5 mm short implants. Only 3 drilling steps are required when placing implants with the 485 kit. When placing short implants, try the 485 kit. MS Implant. Introducing the MS Implant, the one body type implant for narrow bone width areas such as the mandibular anterior region. There are 3 types of MS implant: narrow ridge, denture, and provisional. First, the narrow ridge is a one body type implant suitable for areas with narrow bone width or narrow interdental spaces. Second, the MS denture is an implant designed for overdentures. Third, the MS provisional is used when immediate placement of the temporary prosthesis is necessary. Try the MS implant in the mandibular anterior region where the bone can be very narrow. Introducing Osstem Implant's HySil PLUS. HySil Light Plus is excellent at reproducing fine area. HySil Light Plus can reproduce 20 micrometer lines without any tears or distortion. The stone model poured from a HySil Plus impression produces smooth surfaces and separates cleanly. Thus, the user can fabricate accurate and precise prosthetics. HySil Plus is highly hydrophilic. HySil Plus has a short intraoral setting time of 2 minutes and 30 seconds. HySil Plus offers a sufficient working time of 3 minutes and 50 seconds. HySil Plus has a high elastic recovery ratio of 96.5% or more. Experience HySil Plus for accurate and precise impression taking.
임플란트 유명한 게 좋을까?
뭐가 달라도 다르겠죠.
임플란트 세계적인 게 좋을까?
뭐가 달라도 다르겠죠.
치과 의사에게 사랑받는 게 좋을까?
뭐가 달라도 다르겠죠. 오스템 임플란트.
세계가 주목하는 치과인의 학술 행사 오스템 미팅 2025 서울. 트윈타워 4층 대강당에서 열리는 오스템 미팅 서울은 영어와 중국어로 동시 통역되어 대놀 사이트와 유튜브를 통해 전 세계로 생중계되며 컴프리hen시브 디지털 덴티스트리를 대주제로 각 세션을 빛내주실 4분의 좌장을 모시고 임상에 바로 적용 가능한 강연과 함께 오스템 미팅의 꽃 라이브 서저리와 토론 세션이 진행됩니다. 오전 세션에서는 김창성 교수의 병적 치아 이동을 위한 디지털라이즈 페리어던틀 트리트먼트와 김기성 원장의 보철과 치과 의사가 알려주는 쉽고 안전한 상하 구치부 임플란트 수술 강연이, 오후 세션에서는 지대경 원장의 구체인지 디지털 교정 치료의 진화, 투명 교정 증내 파헤치기, 이종국 원장의 구찬스 투명 교정의 효율적 치아 이동을 위한 임상 팁 강연이 펼쳐지며 오전과 오후 두 차례 선보이는 오스템 미팅의 하이라이트 라이브 서저리에서는 오상윤 원장이 원가이드 시스템을 이용 하악 전치부 치경부의 심리적 개선을 위해 넌서머지 GBR과 CTG를 함께 활용한 수식을 선보이고, 김용진 원장이 즉각적 로딩을 통한 풀아치 임플란트 재활, 과제와 해결책을 주제로 라이브 서저리를 진행합니다. 마지막 토론 세션에서는 백운봉 원장, 창동욱 원장, 조영진 원장이 임플란트 치과학에서 학제간 접근을 통한 종합적 솔루션을 주제로 난해한 케이스에서 교정과, 치주과, 보철과 전공의가 협진하여 최적의 치료 계획에 대해 다양한 견해를 나눠봅니다. 오후 2시부터는 3층 세미나실에서 마련된 임플란트의 기초를 다져줄 임플란트 베이직 세미나, 개원 준비와 성공적인 경영을 위한 개원 세미나, 치과 기공사를 위한 치과 기공 세미나까지 다양한 주제의 강연이 진행되며 오스템의 다양한 제품을 소개하는 전시 부스와 20여 편의 우수학술 포스터, 직접 현장을 찾아주신 분들을 위한 특별 프로모션과 다채로운 이벤트가 마련되어 있습니다. 디지털 치과의 밝은 미래를 제시할 오스템 미팅 2025 서울, 지금 시작합니다.
오스템 미팅 2025
Hello everyone,
서울. 여러분
I'm
안녕하십니까?
MC 하늘 Lim.
아나운서 이만을입니다. 네, 먼저 행사를 시작하기에 앞서서
Before we begin today's event, I would like to take this opportunity to express my sincere gratitude once again for your enthusiastic support of the dental staff forum held yesterday. So currently it is 9:03. Let's officially begin the Osstem Meeting 2025 Seoul with the main theme of comprehensive digital dentistry. Today's event features special lectures not only here in the main auditorium, but also in seminar rooms on the third floor. Starting at 2 p.m., the Implant Basic Seminar, Practice Opening Seminar, and Dental Lab Seminar will take place. We look forward to your active participation. Additionally, all lectures and live surgeries can be accessed in Dental Portal, as well as third floor seminars. Don't miss out on the chance to tune in. The Osstem meeting continues to gain remarkable attention from dental professionals around the world each year. Thanks to this growing enthusiasm, dental professionals from 10 countries are participating today, both online and offline. Additionally, today's mini lectures are being broadcast with simultaneous interpretation in English and Chinese for your convenience. We have special raffle prepared exclusively for those attending on site. The raffle will be held at the end of the event after all sessions have been concluded. A variety of amazing prizes are waiting for you, including Zespa the Clang Massage Chair, Water Pick, Oral Irrigator, and others. Be sure to stay with us till the end. Also, various events are taking place. top 20 academic and clinical posters from Osstem meeting Seoul held in the second half of 2024 will be on display. Photo zone with logo, the official mascot of Osstem Implant, where you can capture memorable moments, are available. Also, on the first floor, you can find a personal color consultation booth to help you discover your best colors, as well as relaxation zone and cafe. A beverage coupon was provided at the entrance, so feel free to enjoy your drinks at your convenience. The second floor shows Osstem product exhibition. Explore Osstem product in the exhibition hall. In the exhibition zone is located next to the entrance of the main auditorium on the fourth floor. Please explore the promotions and consult directly with the product specialists. Catering services with delicious snacks and beverages are also available. Please drop by whenever you have time to enjoy some refreshments. Lastly, for those attending in person, you should have received a stamp tour sheet upon entry. Please collect all 5 stamps from 5 designated spots and submit the sheet at the first floor reception desk to receive a special souvenir. Let's move on to the online event details. For members watching via dental website, we're giving away coffee and dessert coupons to 1,200 participants during the event. Please don't miss the prize entry pop-up that will appear on the dental website before each lecture session begins. The winners will be announced after each session, and the coffee coupons will be sent via text message at the same time. For those who stay with us till the end, on the online broadcast, we've prepared even more exciting prizes, including iPhone 16 Pro, Beauty's teeth whitening device, and others. Please stay tuned and don't miss out on your chance to win. There are a few important reminders when participating in online events. You must log into dental website to join all online events. If you have not signed up yet, please register in advance. When watching on mobile, please keep your phone in portrait mode to participate in pop-up events. Please remember these points. We have also prepared gifts for participants on site. During the Q&A session following the lectures, we will select 10 participants, both online and offline, who ask best questions and present them with Waterpick portable oral irrigator as a gift. We look forward to your participation. Lastly, a discussion session will be held from 4:30 p.m. to 5:30 p.m. Before the session begins, you can participate in a short survey related to delivering comprehensive solutions through interdisciplinary approaches in implant dentistry by scanning the QR code displayed on the current screen or at the entrance door. The discussion will be based on survey results, so we encourage you to take part in it. For online participants, the survey links will be sent via text message. Now let's officially kick off the Osstem Meeting 2025 Seoul. To celebrate today's event, we have a congratulatory speech prepared by Vice President Min-jung Lee of Korea Dental Association. Please welcome Vice President Lee with a big round of applause.
Good morning. I'm Vice President of KDA, Korean Dental Association. On behalf of President Park Tae-geun, who could not make it today due to unavoidable circumstances, I'm delivering his message. Congratulations on the grand opening of Osstem Meeting 2025 Seoul at this magnificent Mago headquarters. Since 2004, Osstem Meeting has been successfully held for 21 years. As a global leader, Osstem Implant has made this a globally recognized academic conference. This year, with the theme of comprehensive digital dentistry, renowned scholars will present various academic and clinical lectures, including live surgeries, implant prosthetics, and digital dentistry. I'm confident that this will be a good chance for dentists from home and abroad to check out the dental innovations in the fourth industrial revolution era. As a leader representing Korea, Osstem Implant achieved over 1.3 trillion won in revenue in 2024, solidifying its position as a global implant leader. Moving forward, I hope that KDA and Osstem Implant will continue to collaborate, ensuring that Korea is at the forefront of global dental technology. Dear colleagues and esteemed members of Osstem Implant, this year is special for KDA as it marks a 100th anniversary. To celebrate, KDA is organizing a 100th anniversary event from April 11 through 13 at Songdo Convention in Incheon. And Osstem Implant gave us a very good assistance, and I believe it will be a successful celebration. As we close a proud century of history and design the next 100 years, all of you are invited to this historic event. I would like to express my deepest gratitude to Chairman Takeo, CEO Kim Hae-sung, and all the Osstem Implant people for making this meeting a success. And I'm behind all your efforts. Thank you.
So, as the Vice President Lee has mentioned, today will be a moment of innovation. Please give her another round of warm applause. We are excited to present the first viewing event exclusively for our online participants in Osstem Meeting 2025 Seoul. Please check the pop-up window currently displayed on the dental website and submit your entry now. The winners will be announced at the end of this session, and the coffee coupons will be sent via text message immediately after the announcement. Here's something important to remember. The longer you watch, the higher your chances of winning not only coffee coupons, but also dessert coupons and other exciting prizes goes up. Now it is 9:12. Welcome to Osstem Meeting 2025 Seoul, where dental professionals from all over the world comes together. We will now begin the first session. The moderator for this session is Professor Jun Sung-shim of College of Dentistry, Yonsei University. He has graduated from Department of Dentistry at Yonsei University, completed residency in prosthodontics at the same university, earned PhD from University of Manchester, and served as chair professor of the Department of Prosthodontics, College of Dentistry at Yonsei University, clinical director of Prosthodontics Department at Yonsei University, as well as president of Korea Academy of Prosthodontics. So let's welcome Professor Shim. Greetings. I am honored to moderate the first session at Osstem Meeting 2025. I am honored to be here with so much celebrated guests. Let me introduce the first speaker.
안녕하십니까. 연세대학교 치과대학 치조학교실에 근무하고 있는 김창성 교수라고 합니다.
I'm Professor Kim Chang-sung, and I'm going to talk about this topic, this digitalized perio treatment for pathologic tooth migration. As a periodontologist, it is important to preserve compromised teeth. So inflammation control is very important. Let's talk about the complications. Pathologic tooth migration, secondary TFO, that causes tooth mobility and radiolucency, and a functional problem and aesthetic problem as well. Those can pose grave problems. So the purpose of a perio treatment, inflammation control, and we also need to control the complications like this. Exactly 30 years ago, in 1995, 39-year-old female came to me, gingival swelling, redness, pathologic migration with premature contacts, and there are other problems. Opalese teeth and intravony defects are observed. TFO also is observed. DTR and perio treatment was provided. After perio treatment, pathologic tooth migration was used using fixed appliances. After the treatment, the patient was very satisfied with the new dentition, and gingival swelling and redness disappeared, and the healing progressed very well. Functional rehabilitation is progressing in the posterior regions before and after. A lot of improvement was made. 10 years later, so in some areas, intrabony defect is improved, and space widening also disappeared. 14 years later, the patient was very happy. 20 years later, healthy perio condition was maintained. So 68-year-old female, the perio tissue is healthy, and that will she is confident that she will have healthy tissue for the next 30 years. But there's limitations in the fixed appliances. When oral hygiene is not very good, that's a big risk. So CAD/CAM CT is used for clear appliance treatment. That was the introduction of CAT. There are some limited effects, but it is more widely applied. Advantages of CAT for perio treatment, which is a very great advantage. Pathologic migration using clear alliance treatment. To make clear aligners, as you know, impressions need to be taken. Very precise impressions need to be taken. 4-step clear alliance were made. So 4 impressions need to be taken, and it is not easy for patients and the dentists. The treatment went well for more than 14 years. The result of the treatment was maintained, but it cannot be achieved in every patient when a lot of flaring is observed in a patient, and when teeth are compromised during impression taking, and we are worried about the risk of extraction. And the second, this is a non-contact impression. So using the digital scanner, so this is the most innovative thing occurred in dentistry. In the mesial number 23, big intrabony defect is observed. Scanning was made using the digital image. The dentitions can be examined to establish dynamic diagnosis. Space control intrusion and overjet were reduced, and also aesthetic considerations were made. Using digital dentistry, we can predict the result of treatment, and various risks can be anticipated during treatment. So 10 more scanning impressions were taken, but the problematic number 23, it was very good for that aspect. Before and after, spaces are closed, and the problems disappeared. But unfortunately, number 23, gingival recession occurred. The gingival recession is a common complication when it comes to ortho treatment. When inflammation is not controlled, that cannot happen. Inflammation need to be addressed, and the connective tissue was taken from palate. So the full coverage was performed. Compared to before, very good outcome was achieved and maintained for more than 6 years. In the mesial of number 23, very healthy bone was observed, and the patient was quite satisfied with the result. So like this, I use a digital dentistry and the clear alliance in the treatment. So digitalized periodontal treatment is utilized, and that improves the outcome and reduces the complications during the perio treatment. So let me share some of the cases. Not so severe perio patient. Periodontal disease always is accompanied with the secondary TFO, which causes secondary tooth migration, and vice versa. So it is a repetition of vicious cycle. Extrusion on the lateral tooth is observed, and TFO is also observed in the X-ray. Intrusion is made. Fitting the maxilla mandible treatment was provided, which gave a lot of satisfaction to the patient. And this is after the treatment. If you compare before and after, the teeth are intruded. So 40% of the PDL is increased in terms of the tooth length. So perio disease can attack young women, and the patient visited our clinic. In the upper anterior calculus, interbony defect, angular bony defects are observed, and also extrusion with the rotation was observed. The premature contact needs to be resolved to remove TFO. So healthy tissues were recovered, and the result was maintained more than 6 years. After the treatment, a lot of improvement is made, and 4 years later, it looks good too. The good result was achieved not only the perio treatment, but also TFO was addressed. So that's a synergy effect between those two. Tooth fracture, severe occlusal wear, cracks. Also, the findings of TFO, especially in the anterior, TFO is severe, and the perio is very poor. In the upper anterior region, intrusion was attempted with rotation, and the pathologic tooth migration in the mandible was performed, and overjet was resolved. The goal is to address the problems, the severe problems in the interior. So the patient achieved a very good outcome at the end of the day, and the result was maintained. A lot of improvements were made. The perio problem disappeared, and the upper teeth can all be extruded. The patient always speak hiding her mouth with her hand. So So black triangles also observed. So intrusion was done in the upper anterior region. Tooth migration, pathologic tooth migration was made, and the spaces are to be closed. That's the plan. And after the treatment, she smiled openly without hiding her mouth. So after 4 months, it is very well maintained after the treatment. 4 years later, the outcome is maintained before and after. So intrabony defect almost disappeared, and the perio tissue is quite good. Extrusion in the posterior region is quite a headache because it can be accompanied with food impaction, and occlusal plane can be formed in a weird way. So that can lead to implant failures. With clear alliance treatment, simply ideal occlusal plane can be achieved, and the crown shape can be made in a pretty form. The clear alliance and elastics need to be instructed how to use them to the patients, and for 3 to 4 months, osseointegration can be achieved. So not only the young female, but elderly people can also understand the treatment. So severe perio problem is observed, and the perio treatment is made with intrusion carefully. Premature contact in the anterior region needs to be addressed to achieve very good results. So this is a very good outcome of the treatment. So let's look at some serious problem in this patient. Tooth migration is not strongly recommended. Inflammation, which is not properly treated, can be a problem during the treatment. Inflammation control should be stringently made, and before tooth movement, at least for 6 months, it should be POP-free, stayed for at least 6 months. The most important thing when it comes to the treatment is the antibiotics, use of antibiotics. Minocycline is the most commonly used one. When the disease is serious, there are some limitations, 60% or 70% of success rate, and it can easily relapse. In order to overcome the problem, minocycline plus metronidazole can address the problem. So minocycline plus that one in animal study, minocycline plus metronidazole prevents relapse. So that has been observed in many cases. Minocycline plus metronidazole in this study, clinical study, and we could see the effectiveness. Even though the disease is severe, non-surgical treatment like this showed a very good result. I believe the product will be available this summer. So a very serious problem can be controlled with this drug. When there's no teeth in the posterior region, they chew with the front teeth, causing flaring. So the patient spoke hiding her mouth with hand, and there's no contact in the upper anterior. So pathologic tooth migration was suggested, and space was controlled, and the severe overjet was addressed. There were too many spaces, and the spaces were planned to be moved behind the canine. And now the patient was very happy after the treatment because the patient goes out with her daughter often. So after 5 years, the condition is still very stable. In 2005, the patient didn't have a big problem, but when another visit in 15 years later, pathologic tooth migration was observed. Also, crowding, hopeless teeth are present. So a sinus bone graft also was done. In University Hospital, the treatment cost is quite high. It will cost more than 20 million won, and I imagine the result of the treatment. So it is very costly treatment, and can the patient smile after the treatment? So there is implants were placed and spaces were realigned. The important thing here is that using digital dentistry, until tooth movement is finished, the implant placement do not need to be delayed. We can anticipate exact implant positions. So that is the biggest advantage of digital dentistry. Implants were placed, and the treatment was finished here, not completely finished, because there was some problem like this, but the result was quite satisfactory for the patient overall. The treatment achieved pretty good results. It was not a perfect result, but the patient was satisfied, and the patient could smile very widely. She is working in a beauty industry, and now she can smile beautifully. And I believe that was a very good result. Force control is the last topic. Root resorption. That is the biggest problem for ortho treatment. If you fail in inflammation control, the young patient can be pretty much distraught. So if this thing happens, all the teeth will become hopeless, and that will give a lot of trouble to a dentist. I'm not sure, but light force for normal periodontium can become heavy force. So we need to be able to do force control, and regional accelerated phenomena, RAP, is suggested. Noxious stimuli, so complex reaction to this. So all surgeries, dental surgeries, can cause this phenomena: swelling, hypersensitivity, tooth mobility. All these are clinical findings. So RAP is induced by extraction and others. The PDL space in the adjacent tooth 1 week after RAP. So inflammatory reaction in PDL space, the PDL space would become wide and the ligament will become loose. Then with weak force, the teeth can move easily, but you do not need to be worried. 8 weeks after, regeneration can be achieved. That is the result of rapid RAP. RAP induction by corticotomy. And I believe you understand the principle of that action, but it is too invasive and it cannot be repeated. So periodontal ligamentomy, a new procedure is something I want to introduce. Surgical extrusion technique. So pediotomy is used for that technique. In 2004, the procedure was introduced for the first time through a paper. The patients were followed up for more than 20 years, and no complications were observed. And this is simple, and it can be repeated. And histology shows that with a light force, the teeth can be moved very easily, and this is safe, and this can be repeated. And light force can be induced. You don't need to wait for 6 months. Simultaneous treatment can be made. Pathologic tooth migration with a perio treatment. And minocycline and metronidazole can work very well too. The patient was treated by me in 2010 due to pathologic migration. Relapse occurred in this patient. So the surgery created a RAP phenomenon, and a light force could be used. And the patient was completed in terms of treatment before and after. Compared to 2010, no complications occurred. Very safe procedure to use. 5 years later, and you can see it is a very safe procedure. So you can see that letter King is on his arm, and I can see he's a boss of some organization, and perio is not very good in this patient, number 15, a blade, and I know how to use it, how to finish the treatment quickly, and the tooth movement, pediotomy, was repeated, and the treatment was finished within 4 months, and the patient comes back frequently because he trusts me. After the treatment, the tissues have improved quite well. When there is no posterior region in terms of the teeth, they tend to use the anterior teeth quite more, and it can affect the face as well. Sinus bone graft was used. I asked my colleagues, how long do you think the treatment would take for this patient? Usually they say 9 months or more than 1 year. But the problem is that during a 1-year treatment, the complications in the anterior region would get worse, so we need to control space, pathologic tooth migration, and overjet needs to be corrected. So ultimately, the excessive force in the anterior region can be alleviated using the treatment. Implants were placed, and the perio treatment was provided. Repeated pediotomy was also done. So anchor burden can occur when there is no teeth in the posterior region, but with a light force, teeth can be moved, alleviating the anchor burden. So this is a very good result after the treatment. Last case, after ortho treatment, the space appeared again, and gingival recession occurred. And root coverage is something the patient wanted, and I tell the patient, this is root prominence. So root coverage is not easy to do, so I recommended this. Before root coverage, periodontal modification is necessary for alignment and space closure, especially when there is prominent roots. Lingual retraction was planned on CT. On the lingual side, there's a sufficient bone space. The cortical bone So during ortho treatment, it can cause a slip out. But repeated episiotomy, they could be moved lingually, and 3 months after, periodontal modification was achieved. Periodontal modification only, the gingival recession greatly improved. In this condition, root coverage. I asked my junior doctor. I referred this patient to him and to the doctor, and he has a very good skill. So almost complete root coverage was achieved, and thick biotype was achieved. So long-term predictability was achieved before and after. You can see huge improvement before treatment. Periodontal modification followed by very good result. Today, I talked about digital periodontal treatment to enhance the effect of perio treatment, to control the complications, and there are some contraindications as well. So new paradigm is suggested using this technique. Even compromised teeth can have a very good result if you still adopt early extraction. I believe it is not very good for dentists. Saving compromised teeth is our major mission, not only for me, but for all dentists. So I hope my lecture contributes to achieving in this mission. Thank you. Thank you, Dr. Kim. Thank you for the wonderful lecture. Please give him a big round of applause. I believe you have some questions, and we will take questions after listening to the second lecture as well. You can raise questions online as well. The second speaker.
The second speaker is by Dr. Kim Gi-sung of Namsang Dental Clinic under the title Easy and Safe Maxillary Molar Implant Surgery Insights from a Prosthodontist. Please welcome Dr. Kim with a warm round of applause. Greetings, I'm Dr. Kim Gi-sung of Namsang Dental Clinic. I would like to express my gratitude to Osstem for giving me a wonderful chance to stand here. And I would also extend my gratitude to Professor Shim. There's a bit of technical difficulty, so I'm going to proceed with verbal explanation. When we do implant treatment, we come across upper posterior. So I'm a prosthodontist, but I want to talk about surgical side. I want to focus on the upper posterior area. I only talked about prosthodontic side, but in the case of today, I want to talk about surgery. And because today's topic is interdisciplinary approach, I want to talk about the sinusitis. So when we place implants, including in sinus, a lot of people hesitate if we come across this kind of case, so if we just avoid the upper posterior entirely like this, then we would miss out on many patients. So even if we do implant treatment, I think the upper posterior is something we cannot avoid in a lot of senses. It is unfavorable. The bone quality is not good, and the bone amount is not good. Also, because of pneumatization, there's lack of bone, and it's inaccessible. I wanted to address my position amongst these conditions, and I would like to also talk about bone compaction kit. First, in upper posterior, this is a summary. First, you need to do guided surgery. In all cases, I do guided surgery, and I use a OneGuide kit. I have made a book out of it. A lot of people should do a guided surgery, especially in the posterior area. One CAS kit, one guide kit, 1485 kit. They can be used appropriately for upper posterior, and in light of that, if you do guided surgery, flapless surgery is possible. And if you look at different lectures in the posterior area, so the surgery specialists like to use their knives. So in the posterior side, if you look at the bone quality and amount using CT, and if you assess the amount of keratinized tissue, then at times wonder why we need to open flap. When we do guided surgery, we can do flapless surgery, and in a lot of cases, because of lack of residual bone, we need to do crestal lift. The different systems are available to help us provide treatment. In Osstem, there's casket at one casket, as well as a bone compaction kit, which is gaining popularity and was launched recently. You'll be able to do sinus surgeries much more easily. And the implant itself is very important. My favorite surface is BA and soy, and it allows for rapid osseointegration. This will lead to good implant treatment results in the upper posterior area. This is the OneGuide kit lineup for guided surgery in upper posterior. You will not be able to use one MS kit, which is designed for the lower anterior. When you use guided surgery, you can place not only one implant but multiple implants, and you can assess the residual bone amount and quality and gain good implant treatment results. Also, good prosthesis for the patient. So given with guided surgery, if there is sufficient amount of bone and keratinized tissue, I tend to do flapless surgery more frequently, and in most of the cases that I'll show you are flapless surgeries. In relation to sinus, there are many techniques available in Osstem. There's casket for crestal approach and last kit for lateral approach, and good results have been achieved. Personally, I really like the casket. The end of the drill, even if it is in contact with membrane, it does not tear the membrane. Hydraulic membrane lifter can be done, and sufficient amount of membrane lift can be done. Also, bone carrier could be used to add powder type of bone graft material into the sinus, so you can get good results with that. One part that was lacking is that because this is a blind technique, the height checked by CT, depending on the direction we use the implant engine, there can be slightly deviations. So casket is good, but I use one casket. So the one casket is designed for guided surgery using casket, and since then, crestal sinus cases showed good results using this kit. This is the first case in 2017. At the time when it was first launched, I planned the implant surgery and placed the implant here, and as planned exactly, the crestal bone went up and implant was placed, and this is the autogenous bone, so there's a bit of resorption, but up to the implant apex, bone formation was nicely done. In one lecture, in 2017 to 2023, I have done statistics out of it. Out of 450 implants placed during surgery, sinus membrane tearing was just one case during surgery, and not all cases were successful. And at times there were late ruptures, and at times there were about 6 failures, including sinusitis. But the sinus lifts were overall done very safely. Statistically, compared with what is written in the documents literature, the success rate may seem quite high. But I am very cautious in my approach. This is written in the Osstem textbook. Depending on vertical bone height, we can determine the approach. If there's about over 4 millimeters, you can use crystal approach. If there is less than that, we need to do lateral approach. Personally, different people have different standards. So if there's no lesion in sinus, if there's a residual bone height of 3 millimeters, I use crystal approach. And if there's 7 millimeters, depending on different situations, I use short implant to address the implant treatment without addressing the sinus. Using sinus lift, I used one cascade very successfully, and as of late, I have used a bone compaction kit, which was launched last July. And I became to really favor this kit, one cast kit. I moved on to the bone compaction kit because of the osteodensification concept. So this was first designed by Densaber in 2012. So the Sala raised a patent, and for osteotomy, we had to remove bone. By changing the direction of flute, we can push the bone towards the side and the apex side. Therefore, we can conserve the bone and compact the bone. Using this concept, Osstem has changed the flute blade and changed the direction of the blade so that at the tip there is a prep, but at the flute area, bone compaction can be done. So it can be used for sinus kit, and if you use it for bone compaction, you need to use it for soft bone. This is 1 to 2 taper drill, bone compaction drill. They were compared. You can see at the sides and apex, there's condensed areas. It's over here. Towards the side, about 0.4 to 0.5, and about 1.5 of bone condensation zone occurs in the apex area. So the first indication suggested by Osstem is you need to gain bone compaction in soft bone to get increased primary stability, to reduce micromotion, and to quicken bone regeneration. The second is in a crystal approach. When using for sinus lift, if there is a residual bone of 6 to 7 bone, we can lift 2 to 3 millimeters of bone compaction and then do the lift. After having used this kit, as mentioned, the residual bone height, even if it is 3 to 5 millimeters through crystal approach, you can lift the membrane safely and along with a bone graft. Yes, you partially use one cast or cast kit drills. So you can utilize this kit for various cases. So let me introduce this kit, the 1.25 lens drill and 2.2 to 5.0. There's different ranges of compaction drill. There's about 30 different drills. This kit is a smaller kit, so it doesn't have implant placement tools. There are different existing kits available, and if you use that in conjunction, that'll lead to best results. There's a stopper, 3mm stopper, and the 11.5 and 13 millimeters are options, and 4 to 10 millimeters are the basic specifications. 6 different length and different diameters are available personally. 3mm option and 11.5 and 13 millimeter options are also necessary. If you have the full option, then you have 40 bone compaction drills. This is the same with 2.2 initial drill, and it has bone compaction concept 3.5 to 5.0. F5.0. You use that, and you would use a 5.0 diameter implant in the case of soft bone, and the distance to stopper is 3 to 13 millimeters. Personally, when you do sinus lift, I use this drill in most cases. Unlike caster 1 cast drill, this is taper drill. Stopper is connected in all of them. It has drill. If you look at F5.0, the top part is 4.0, and on the apex side it is 3.3, which is 0.7 millimeter smaller. So F5.0, the number 1 is a 4.0, and number 2 is a 3.3. If you look in green, F4.5 and F4.0, you need to look at the different specifications when you use them. This drill to the stopper, there's no Y dimension, so the number is as shown. Unlike a 1 to 2 taper drill, so there's 1 millimeter of Y dimension and 1 millimeter of gap between the laser and the marking. So 1 to 2 taper drill, you drill 12 millimeters of drilling is done, but as for bone compaction drill, the length is the same as the length of the implant. So you need to think of the following concept of F4.5 by 8.5 millimeter bone compaction drill. There are different lengths. The reason why I'm showing you these numbers is that I do most of my cases flapless, so at times the bone is in contact with stopper, but you need to understand the different distances to be able to do implant drilling properly. As mentioned, bone compaction, when you use it for bone compaction rather than for a sinus surgery, for F4.5 by 10 millimeter drill, if you do it and place 4.5 by 10 millimeter, it is placed deep. If in a lot of literature, implant, especially one with 11-degree conical connection, if you use 10 millimeter drill, you need to place a 8.5 millimeter implant. There's no gap with Y dimension and gap, so we need to use a one-step oversized drilling. Bone compaction drill, the top part is the same as cast drill, so it has reverse conical shape, so you can lift the membrane very safely. About 1.5 millimeter apex, towards the apex side, bone is compacted, and as you drill, the drill is not in contact with the membrane. The bone graft materials push the membrane. As you can see, this is bone compaction drill. Before you see the drill, you can see the bone graft materials going up. The wider the diameter, the more the bone graft material is bone powder is compacted. So I use it for bone penetration and sinus surgeries. The bone compaction drills are used in sinus lift surgeries. Bone compaction drills, there's a lot of drills, and there's stoppers. You do not need to replace the stoppers because they're already there. If you look at the drill, the flute is very shallow, and it does not have wide dimension. The flute direction is different, so the bone chip does not come out, but it is compacted. Even if you use the same drill, bone compaction drill, when you use it, the primary stability increases as well as ISQ value. So this is not just unique quality of bone compaction drill, but you need to also consider that it is under drilling. I want to explain once again bone compaction. So the diameter of the top part and the lower part is as shown. If you look at F5.0, the top part is 4.0. And if you compare that with 1 to 2 kit, F5.0, the bone compaction drill is diameter 4, but for 1 to 2 taper drill, F4.0, the top part is 4.1 in diameter. So the bone BCD is two times under drilling. Therefore, F5.0 should be done drilling. And if you place the implant, the 5.0 diameter implant, then you can get good result. If you use a bone compaction drill in normal bone or D2 bone, you will not be able to place a 5mm drill, about 5 diameter implant in using 5 diameter bone compaction drill. In soft bone 1 to 2 taper drill, you do 1 times under drilling, and on the right, you do 5.0 bone compaction drill and use 5.0 10 implant. And if you consider the size, the bone primary stability is good when you use bone compaction drill, and if you do not evaluate the bone quality properly, then there can be bone heating as well as other issues. So we need to factor in these. This is a protocol suggested by Osstem, especially in soft bone. You need to use a sinus drill, and you need to penetrate the cortical bone, and 5mm diameter implanted drill, bone compaction drill, should be used from 2.2 to 4.5. And finally, 4.5 bone compaction drill with increased length from 5 to 7. 4.5 bone compaction drill with increased length, you continue on with drilling. And with the raised membrane, you can place the implant, or if you need a bone graft, you can additionally add more bone grafts before placing the implant. In this protocol, we need to remember that this is soft bone. When we come across sinus bone cases, if in the case of normal bone, you do not use lance drill, but you use cast drill. I would use 1 cast drill, and you would remove certain amount of bone, and after that you would use bone compaction drill. But if you just over rely on bone compaction drill, in this case, the drilling speed will be very slow, and there's concern about bone heating, so you need to evaluate the bone quality first before using this.
bone compaction drill. It has similar concept with Densa-Berg. The difference is that a Densa-Berg perhaps removes bone when it rotates clockwise direction, but the bone compaction drill uses only clockwise rotation, and we can prevent a sinus rupture. The RPM you use is that the bone compaction drill recommends a 400 RPM, whereas Densa-Berg recommends a 1200 RPM. The RPM is not defined, so you need to choose the right RPM depending on the bone quality. And after you penetrate the sinus, when you do not use the irrigation. Also, it is cheaper. The bone compaction drill has bone compaction concept, preserves the bone chip, and if you evaluate the bone quality wrong, then that you may not get the desired results. You can get the primary stability, but you can use it for sinus elevation as well. The drills, one cast and bone one cast. The reason I prefer bone compaction is that if you use 6mm drill with residual bone height of 6mm, the casting one cast remove bone, it does not go up, but bone compaction, because of bone chips, the membrane is automatically lifted. So you can get good results with one cast, but you can get the more safer results with bone compaction drills. That is why I use bone compaction drills for these cases. But you need to remember you should not use it on hard bones. When you use it for bone compaction purposes, allogenic bone grafting is recommended. If you do bone graft within the sinus, you can use all bone grafts. Also, they should not be used for ridge split or ridge expansion. So I do not really use it for the lower. For ridge split or ridge expansion, Esthetic kit is much better fit. This is recommended by the company, but it should be changed after 50 uses. So let's look at a clinical case. So I do 100% guided surgery. So guide compaction drill is not for guided surgery, it's for analog surgery. So this was not for guided surgery. This is underway. My hope is that the guided kit for one, I hope such kit comes out. And so in number 25 and 26, there was a lesion, so extractions were done, and for guided surgery, CT was taken. And the implant position were determined in the implant studio and looked at how much sinus penetration and how much the implant should go in was determined. Guide was fabricated. Punch, initial drilling was done with OneGuide kit, and the rest was used with OneGuide. One bone compaction drill was used. The length was just 8.5. So I used bone compaction drill as well. Autogenous bone was used here, and right after implant placement. As shown, I always use guide, and flapless surgeries are done, and 5mm healing abutments were connected. This is panoramic image. After 2 months, ISQ values were over 70, 85, and 86. Scans were done, and 1 fit abutment was fabricated, and abutment level impression was taken, and the final prosthesis was delivered. ER type full zirconia prosthesis was fabricated. As shown, the margin is slightly visible. This is the CT result. So I used at the end of July using bone compaction drill, so it was not long since I've started to use it. On CT, the exact effects are not visible, but good results were achieved. So this is the second case, and this is number 14. And the bone quality was not good because extraction was done recently, and there was slope. This was how implant placement was designed, and it needed additional 2 to 3 millimeters of bone graft. Guide was used, and bone compaction drill. Before using this, OneGuide drill was used to find the path. Bone compaction drill was utilized to approach sinus floor to lift the sinus membrane. The amount that needed lift was not significant. The amount of bone chip was not significant, so I used a bone graft material. You'll be able to use it in the booth. This is a alloplastic bone. This is a low crystalline apatite, and this is resorbable like autogenous bone graft. So this does not have a long-term clinical results, but for me, it showed good results. Implant was placed. The KS implant, the soy surface was used. It was flapless surgery. After 9 months, ISQ value was over 85. Scanning was done, and CAD/CAM abutment was fabricated. Abutment level impression was taken, and the ER type prosthesis was delivered. This is the third case. Bone compaction was used. This was used for bone compaction rather than sinus surgery. You can see bone quality was not good here. The bone amount was sufficient. There are many ways to get primary stability. In this case, a bone compaction drill was used. Bone compaction drill for guide was used. Bone compaction drill was used at 10 millimeter and 11.5 was used sequentially. The implant was 10 millimeter, but as mentioned earlier, because we need to place the implant deep, 11.5 was used, and PS3B, a surface 5.0 by 10 millimeter implant was placed. As you can see, the implant may seem to be placed deeply. I tend to place implants more deeply. I think that is better. Flapless surgery was done. The patient was an insured patient, so stock abutment was connected. Transfer abutment was connected, and impression was taken. Metal occlusion. PFM prosthesis was delivered. This was in 2025, January. And from February, it is insured as well, so I have the milling machine inside. This is after 2 months. The final prosthesis was delivered because there was sufficient bone height. This was achieved. This is the final case. So autogenous bone was used only here. This is not complete, so I wondered whether or not to show you. This is number 27. 3-4 millimeter of bone graft was necessary here. In this case, when I use bone cast, I always use bone graft here. The residual bone height was not insignificant. Bone compaction drill for OneGuide was used to utilize autogenous bone. F5.0 was used. You can see that the top part is autogenous bone. This is pure autogenous bone without additional bone graft. The implant was as 5.0 when I used the drill. I increased the diameter of the implant to 5.5, and after 2 months, ISQ value did not go up sufficiently, so it's about 73, so we're waiting a little bit further. So 76 implants were replaced using bone compaction drill from last July up to this point, and there was one failure, and in many cases it was successful, and 36 cases have been complete. Bone compaction drill, bone compaction kit. So I think it can be utilized for sinus surgeries. My suggestion is that you need to do guided surgery. And yes, that can cost more time and effort, but you can do guided surgery as well as flapless surgery. And I suggest you to utilize bone compaction kit and crystal sinus lifts. As for the implant surfaces, I think if you use Osstem, you need to use Essay and Soy. I recommend you to use the latest implants. So even in upper posterior areas with poor condition, you can get good results. Thank you for listening. Thank you for the wonderful lecture. Thank you, Dr. Kim. Please give him a warm round of applause. Now for Q&A, Professor Kim, would you please come up to the stage? You can come up. Thank you for the wonderful lectures. We will now have Q&A session. So we will receive questions from the floor. Professor Huang, please give him the mic. And there are many questions online as well. So, Professor Kim, thank you. For retention, what kind of protocols do you have? For retention, you currently use fixed appliance. What kind of protocols do you have? So the biggest problem is Wyatt syndrome. And there are systematic reviews. If you look at the last case, it's unsure. Although wire was added or whether, I'm unsure. In the case of patients with mobility, so there was splint effect. Wire failure, dislodgement occurred more frequently when there was mobility. And in perio patients, there's instability, so retention can fail. In the case of younger patients, etching needed to be done differently. And choosing resin. Bonding for retention. So there can be issues with retention failures. So a lot of doctors, I'm sure a lot of you are doing it. I put in double safety measures. I apply fixed appliance and I use clear appliance for retention so that the patient has backup. And this is my tip. As shown, I do pediotomy. If you do pediotomy, at the very last stage, periodontal ligament is cut. And relapse occurs because the strain and stress and the ligament continues on. In order to offset that, ligamentomy is done. It is cut and it is realigned. So recurrence because of that reason can be prevented ahead. I have many protocols. Before etching, sandblasting is done. If you remove the fixed retainer in the middle, so the patient has spacing, so I asked the question. Another question I have is that in order to avoid confusion, doctors, you say that orthodontists also use a light force. If there's no anchor in the posterior, I use orthodontic mini screws to treat the patient. So I wanted to avoid any confusion. So I'm sure you're in university hospital and you get good results with interdisciplinary approaches, but you seem to do it all by yourself. Yes, when we treat patients, minor tooth movements are included in the scope. So let's look at one online question. A lot of questions have been raised on Professor Kim's lecture. Let's live happily. 세종 top. So there were many questions. So what is the contraindication for perio patients? So maybe mobility can worsen, and at times it may have led to extractions. Were there such cases? In a lot of cases, I work closely with the orthodontic division, and I need to take accountability. So at times, I need to take up such burden. On the apical side, the patient came back. So when I send my patient to orthodontic division, it's not really easy. We need to explain thoroughly. We need to tell the patient that the tooth may not be able to withstand the treatment, and at times there may be need for implanted treatment, and we need to have a backup plan. In most cases, when you do treatment, in relation to implant treatment, as mentioned earlier, always secondary TFO is caused. So it can worsen the situation. The purpose of the treatment, you need to tell the patient ahead. It's not that orthodontic treatment at perio division. So atraumatic occlusion is the purpose. We need to address the inflammation, and we need to treat traumatic occlusion into atraumatic occlusion. What is most important is if inflammation is uncontrollable, we need to control the inflammation continuously. No matter how you emphasize oral hygiene, whenever the patient comes in, at times it is uncontrollable. We need to be aware of that and be prepared for that situation. This is another advantage of digital dentistry. If you look at the digital images, you can accurately see where premature contacts are made, and you can also see where TFO-related inflammation can be assessed, and by moving the tooth, we can adjust it. we need to control inflammation, and we need to be able to understand TFO, and we need to be aware of ways to address it. So the cause of perio disease, for patients with bad oral hygiene, we need to be very cautious. So patients with severe perio disease, oral hygiene is very difficult to maintain. The different tools for perio treatment have improved, so we need to be fully aware of these. So, be it removable or fixed, the person already has difficulty maintaining oral hygiene, so we may need to be more cautious. I have another question. Clear Alliance. When you make order of it, if there's a perio disease, do we need to make the movement slower, or do we just follow the conventional steps? You have to tell the patient. There are like 10 stages, as mentioned earlier. At times there can be root resorption, and alveolar bone loss can worsen. And you can stop such treatment. We can take a rest for a bit and then proceed. We need to have some flexibility. What is most important is that we're treating TFO. CT, you need to understand what the direction, the crown shape and overall alignment. It might not be optimal, but our purpose is not towards the crown. Our purpose lies with the periodontal tissue. On the X-ray, we need to make decisions so that periodontal tissues are regenerated. We need to understand in which direction the teeth need to move. CT and different modalities may be needed. So you need to do you do conventional treatment for TFO? As you know, premature contacts are removed, and then you fixate the tooth with mobility with wire or resin. So personally, I disagree. The teeth with TFO, it has mobility. At times it rotates. At times there's vertical movement. Even if you use articulating paper, it is not registered. Even if you grind it using high-speed burr with mobility, you cannot remove it accurately. So if you grind it, it becomes like an animal's teeth. Removing teeth itself is invasive, it's inaccurate. And you can do wire splint. On the buccal side, the palatal side, there's seesaw movement. Accurate splint is very difficult because it's tied. You do not get a sense whether mobility is decreasing. After 3 months, you may wonder if things have improved. If you remove the resin, in the process, trauma is applied. And if it continues to have mobility, then it does not have good prognosis. Perio patient, it's not just one tooth, it's multiple teeth. So if you use articulating paper that does not work properly, and if you continue to grind off teeth, I don't think it's appropriate. If you use clear aligner, even if you do splinting, it is held from different directions. I tell my patient you can chew. I understand. Thank you. Because of time constraint, we will end this question and we will move on to Professor Dr. Kim. TS, at times it does not go in fully. I think this problem maybe is related to bone quality. This is bone compaction drill has 2 times under drilling characteristic. Personally, I wish there was a F5.5 option. So I place F4.5 after drilling bone compaction drill 5.0. You can also utilize OneGuide drill or OneCast drill, 4.1 diameter drill. In my case, I would use KS implant. If you do go one step smaller diameter in implant, you can use KS implant rather than increasing the drill size. You can reduce the size of the implant. It can be an option. Thank you. That ends the Q&A session of the first session. TS and Let's Live Happily will be the winners of best questions. Congratulations. Thank you, speakers, for being with us today. Let us end the first session. Thank you, Professor Shim, for being the chair of this session. So we will announce the winners of coffee coupons. 300 people will earn the coffee coupons. Congratulations, everybody. You'll be able to see the coffee coupons via text message, and please refer to notification on dental site. Osstem Meeting 2025 Seoul looks into the satisfaction surveys of the lectures given. All people participating, offline participants will receive texts. Click on the link and participate in a short survey. 200 participants will be selected through a raffle to receive chicken gift voucher. Don't miss the chance. Now we will have a brief break. Delicious refreshments and exhibition booths are available near the right side of the entrance of main auditorium. On the first and second floors, you'll find displays of outstanding academic and clinical posters. Please take some time to explore these areas. We'll return shortly.
Have you ever experienced any difficulties because of implant fracture, screw loosening, or dislocation of abutment? The brand new KS system is designed to avoid potential issues for implant placement. With 1 to 2 paper drilling sequence, now it is ready to place implants. The KS comes with a abutment holding system, which is located in the lower part. When the implant is connected to the abutment, it holds these 2 parts firmly without using a screw. At the moment of loading prosthesis, the KS system prevents dislocation of abutment, which may cause by gingival elasticity. Also, it is more convenient for clinicians because it does not require to see X-ray after loading. For conventional abutments, clinicians are required to select between mini platform and regular platform. However, KS abutment is compatible with all different diameter of implant, so the selection of prosthesis becomes a lot more easier for clinicians. The abutment screw of KS system is designed slimmer and the space is being used to reinforce the inner wall of the implant body. The KS system is aimed to reinforce abutments by thickening the walls. An implant wall as well. In addition, the depth of connection between implant and abutment is increased. As a result, structure of the KS system disperses masticatory pressure effectively. By the reinforced structure, the external force which may affect on the screw stays minimum and eventually minimizes the screw loosening. As of the diameter of 4.0 implant, the KS system secures the degree of strength at 4.5 with the increased depth of connection, reinforced walls of abutment, and thickened implant body. Find your key solution. Did you know pre-irrigation on implant may improve clinical prognosis? Osstem Implant provides guidelines for how to pre-irrigate an implant before you placing it. Before placement, irrigate the implant with saline for 5 seconds to avoid intraoral bacterial infections. Irrigating the implant with saline covers the surface with water. This temporal water film covers the surface of implant. The bacterial attachment is decreased because the oral bacteria contacts the barrier and diluted by water. According to the research, the degree of bacteria attachment is decreased by 28% when the implant is pre-irrigated compared to not pre-irrigated one. It is applicable to not only SA implant but also CA and BA implant. Pre-irrigating an implant may reduce the attachment of oral bacteria. This procedure may be helpful to avoid bacterial infections. Unlike other implants, the soy implant is in wet condition. The surface of soy implant is already coated with the substance, so please use it as is. Although the amount of coated substance on the surface of implant may be reduced through pre-irrigation, it does not affect on the stability of implant. By pre-irrigating an implant before placement, the risk of oral bacteria infections may be reduced. It does not affect on the stability of implant. Increase the success rate of implantation. Introducing OneGuide for sophisticated surgery, wide range of clinical indications, and excellent convenience. OneGuide is convenient to use. With an ultra-simple drilling technique, the implant can be placed at the plant site in only 3 drillings for shortened surgery time. OneGuide also offers high precision. The site, direction, and depth of implant can be precisely planned using digital method and used to manufacture a OneGuide template. This allows the implant to be placed as planned. OneGuide template holds the drill to help maintain a precise path even during high-speed drilling. The stopper is in contact with the top of OneGuide to enable precise control of drilling depth. OneGuide is particularly useful for surgery in the posterior region. In addition to the basic closed type hole, open type hole can be selected for designing. This function allows a drill entry through side and posterior teeth with insufficient vertical space. Open type hole helps to secure additional vertical space. OneGuide can be used for various clinical purposes. OneGuide kit for cases of single to fully edentulous. OneCast kit for maxillary sinus lift surgery. 1MS kit for the anterior region with narrow bone width. 1485 kit for short implants in mandible molar. These 4 dedicated kits are available for a wide range of clinical cases. Improve the convenience of digital implant surgery with OneGuide. It is simple and precise. Introducing the OneGuide bone anchor and implant anchor, which are used to fix implant guide. The OneGuide bone anchor can be used in cases where it is difficult to anchor a template, such as completely edentulous cases or patients with insufficient remaining teeth. You can also place it vertically in the bone and anchor the template at the position you have planned. The OneGuide implant anchor can be fastened to an implant already placed in the patient's mouth, which helps anchor the template much more easily. If you need to prevent the OneGuide from shaking and secure it in position, try using the OneGuide bone anchor and implant anchor. Introducing the OneCast kit, the digital sinus surgery kit. If you use the OneCast kit, you can digitally pre-plan the exact implant position and drill length required for the sinus surgery. Place the OneGuide template first. Then, use the drills with the rounded apex together with the stopper in order to perform safe drilling. You can also perform hydraulic lifting and bone grafting while the template is still in the mouth. Try the OneCast kit for safe and precise sinus surgery. Introducing the Trios 4, an intraoral scanner which scans and digitally replicates the oral cavity in 3 dimensions. The Trios 4 is extremely precise and offers fast scanning. It automatically eliminates unnecessary areas such as lips and cheeks during the scanning using the AI scanning function. Even the novice users can scan quick and easy. The Trios 4 is an integrated wired and wireless scanner. It is easily used wirelessly at large dental clinics. If the battery runs out, clinicians can continue using the Trios 4 by plugging in its power cable. The Trios 4 helps diagnose dental caries with its fluorescent scanning function. Also, the clinicians can track changes with dental caries over time. The Trios 4 can record patients' occlusal movement. The patient-specific motion function allows clinicians to record occlusion according to the movement of the patient's temporomandibular joint. Experience the Trios 4. It can be used in a variety of treatments. Great unit chairs designed for dental treatment must be convenient for the clinicians to use, feel comfortable for the patient during treatment, and they should also be easy to clean and maintain. I would like to introduce K5 as both a stylish and convenient unit chair. In case the backrest tilts downwards, the leg rest goes up. The tilting function prevents the patients from slipping down. It is convenient for the clinicians to carry out treatments and provide comfort for the patients to receive treatments. The K5 also has a wireless foot controller designed to offer an even more convenient treatment experience for the clinicians. Handpiece RPM can be easily adjusted by turning the foot pedal left and right, making treatment. The sterile water supply device suppresses formation of bacteria and biofilm in the water line of the unit chair. Always using clean water during treatment makes it much easier to reduce the risk of infections. Let's go over K5's key features again. The patient does not slip downwards thanks to the tilting function. When the backrest tilts downwards, the leg rest goes up. Second, the wireless foot controller makes treatment much more convenient for the clinician. Third, DWCS suppresses bacteria in water line to supply only clean water during treatment. Try the K5, a unit chair designed to add both convenience for the dentist and comfort for the patient. Introducing the upgraded T2 Plus with superior high-resolution imaging, ultra-high-speed scanning, and ultra-low radiation dose feature. The T2 Plus has a 0.05 mm voxel size, which results in superior high-resolution images. This enables a more accurate diagnosis compared to the T2. With a T2 Plus, patient waiting times can be reduced thanks to a faster scanning speeds compared to the T2. Images are acquired in just 30 seconds. T2 Plus low radiation mode allows for safer scanning with only 22% of the radiation dosage compared to that of the T2. The low radiation mode allows scans for children and pregnant women without any concerns. The T2 Plus offers various field of view sizes for facial imaging, implants, TMJ, endodontic procedures, and more. The T2 Plus allows for customized scanning based on the treatment. The T2 Plus includes convenient and easy-to-use 1-2 software, 1-3, and VSEP. Through consultation, treatment and implant planning will help increase patient acceptance rates. T2 Plus is available in 3 colors: white, blue, and red. You can choose the color that best matches the ambience of your clinic. Introducing the upgraded T2 Plus with clearer images, shorter scanning times, and lower radiation dose. Selecting the right bone material by comparing it to the patient's existing bone quality and conditions is crucial when expecting the satisfactory result from the GBR. Defects may occur on surgical sites such as the anterior, maxillary sinus, and ridge, which will require bone graft materials that facilitate the process of forming new bone osteogenesis while maintaining the bone volume. With that said, here is the Osstem Implant's xeograft EOS with phenomenal volume maintenance and osteogenesis. For bone graft materials, it is important to have a faster remodeling feature. Similar to the human bone, EOS particles have a cancellous pore structure. The structural property of EOS, when fully saturated with blood, significantly contributes to the process of new bone formation. The success of bone graft material must be verified with various clinic cases. EOS is designed to graft bone in a socket after the tooth extraction, and the treatment of peri-implant defects with guided bone regeneration. EOS can be applied to the sinus lift to place the implant in a maxillary sinus, and to augmenting and reconstruct of the alveolar bone. It can be used to treat and prevent various bone defects. A bone graft material must be easy to use in a variety of surgical situations. EOS collagen plug contains 10% of bovine type 1 collagen. It is specifically designed for post-extraction socket augmentation to maintain the volume and allows for better aesthetic and implant placement. The surgical can cut and reshape the plug to better fit the defected site. The EOS pen is a bone graft material delivered in a syringe-type container that allows the surgeon to hydrate the material with just one hand. And the syringe's inner diameter is available in two specifications, 5.4 and 3.5. This allows the surgeon to select a better suited syringe for each case. In summary, EOS forms new bone rapidly, which can be applied to any surgical site due to its similarity to the human bone. EOS is a perfect solution for both the surgeon and the patient. Try now! For successful implant surgery, it is important to use a membrane that facilitates creating new bone. Introducing Osstem. Osstem is a collagen membrane that offers outstanding shielding performance and nutrient permeability. These functions contribute to new bone formation. Osstem has a porous structure with cavities smaller than epithelial cells. It serves as a barrier to block epithelial tissue growth while new bone is formed. Therefore, it provides optimal space for the osteogenesis. Osstem also allows nutrients to pass through and facilitates the formation of new bone. Osstem comes in two types, hard and soft, as well as 4 different sizes. Thanks to its dual-sided use for all sizes, Osstem can be easily manipulated depending on the surgical sites. Try our Osstem that facilitates the formation of new bone and successful GBR.
오스템 미팅 2025 서울 이번 순서는 오스템 미팅의
Now,
하이라이트죠. 라이브 서저리가
we will have live surgery.
오늘 라이브 서저리는 오전과
Live surgery will be held in the morning and the afternoon. Let me introduce the chair for the first live surgery session, Dr. Myungjin Kim from Angle Dental Clinic. Dr. Myungjin Kim is former professor and director at SNU of Dentistry and Dental Hospital, president of Korea Academy of Dental Implantology, chairperson of the Korea Association of Oral and Maxillofacial Surgeons. He is currently director of Angle Dental Clinic. Greetings, I am Dr. Kim Myungjin. First of all, I am honored to be here, and I would like to congratulate the successful hosting of Osstem 2025. And I am honored to be the chair of live surgery session, which is the highlight of the meeting. This live surgery is very interesting.
So, from Acro Dental Clinic, Dr. O is diligently doing a lot of studies, and he's very academic. How to combine non-submerged GBR with the CTG using OneGuide system to improve aesthetic cervical line in mandible anterior region is the theme of this session. First, Dr. O is going to describe the case for this live surgery, and he's going to talk about the treatment plan as well. Please go ahead.
Hello, I'm Dr. Sang-yeol from Macro Dental Clinic. I would like to express my sincere gratitude to Chairman Jayeyoung of Osstem, Professor Jo In-ho, and all the staff involved, and my respected Professor Myung-Kyun Kim, who kindly accepted the role of the chair. This case involves 25-year-old female patient who underwent orthodontic treatment 10 years ago to secure space for congenitally missing teeth in the mandibular lateral incisal regions, tooth number 32 and 42, based on the preoperative intraoral condition and CBCT analysis. The mesiodistal width between adjacent central incisors is too narrow. Therefore, to recreate prosthesis harmonious with the adjacent central incisors, if a 3.5 millimeter diameter mini implant were to be placed, it would be too wide to replicate the root form of the adjacent teeth. Thus, a 3.0 millimeter diameter one-body mini implant with a cervical line compatible with the adjacent teeth must be placed to achieve an aesthetic prosthesis in harmony with the natural teeth. In this patient's case, a 3.0 millimeter diameter one-body implant with an appropriate cervical line was planned to replicate the mesiodistal width of the adjacent teeth. To meet the requirement of a narrow buccolingual width, a 2.5 millimeter diameter one-body mini implant was selected. Since the vertical bone height was not insufficient, a 2.5 millimeter gingival cuff height was chosen. However, upon placement at the desired position, buccal bone defect was observed after a horizontal bone augmentation, since a one-body implant inherently undergoes transmucosal healing. It requires a non-submerged GPR approach. When DBBM, which does not facilitate rapid bone substitution, was used, long-term stability has been consistently observed in many patients. Interestingly, non-submerged GPR offers advantages over submerged GPR as it avoids the need to stretch and press the flap, thus maintaining buccal space and reducing deviations in the shallow vestibule and mucogingival junction, ultimately achieving more aesthetic and functional outcome. Over time, the stability of areas treated with non-submerged GPR remained well maintained. In another patient, non-submerged GPR using a one-body mini implant demonstrated similar stable outcomes. Since one-body implants cannot accommodate customized abutments, the cuff margin which will determine the crown margin must be placed with absolute precision. In cases with insufficient buccal bone, accurate positioning is critical, especially when there is deficiency in buccal bone. The following approach prevents displacement by dense lingual cortical bone by reproducing the most aesthetic cervical line. It is advantageous to use guide stand for implant placement to ensure precise positioning in the buccolingual, apical-coronal, and mesiodistal position. The following approach prevents displacement by the dense lingual cortical bone. One major concern in this patient was gingival recession of the adjacent teeth. If a standard implant crown shape were formed, non-aesthetic cervical line would result at the thin gingival phenotype, and insufficient keratinized gingiva would compromise long-term stability. The critical aspect of this surgery was to perform a connective tissue graft to cover recessed area, to conduct a coronally advanced flap to align the implant cervical line with that of the adjacent teeth for aesthetic improvement, and modify the gingival phenotype by thickening the thin phenotype with the connective tissue graft to ensure long-term stability. After root coverage using connective tissue graft, a coronally positioned flap was performed, improving the cervical line. In another case, not only was the aesthetic cervical line enhanced, but a thicker phenotype was ensured, ensuring long-term stability. So the final treatment plan is to place a 2.5 by 11.5 one-body implant using OneGuide stand.
Execute non-submerged GBR using DBBM and collagen membrane. Provide immediate provisional ground to complete the primary hard tissue augmentation. Harvesting connective tissue from the palate for root coverage to perform coronally advanced flap for the cervical line improvement. The flap design and technique, how to place one body mini implant in ideal position, and how to perform non-submerged GBR connective tissue harvesting method and root coverage technique, and coronally position the flap. These should be understood, and that is the goal of the life surgery. Thank you.
Good morning. As was introduced, I am Dr. Oh Sang-yun for this live surgery. So I'm wearing Google, and it will interfere with the speed of the surgery, but I will do my best to meet the deadline of this session. And I would like to thank Professor Kim for chairing this session. Please give him a big round of applause before he starts surgery. As you can see, incision is to be made. Partial thickness is used for the areas for root coverage, but here is too thin. If we use the partial thickness, perforation can occur and tearing can occur during closure. So I'm going to make a full thickness flaps, and only the papilla area that will have a partial thickness. And the papilla can be cut here. In that case, the adjustment at the end can be a little bit difficult. So I'm going to use a partial thickness for the papilla, and at the time of closure, that will be cut out. So here, root coverage will be made at the missing areas and will receive implant placement. Partial thickness flap raising for the papilla only. Here, full thickness circular incision is made, and here full thickness incision is made. So this is a very thin phenotype. When we form a flap tearing can occur, so we need to be very careful when we do the incision, partial thickness. So for better flap management, we also use the full thickness. Now I'm going to form the flap. If a periosteum is not cut, when a flap is made, the flap can be damaged. The cervical line should be captured very carefully in this patient, and we need to check that carefully. So you may find that some areas where incision is not completely made. So we can use a mesh to cut it in order to avoid the damage. Periosteum cutting should not be missed. Otherwise, the flap management will become very hard later. At the mucogingival function, flap perforation can be made. So in this area, we need to make the flap in full thickness. This site also, rather than making the flap quickly, you need to make sure the incision is made properly. For coronally positioned flap, for the root coverage areas, from now on, over the mucogingival function junction, and we need to aim for partial thickness flap. Would you close the mouth just slightly? For non-submerged GBR, we need to make full thickness flap. And here in the middle, for root coverage area, the flap is in partial thickness. The incision can be made through periosteum rather than full thickness ostium incision. I use partial thickness here, and for GBR here, for bone regeneration later, soft tissue should not be present here. So a slight alveoloplasty is made. Dr. O, at the site of number 43, a vertical incision is made. In quadrant 3 at number 34. Yeah, that's for root coverage. Yes, that was for root coverage. And the wide remote at the proximal line angle, I prefer to make the incision. change it to the control angle. So I need to do GBR and the lingual side. So bone graft site. So you are scratching using a diamond burr. I believe that's a good approach. So soft tissue would interfere with the bone regeneration, and that can facilitate the blood supply. So I believe that's a very good technique that you use. So congenital missing area has been present for a long time. As I said in the video, placing implants by hand without using a guide is almost impossible. So I'm using a guide. Even with a guide in a very narrow bone, slipping can occur. So you need to firmly hold the guide, and you need to consider the possibility of slippage of the guide. First, I'm going to flatten the bone. So, bone flattening. So the technique that you are using is the flattening of the ridge to prevent the slippage of the device. Especially at site number 42. If it is oblique, before twist drill, I use the path drill. For the twist drill. Even under a guide, you need to check whether the positions are correct. Yes, it looks okay. And the problem is that mediodistal bone can interfere. And we need to estimate that. Here, mediodistal bone area. The gingival cuff can be cut. So we need to prevent that. Guide, change it to contra angle. The issue is the narrow ridge. So cortical bone on the lingual side. We need to determine the amount of prep. If the prep amount is too small, the device can be cut. So I check the hardness of the bone during drilling to determine the amount of preparation. Now it's very hard. So I'm planning to use 11.5 millimeters. If the drill hole is just right for that implant, there's a chance that the implant may not be be inserted, so I use a little bit bigger drill. The bone flattening on the alveolar ridge was made. So 13 millimeter drilling is a good idea instead of 11.5. 2.8 by 8.5 is used here. It's a little bit loose. So without drilling 11.5, let me place the implant. This one, MS, this is MS implant, which is the Osstem implant is very proud of. The entry point is correctly inserted. So at low speed, what's RPM? 25 RPM, 25. So we need to stop at the first mark. If you go deeper, the driver can be cut and cannot be retrieved. So I can feel it is a cut in the cortical, so I need to make a decision whether I need to do preparation a little bit more. So this is tricky. So I don't know whether not preparing the linguocyte is a good idea. So now it is cut in the cortical bone. And if something goes wrong, spinning, it will spin. So you need to apply torque carefully at your fingertips. So I'm trying to show this to camera. So at that angle, I cannot accurately take note of the mark. And the arrow should match, should be aligned with the sleeve. And I need to rotate one more circle, and I cannot really see the mark at this angle. So it looks like it went a little bit deeper, but it looks okay. So it went a little bit deeper. On the right-hand side, if the right-hand side is tricky, we need to penetrate into the cortical bone completely, and it's not easy to determine the amount of preparation. So 1.5, full drilling is to be made. 13 millimeter drill is too long, so it will be about 11.5 millimeters. And then 13 millimeters will be inserted a little bit less than usual. So this is a very important part. So I rely on at my fingertips, and number 32 was too hard, so I applied the force a little bit more. So the reach is too narrow. I cannot use the 3.5 here. So if anchorage is not obtained, I will change it to 13 millimeters. And the reach is too narrow here. So it is cut in the cortical bone. So it is strongly cut in the bone, and it cannot be retrieved easily. So it is a little bit lingually inclined, and let me retrieve it a little bit to adjust the angle. Drilling, and I'm gonna drill a little bit more. So I pulled it out in the reverse direction, and I go in again. Actually, it is cut in the bone. It is cut in the lingual cortical bone, and I believe I need to do drilling a little bit more. If I push more into the cortical, lingual cortical bone, spinning can occur. A new one, please. So I'm going to drill 13 millimeters in full length. I'm removing the guide. (13 millimeters). Now it is pushed outward a little bit, so I'm going to trim the lingual side slightly. Please raise your head a little bit. And put on the guide. 2.3, so that it doesn't slip. So the same size. I'm gonna perform the placement. Please hold it. The fixation seems to be a little bit weak, so let me change it to 13 millimeters. If it doesn't work, I'm going to change it to 3.0. So lingual-cortical bone. So the fixation is going to be achieved at the lingual-cortical bone. I believe I've gained some stability. And I'm going to rotate just one more rotation. So fortunately, stability is achieved from the cortical bone. High speed. So to fit the temporaries, this part needs to be cut. And here as well. The site for root coverage, I'm going to do this slightly as well. And let me fit the temporaries. Dr. O, you are using the high speed and a lot of water is coming out. Is it saline water? Yes, you may think so. It's a purified water, so it fits well here. And this side, it doesn't go in very well, and I believe it is cut in the metal. Now they fit well, and here I believe it needs to be rotated to the right just slightly. Just a little bit. Number 32. Let me try it again. So they fit pretty well. For root coverage, curate. Root planing needs to be performed stringently before surgery. Yes, and it is already done, so not much is required here. Connective tissue graft is to be performed. So a little bit big size is required. So adjust the chair, please. A little bit backward. And raise the chair a little bit. Please turn off the irrigation. About 25 millimeters would be needed. Say ah. Okay. In this patient, the palate is not very thick, so I need to be careful in harvesting this. I like the trapdoor technique and the vertical incision. Incisions are made, and that there's a limitation in single incision in the front side on the palate. So a flap is formed. This area should be harvested in some thickness so that it can be inserted between the teeth. So do you want to cover the implant area as well? No, if soft tissue is pressing down on the implant side, it's not good. So I separate the areas, the implant area versus no implant area. The root coverage site doesn't require very high or thick flap. Now it's going to be taken out. Epithelial band is included to make it thick. That's what I'm trying to do here. The thickness would be the full thickness from the posterior palate. Great palatal artery, where nerve is present. Do you cut it? Yes, I do cutting here. Cutting in this area. The artery coming from distal of number 3. So distal to the second molar, there is a great palatal artery. So periosteal elevator can be used, but it can delay healing a little bit. So I'm trying to take it out using a mesh. Periosteum. Do you preserve the periosteum? In my case, I try to harvest the periosteum as much as possible, but now we don't need a very thick flap. And in the posterior area is very thin, so I'm going to take it out using a crystal elevator. Now it is thick enough. The length is more important than the thickness or the width. I made a stent. So suturing is not required, but to prevent bleeding, I'm going to suture it. Do you use bipolar? So after splitting, you just wait. The pressure will make it work. I'm wearing a lupe, and I cannot clearly see at the end of the thread suture. Suction, please. And we use a splint, so meticulous suturing is not required, just enough to stabilize the flap for secondary healing. Now connective tissue has been harvested, and I'm going to insert a splint. I'm going to take a photo. Connective tissue. Epithelial band part needs to be removed. And the fat is removed. Usually for Jukeli, a 4 millimeter height is enough for a root coverage. And we are going to dividing the frontal part and the rear part mass. Now the connective tissues will be fixed. Here and here. Root planing, the attachment. And it's fixated, 50, please. Now we are being delayed. And I ask your understanding for a little bit of delay. In my case, I prefer to use a horizontal mattress, and it is hard to do the stitching, and it takes a little bit of time. So to fix connective tissue, and your suture, the mattress suture looks good. Many people use interrupted sutures, but it is not as good as this one in terms of the fixation. In the chat, there are many questions coming in, many interesting questions. So, whether the water from the high-speed instrument is disinfected? It's an invasive surgery in implant clinic. Distilled water is connected for the high-speed instrument, and there's a comment that it would be better. And there are some questions regarding the indications. And as you are performing surgery right now, and the questions will be addressed later. So central incisor area. I need to take time to suture meticulously. It is hard to do localization. So you need to put it in place like this for the fixation. At number 3 site, in order to save time, I'm going to do it a little bit differently. And again, suction. GBR and connective tissue graft, you're performing it simultaneously depending on a case. Do you do it separately in 2 sessions? Yes. In terms of healing, it would be safer if you use different sessions for those. But today is special. That's why I'm doing it simultaneously. And for harmonious cervical line, the surgery is difficult to do them simultaneously, but for harmonious cervical line, doing it simultaneously can help. As you can see, what is important when it comes to the connective tissue is positioning it very accurately. My staff is doing the job very well. So to save time, I'm going to use this approach, and it is compressing it down. Cut it, please. Okay. I'm going to perform GBR first. In the chat, there is a question. So at the GBR site, whether you perforate the vertical bone, it is controversial. If you perform the perforation, it would be better, but it is bleeding pretty well, and looks like it has a very good healing potential. So only I work on the perio still. if you have a lot of bleeding from perforation, sometimes you lose more than you gain. So this is AOS. So I cut it like this. I make it like a sticky bone. So we can build it up like this. So periosteum is removed using a diamond burr. You made bleeding, so it doesn't require perforation. So hard tissue graft, actually, the bleeding will continue. So this is a little bit difficult because of the bleeding, and membrane is to be placed. So you're using the allogenic bone, DBBM, the proteinized bovine bone mineral. It doesn't have the bone substitution function, and it is beneficial to maintain the volume. And the width is about 6 millimeters. Pencil. So I'm going to work on 2 of these simultaneously. Tissue punch. I use this often. Tissue punch. This is Osstem hard from Osstem, a cross-linked one. Osstem. And there's a soft and hard ones. So I'm using the hard one. The disadvantage of the hard one is a little bit harder to manipulate, but I'm going to see whether it will work okay. I soak it in water. Fortunately, today, at number 42, the fixation was gained properly, fortunately. So it's not an easy area to get the fixation. And I believe I've been lucky today. Soak it in water. So it needs to be hydrated, and I don't really have enough time, so just go ahead. I believe you have many questions regarding non-submerged approach. For more than 10 years, I have followed up on patients where this procedure is used. If you choose bone properly, you won't encounter problems. So we can perform the procedure very fast. A lot of advantages associated with it. AOS, more AOS needs to be inserted here. More AOS, please. So surgery is finished. And the more bone is inserted at this site. What sort of suture do you use? Monofilament, papillon, 50 is used. For flap fixation, I use nylon. It's made in Korea. And I'm going to take a photo for record. How to maintain the coronally positioned flap, and that's something we need to focus on. First, this side is sutured. And then coronally positioned flap. I use a sling suture, and I'm going to use it here as well. For this live surgery, anesthesia is injected, and it was done some time ago, so it causes a lot of bleeding. You pulled it too much. At number 3, coronal portion flap is going to be sutured to use the sling suture. There are many other ways. Contact over suture. Cross suture, vertical or double cross suture can also be used, but worldwide, a sling suture is used the most. Now the papilla is overlapping a little bit. In this case, I cut it out. Scissors, please. So it's cut out. Suction. Here. Now the root coverage is achieved. Suture. Interproximal sling suture is convenient. So the temporary will be inserted at the end. So this is the right position, a little bit raised up. Please hold it. Be careful. Cut it off. Hold it in the distal side. The collagen membrane at the sites of 31 and 41, do you need don't you need to cover the sites with a collagen membrane? So you cover the GBR site with the membrane. And what about the connective tissue area? Covering it with the membrane can interfere with healing, so you need to distinguish those two sites in terms of the approach. Coronally positioned flap is completed, and on the left side, the same will be done. The GBR site healing is important, so this is sutured first. Suction. Please cut it off a little bit. Dr. O, please take time. Now we need to finish. So this is almost like a microsurgery, and it takes time. And Q&A should be omitted due to constraint of time. Take your time to finish it, because performing surgery is higher priority. During Q&A, if you have any questions, I believe you can ask some questions now. Oh, what do you think? So I believe I can finish within 5 minutes. So maybe we can take one question from the floor. If you have any questions, please raise your hand. Dr. Kim? Okay, you always ask questions, so I expect very good question. Dr. O, I watched it. I enjoyed your surgery. And my name is Kim Myung-nae, and I opened my clinic about 10 years ago. And I was with a university hospital before. You have very good technique. And Dr. Kim Myung-jin asked me to ask a question before. So the tissue glue, the AOS powder, yes, it was mixed with the cell line, and I cut them. So do you use a tissue glue, green plaster from the Green Cross? PRP, PRF are used. So you use PRF sometimes? It's a very significant procedure. And you don't use electrosurgery at all. So when the flap is pulled, and if you use a bovie releasing, so you don't use that. Why you're not using it? Without electro, the flap releasing, when the releasing is properly done, there'll be no problem. And there are many speakers who are surgeons, and many surgeons do not use electro for partial thickness. For the partial thickness, and you can control it properly without using it. But if you can use it, as you said, I believe it has benefits over not using it. So the suture technique for number 34. So you go distro and come out visually. Is it a special technique? It is sling suture, most commonly used for coronally positioned flap. So it doesn't slip and it doesn't tear. The incision area, when a suture is covering over it, it can apply some pressure on the site, but the sling suture does not apply pressure on it. When you place an implant at number 42, you use the new one later. It's a longer one. I use a 2.5 by 11.5. So for the engagement in the cortical bone. So you always use a new one when you pull out the implant that you placed. Right. In my case, for example, the surgery is very clean, but if you use a two-stage approach, GBR first and using OneGuide later, you can place an implant. That would be another approach. I believe your approach is better, but to be honest, there are many questions in the chat. To raise the cervical line a little bit, contact over suture is to be made. Thank you. So it's almost done. And Dr. Kim Yong-Dae, thank you for the good question. So you are performing surgery, and we will finish the Q&A now. And after surgery, you will take X-ray, and there'll be time to evaluate the result. And then we can entertain some individual questions. In the chat, there are so many questions, but if time allows, you can ask some questions. I can answer, not just focus on your surgery. And I already raised some of the questions in the chat, and I believe some of the answers have already been answered. Let's finish it here. Please take time to finish the case. So this concludes the live surgery. Thank you. Please give him a big round of applause. Thank you. So I would like to thank Dr. Oh and Chair Professor Kim Myung-jin for the wonderful job. Please give them a big round of applause. Now, this concludes the second session, and from now to 1 p.m. is lunch time. Enjoy your lunch, and at various places, please visit exhibition and the various experiences. And please stay with us until the end, and after lunch, we will have a coffee coupon event before session 3. So discussion is prepared in the afternoon. Please participate in the survey. So at the entrance door and at both sides of the stage, you can participate in the survey. And the result of the survey will be reflected in the discussion. Your participation is expected, appreciated.
See you in the afternoon session.
TS Multi-TI base enables digital implant restorations for Edentulous patients. Using the TI base with a multi-abutment and multi-angled abutment enables creating a single unit prosthesis even in an Edentulous case. Using a multi-scan body, the surgeon can select from a dedicated library to 2 digital scanning options, TI base, long or short. To ensure a proper fit and eliminate any possible errors, the prosthesis must be seated in the mouth before being cemented onto the TI base. Try our simple and accurate TS Multi-TI base. Introducing OneFit abutment, custom designed abutment by Osstem Implant. OneFit abutment has the basic titanium abutment as well as gold-color titanium-coated abutment for production of aesthetic zirconia and ceramic prosthesis. Manufacturing request is simple and convenient with 3 options of impression body, intraoral scan, and design file through an online order system. The product offers various design options for customization based on patient oral cavity and implant placement conditions. Try OneFit abutment, custom designed abutment by Osstem Implant. Introducing the 1485 kit, the implant surgery kit for mandibular posterior region. The 1485 kit is used for implant surgery in the mandibular posterior region with vertical bone resorption. The implant specification and position can be elaborated with digital planning. The surgeon can prevent damage to the inferior alveolar nerve even when the residual bone height is low, in case the surgeon places a OneGuide template and performs drilling with the 1485 kit's round design drills. Also, the 1485 kit helps you to place from 4mm to 8.5mm short implants at proper depth and avoid any damage on inferior alveolar nerve. Try the 1485 kit when you need to perform a surgery in a mandibular posterior region. Introducing the Scan Healing Abutment, which helps you to take implant impressions without removing the healing abutment. You can use the dedicated carrier to fasten the Scan Healing Abutment . TS Multi-TI base enables digital implant restorations for Edentulous patients. Using the TI base with the multi-abutment and multi-angled abutment enables creating a single unit prosthesis even in an Edentulous case. Using a multi-scan body, the surgeon can select from a dedicated library to 2 digital scanning options, TI base, long or short. To ensure a proper fit and eliminate any possible error, TS Multi-TI base enables digital implant restorations for Edentulous. Have you ever experienced any difficulties because of implant fracture, screw loosening, or dislocation of abutment? The brand new KS system is designed to avoid potential issues for implant placement. With 1 to 2 paper drilling sequence, now it is ready to place implants. The KS comes with abutment holding system, which is located in the lower part. When the implant is connected to the abutment, it holds these 2 parts firmly without using a screw. At the moment of loading prosthesis, the KS system prevents dislocation of abutment, which may cause by gingival elasticity. Also, it is more convenient for clinicians because it does not require to see X-ray after loading. For conventional abutments, clinicians are required to select between mini platform and regular platform. However, KS abutment is compatible with all different diameter of implant, so the selection of prosthesis becomes a lot more easier for clinicians. The abutment screw of KS system is designed slimmer and the space is being used to reinforce the inner wall of the implant body. The KS system is aimed to reinforce abutments by thickening the walls and implant wall as well. In addition, the depth of connection between implant and abutment is increased. As a result, structure of the KS system disperses masticatory pressure effectively. By the reinforced structure, the external force which may affect on the screw stays minimum and eventually minimizes the screw loosening. As of the diameter of 4.0 implant, the KS system secures the degree of strength at 4.5 with the increased depth of connection, reinforced walls of abutment, and thickened implant body. Find your key solution. Introducing the last kit, the lateral approach sinus kit that safely raises the sinus membrane without perforation. The patented drill designs, both dome and core drills feature rounded cutting edges that minimize direct contact with the membrane. In this way, lateral windows can be created safely. The dome drill in the last kit helps lift the sinus membrane safely while collecting autogenous bone particles between the cutting blades. By creating bone chips between the blades, the core drill's rounded cutting edge reduces the chances of direct contact with the membrane. The last kit's dome and core drills are specifically designed to create the lateral window safely. Last kit allows for more precise control over drill depth. The last kit features drill stoppers in 0.5 mm increments. 6 different lengths of drill stopper allows for more precise control over drill depth when creating a lateral window. All these last kit features contribute to safer sinus lifting surgery and reduce the chances of sinus membrane perforation. Let's go over the advantages of our last kit. It is specifically designed to help surgeons to create lateral windows safely with the patented drill design. 6 different lengths of drill stoppers with 0.5 mm increments allow for more precise control over drill depth. Try the last kit specifically designed for clinicians to perform a sinus lift safely in a short time. Introducing the CAS kit, the crystal approach sinus kit that safely lifts the sinus membrane with a hydraulic lift system. The CAS kit reduces the chance of membrane perforation. The patented CAS drill creates a conial bone lid that keeps the drill edge from direct contact with the membrane. CAS kit ensures safer drilling by preventing sinus membrane perforation. Using the drill stopper makes it easier to adjust the drill depth. The CAS kit features drill stoppers in 1 mm increments. It is possible to control the drilling depth precisely by using the stopper, which ensures safer drilling without the risk of perforating the sinus membrane. The hydraulic lifting technique of the maxillary sinus can facilitate the blood supply of the surgical site. The CAS kit's membrane lifter is using hydraulic pressure to elevate the maxillary sinus membrane higher and wider. Consequently, it facilitates blood supply, which encourages the formation of new bone and the healing process. Try the CAS kit that reduces the risk of membrane perforation to ensure safer surgery. Introducing the Esthetic kit for narrow alveolar ridge split. The Esthetic kit uses expansion drills able to expand the bone buccally and lingually, even in the case of severe alveolar bone resorption. Eliminates the use of a mallet. A safer and easier buccal plate expansion is achievable when minimizing the risk of buccal fracture. During the final stage of implant placement, the implant can secure a strong initial stability in the narrow ridge without tilting. The Esthetic kit allows regular size implants to be placed in narrow ridges with a low risk of buccal fracture. You can try it out. Introducing the 485 kit, the kit for placing short implants. The 485 kit has drills with round design apex, which minimizes damage to the inferior alveolar nerve when performing surgical drilling. The 485 kit allows you to place 4 to 8.5 mm short implants. Only 3 drilling steps are required when placing implants with the 485 kit. When placing short implants, try the 485 kit. MS Implant. Introducing the MS Implant, the one body type implant for narrow bone width areas such as the mandibular anterior region. There are three types of MS implant: narrow ridge, denture, and provisional. First, the narrow ridge is a one-body type implant suitable for areas with narrow bone width or narrow interdental spaces. Second, the MS denture is an implant designed for overdentures. Third, the MS provisional is used when immediate placement of the temporary prosthesis is necessary. Try the MS implant in the mandibular anterior region where the bone can be very narrow. Introducing Osstem Implant's HySil PLUS. HySil Light Plus is excellent at reproducing fine areas. HySil Light Plus can reproduce 20 micrometer lines without any tears or distortion. The stone model poured from a HySil Plus impression produces smooth surfaces and separates cleanly. Thus, the user can fabricate accurate and precise prosthetics. HySil Plus is highly hydrophilic. HySil Plus has a short intraoral setting time of 2 minutes and 30 seconds. HySil Plus offers a sufficient working time of 3 minutes and 50 seconds. HySil Plus has a high elastic recovery ratio of 96.5% or more. Experience HySil Plus for accurate and precise impression taking.
임플란트 유명한 게 좋을까?
뭐가 달라도 다르겠죠.
임플란트 세계적인 게 좋을까?
뭐가 달라도 다르겠죠.
치과 의사에게 사랑받는 게 좋을까?
뭐가 달라도 다르겠죠. 오스템 임플란트.
오스템 미팅 2025 서울 오후 세션에서 다시 인사드립니다.
Greetings. I hope you all enjoyed your lunch. Earlier, Dr. Oh Sang-yoon showed us fabulous live surgery, and we're going to look at the surgical results after the discussion. Let me share some exciting event announcements. First, there's an on-site raffle for our in-person attendees, and the raffle is going to be held after the session from Zespa the Clang massage chair, water pick oral irrigator, Osstem oral care gift set. The raffle will take place after the event concludes, so please stay with us until the end. Next, for our online participants. For members logged in and watching through dental website, 600 lucky participants will receive coffee coupons and dessert set coupons during the afternoon session. Be sure to check the prize entry pop-up that will appear on the dental website before the session starts. Additionally, for those who stay with us until the end of the online broadcast, we have prepared even more incredible prizes, including iPhone 16 Pro, Beauty's teeth whitening products, travel toothbrush kit. Stay tuned. There are a few important points you must check to participate in the online events. You must be logged into the dental website to join on all online events. If you haven't registered yet, please sign up in advance. For those watching on mobile devices, please keep your phone in portrait mode to participate in pop-up events. During the Q&A session following the lectures, we will select 10 participants, both online and on-site, who ask the best questions and present them with water pick handy oral irrigator. For online participants selected as best questioners, will contact you individually. You can now look at the second event pop-up on the dental website. Don't miss out on this opportunity. Check the pop-up and try your luck at winning coffee and dessert coupons. The winners will be announced after the third session, and the coupons will be sent via text message at the same time. Next, President Jayeyoung of Osstem Implant is going to provide a lecture. Please welcome him with a warm round of applause.
Thank you for coming amidst your busy treatment schedule. Even though it is weekend, thank you for joining us in this awesome meeting. And those who are watching online, I would like to express my deepest gratitude as well. Now the digital era is upon us, as I mentioned many times. Osstem is our company name. Osseous Technology and Digital System. It means that so DM is attached to the digital system and OSS at the end. So it became the name Osstem. At the beginning, when I founded the company, dentist and the digital system was the name. It was a software company. Dentist is me, and digital system was incorporated. And with the implant system, also technology and OSS and TM was attached to make the name Osstem. We have 800 researchers and the 400, almost 500 people are developing or planning software. Therefore, we are moving toward the software from hardware company. Today, I'm going to talk about digital dentistry. It is not launched yet, but we are working on it very diligently, so I'm going to introduce them. And the biological stuff is going to be mentioned as well. So when we were in school, the three dental top dental diseases, malocclusion, caries, and the perio diseases. And we have two major diseases, missing teeth and malocclusion. So in terms of incidence, there are many perio disease, but it is not as bad as missing teeth. So missing teeth should be resolved. That's our utmost task, and implants can play the role. We develop implants, and how we can successfully develop implant is our goal. And when bone is missing, creating bone substitutes was our focal point. In that respect, PA surface treatment, or PA, is used up to now on machined RBM, SLA surfaces have been used. Those were not developed by us, but we followed others. But the PA is patented by Osstem, and LCR, low crystalline apatite. It's a calcium phosphate is developed by Osstem. It has a low crystalline and resorbable, which is a bone substitute. Let me introduce it. PA surface. Originally, surface treatment is provided, and surface cleaned, and the treatment is provided. And over that, LCA, low crystalline apatite, is treated, and hydrophilic material is also added. So hydroxyl would be attached to the surface, making it hydrophilic. So this is how the surface is packaged. Technical problems. So that was a little bit of hitch. Hydrophilic. So when water drops, it spreads. I wanted to show the video, but it didn't work. SA surface, on the other hand, so after the product is manufactured is hydrophilic, but over time, hydroxyl would be lost. So hydrocarbons in the air would be attached to the implant. So the surface is turned into hydrophobic. So this one doesn't work either. So we drop water on the petal of lotus, and the circular forms remain, and as a surface it becomes hydrophobic, but still it has very good bone reaction response. As a surface has a hydrocarbon attached to the surface, but over time, after a short time, it becomes like this. On the other hand, the PA is highly hydrophilic. So some images, the whitish ones are more on PA surface. So videos don't work. Hydrophilic surface. So post-cleaning assay is hydrophilic over time. However, so it turns into hydrophobic. This was the image was taken just recently. So this is hydrophilic, blood-friendly SA versus PA. There's a big difference between those two. So this is magnified images. So there's a difference in the blood friendliness. So there's a difference how much blood is attached. So bone response is different if you look at the histological images. Also conductivity, SA and PA on the left and right. It is not clear here, but if you look at the bone only, SAPA has a big difference. So PIC, bone to implant contact, BA is higher, PA, bone area. Bone area is higher in PA. Removal torque has a bigger difference between those two. So on removal torque difference is bigger than PIC difference because at low magnification they look attached, but in the high magnification as a hydrophobic surface and PA hydrophilic surface, you can see more blood is attached to PA, and the fibrin formation is different between those two, and the blood vessels are made, and the bone look different between these two at high magnification. So rather than PIC removal torque has a bigger difference. In terms of removal torque, UV is also irradiated compared to UV. PA has more hydrophilic treatment, showing higher removal torque, as you may very well know. The SA primary stability over time is decreasing, and the secondary stability is increasing. So if you combine them together in terms of the total stability, you see the stability dip. On the other hand, BA has a very good primary stability. This is similar to SA, but the secondary stability is very different from SA. So if you combine those two in terms of the total stability, there's no stability dip in BA. So when bone quality is poor, implants were placed, and the failure rate was much lower with BA. Dr. Kim Ki-sung placed 1,005 implants, and the statistical analysis was performed, and only 2 failures were observed. So the percent of successful rate used to be used, but so we are managing the success rate in terms of how many out of over 1,000. So you can deliver prosthesis faster, and it is favorable in weak bone, and this is favorable for immediate placement in immediate loading. So those are the advantages of PA. So in summary, PA surface compared to SA has a faster bone formation and strong osseointegration. No stability dip, and the success rate is high, and fast prosthesis delivery, and placement in the weak bone is possible, and it is favorable for immediate placement. So this is BA is strongly recommended to those who believe SA is the best. LCR, this is low crystalline apatite resorbable. So this is a bone substitute. As you can see, the certificate, according to SEM images, there's a big difference in terms of the surface, in terms of the formation of the surface. This shows the blood friendliness, LCR versus BCP. When a drop of blood is put on them, there's a big difference. This is showing the LCR is soaked in blood, and the fibrins appear faster, and blood vessels go into the space between them, facilitating new bone formation. LCR is resorbable, so the LCRs are decreasing, substituted by bone, and the BCP is less blood friendly. So blood is attached less, and less fibrin is made, and the blood vessel distribution is less, leading to lower new bone formation. The new bone is indicated here. So BCP has less new bone than LCR. The pink indicates new bone, which is higher in LCR. At week 24, LCR has much more new bone formation, and bone is much stronger. This is an attachment of bacteria. BCP, on PCP, bacteria attach more, and on LCR, less. So it has better antibacterial property. Allograft has a similar form to LCR, so LCR is similar to allograft, and new bone formation capability. LCR has a similar level to allograft, and bone strength is similar. And there's not much difference between those two in terms of antibacteria. PCP versus allograft versus LCR. So in high magnification, they look very different. And LCR's surface is much different from PCP, but not much so compared to allograft. So LCR has much more new bone formation capability, bone strength. This LCR's capability is similar to allograft, much higher than PCP. Antimicrobial property, it is similar to allograft and much better than PCP. It is a synthetic bone which will replace allograft. So a very high bone formation capability and very strong bone, which can substitute the bone. We have conducted bone augmentation quite a lot, but our homework challenge lies in the vertical bone augmentation. So when we can achieve that, the bone can become young. Right after healing, after extraction, bone and the situation is like this. Over time, the alveolar bone goes down, reducing the keratinized gingiva, and the periosteum would be reduced as well. So if we use the old technique to recover the vertical bone, there are three problems. First, the periosteum is decreased, so we need to increase that. In a huge bone graft, we need to make incisions and reducing mucogingiva, and bone chips can come out. So there's a lack of periosteum as well as the keratinized tissue. So the bone graft would be moving, would be mobile, so that bone cannot be stabilized properly. We need to address these issues to make bone young. So we have a tissue max to address that. This is expanding the osteum, periosteum. So it is rather big, so it has been a little bit inconvenient, and Dr. Yong-Dae and others found some difficulties. So tissue max used to be 4 to 5 millimeters in diameter. Now it is reduced to 2 millimeters in diameter. So this is used to expand periosteum, and bone graft is done, and they are stabilized using os builder, and the implant can be stabilized. The os builder is stabilized. After that, the deficient attached gingiva can be expanded. Attached gingiva is already developed, not by us, but there are other companies, and we are doing it as well. By us is currently sold by us, and if they can be achieved, a lot of advancement can be made. This slide is provided by Dr. Kim Jin-woo of Ide-Mokdong University Hospital. Tissue bags was inserted, and bone graft is done later. Tissue bags has big particles, and the shell and the material inside has some gap, and we are improving it to reduce the gap. Implant and bone osseointegration, regeneration is very good, but placing implant should be done properly as well. Direction, depth, and positions need to be appropriate for the placement, but mistakes can be made. So cantilever can be made in a wrong place. Cusp would be located, or it can touch the adjacent tooth or damage alveolar nerve. So these problems occur in the hands of masters as well, more in the hands of beginners. So we can use a guide to control precisely the position, direction, and the depth. So we have OneGuide. The problem with OneGuide is that dentists need to do design themselves, but they usually leave it to others to design it. And so we are providing the OneGuide software. With only 3 clicks, you can reduce the work to design the guide. Preparation, design, printing. Those are the 3 steps. Patient name should be entered and OneGuide should be executed. Then the patient's CT and scan data would be brought in, and the missing tooth would be identified. Numbering and segmentation are the words that we use. So tooth have identifying numbers, and from the library, crowns are brought in to indicate where implants would be placed, and 5 millimeter for center incisor, 5 or 10 for other tooth. So depending on the setting, this is made. That's the preparation, and this is the guided design. And you can do prosthesis based on that, and export sends the guide out. Prosthesis, abutments, and all are displayed together, and if this is correct, a guide can be printed. The guide is fit into the patient's mouth. If they fit, you can use it. Otherwise, it should be adapted. The inside of the guide needs to be adapted, for example. Planning versus adaptation. If they match, you can use it. Otherwise, you can adapt until they match. So sometimes the using guide doesn't achieve accurate positioning of implants, so you need to check. And the prosthesis is the same. After implant placement, the prosthesis should be made. The key here is the library. The software has the library for guide design. The optimal one would be displayed. For the crowns, there's a library, and the computer already knows which teeth are missing, so we call it numbering. And the missing teeth numbers are identified. So this is on the left-hand side. The right-hand side, the images are also displayed, and from the library, the appropriate ones are selected, and the contact points, the occlusal points are checked, and they are exported. So everything can be done with 2 or 3 clicks, and that means the program has very good functions in there. AI function is also added, so the implants are placed and prostheses are delivered. Malocclusion, broadly, there are malocclusion types: crowding, spacing, open bite, deep bite, and cross bite. So those are the major ones. How to resolve them easily? We can use digital dentistry. For a patient, the teeth are scanned, and CT is taken to make the invisible part more visible. The program name is OneOrtho. So those are brought into OneOrtho. That is the preparation, and the images are merged and displayed. Preparation And here, analysis is included, how the teeth would be aligned. The criteria of alignment is included. So analysis is performed. After that, the setup means showing the finished image. So there are two ways to treat that. One is using clear aligners, and the other one is brackets. Clear aligners. Magic Align is the name, or One Ortho Aligner. One Ortho A will be the name, and by step, incrementally, the design is showing the result after treatment, before treatment versus after treatment. And in the middle, for each aligners, you can see the aligners at each step. Simple ones would require less number of aligners, and the models would be displayed and can be printed using the sheet. It's cut. So on the right-hand side, the aligner will be sent to your clinic, and this aligner is fit into the patient, and attachments are included in there. And incrementally, the orthodontic treatment is done. So as long as you make a proper plan, there's not much you need to do. And the software shows images at each step, and then you can discuss the image with your patient to create the aligners. So we are not using our software, we are using another software, and we are using Magic Align software, and you can access there, and scan data can be entered there. Then we fabricate the aligners and show them to you, and on the computer you confirm the image. Then we fabricate them and send them to you. So Kosan is where this is done. This is different from others. We are not you're not doing all the steps at once. It is divided into 1 to 6 steps and others. On brackets, do not use digital dentistry that much, but clear aligners, acrylic resin can be changed. The form can be changed, and the tooth movement is made by the recovery of the resin. But here, for brackets, wires are used. That is the big force, and spring coil can provide a minor, the light force for minor correction. Brackets should be used properly. So this is before and after treatment. So setup means after treatment image, and brackets are attached digitally. And this is the actual attachment, IDB, indirect bonding jig, using the jig. The brackets are attached to the jig, and one by one, they're attached to each tooth. This is the indirect bonding jig. The bracket is attached before it is sent to you. Sometimes resin can be applied by a dentist, but it can be attached before it is sent to a dentist. So we want to make it very simple. We have smart bracket, we try to register it as our trade name, but it didn't work, so we call it Majesty. The final torque is important. For example, 7 degree is something we want, and the Roth prescription is 12 degrees, and MBT only 17 degrees is available. Then 7 degree is okay, but Roth and MBT would apply torque in the wrong direction. So to match that, rect wire should be controlled for finishing. So you need to do the final job properly in order to get rid of that cumbersome step. Roth and MBT are kept, and a low and high are added, and statistical analysis done. Upper central incisor, 7 degrees is necessary. For number 12, 3 degrees is necessary. And number 3, -7 and +7 degrees are needed. So we have many different variety, and we do digital setup, and the optimal bracket can be chosen. And the brackets are attached, and a low friction force. It has a low friction force and has excellent strength. And brackets are attached. This is the treatment procedure. Brackets are attached. After attaching them, a wire is attached, and this is the next step. And the spring is used to widen the narrow space, and the brackets are attached again. After the treatment, after recording all of this, we leave a chart, and this is called charting. So it looks like this, and it is a little bit different from the one actually used. On the left-hand side, what brackets are used, when used. So 1, 2, 3, 4, 5, and 6 refer to visits, appointments, and brackets attachment, and what wires are used at the beginning. Thin round wires are used, and then the wires would become thicker and erect as well. ETC means minor corrections. So elastic springs can be used as necessary, and this is something you can see. A dentist should know how the treatment will go. But we have one ortho that is developed to get rid of all those manual work. After the final setup, the appropriate brackets, including the angle and the appropriate jig, are attached, and those are sent to you, but you will be able to do it yourself. The charting is made. So this is recording what will be done versus the previous chart showing what has been done. So before, the chart shows what have been done, but this one is kind of plan what will be done. So whether this will go smoothly or not, if you're not sure, you can scan again, and that is entered, and what can be done is shown to the dentist after all those works. And errors can be made. As I said before, finalization is important. The controlling at the final stage should be properly done, and then meticulous bending can be facilitated. And the fixed retainers, this is not easy to fabricate them. It should be tightly fitting, So fabricating this can be also assisted by us. Brackets, clear aligners all sound good, but you cannot afford to use one of these. Clear aligners very good because it works in the oral environment very well, but the rotation bodily movement, root movement are not easily made with the clear aligners. So hybrid devices are used currently, and we are studying on those topics for the bodily movement. Mini screws, mini ortho screws can be used, and clear aligners. Some of the aligners can be opened to attach a button. We provided implant master course, and we have an ortho master course, orthodontic master course. This is for overseas dentists who are not very familiar with orthodontic treatment approaches. We have bracket ortho program and clear aligner training program, and those are 10-day courses. And the dentists here developed the course and are involved in there. If you are interested in ortho treatment, please register in one of these courses. Thank you.
Thank you for the wonderful explanation, and I could really feel your passion. Please give President Jayeyoung another round of warm applause.
영어와 중국어로 동시 통역돼 해외로
Welcome back to Osstem Meeting 2025 Seoul, which is being broadcast live worldwide with simultaneous interpretations in English and Chinese. We will now begin the third session. Let me first introduce the chair for the third session, Dr. Hwang Chung-ju, Director of Osstem Implant Dental Research Institute. He is former chair professor of the Department of Orthodontics and head of orthodontics at Yonsei University. And he is former director of Clinical Research Institute at Yonsei University, former director of Craniofacial Deformity Research Institute at Yonsei University, visiting professor at UCSF, president of the Korean Association of Orthodontists, chairperson of the Ethics Committee at Korean Association of Korea Orthodontist, honorary professor at Yonsei University College of Dentistry. Hi, nice to meet you. Hello, everyone. I'm Dr. Hwang Chung-ju, chairperson of the third session. I believe that, as President Jayeyoung has mentioned, he has a really diverse, deep interest in orthodontics. The clear aligners will pave a new path forward. I hope that this session will be informative and meaningful for all participants. Now let me introduce the speaker for the third session. The first speaker to open the third session is Dr. Jayeyoung from Seoul Orthodontic Dental Clinic. He has completed a Korea University residency, a WFO fellow, and he is also runs a course on clear aligners in Osstem. So let me introduce Seoul Orthodontics Dental Clinic Dr. Jayeyoung. The title of his presentation is Good Change Paradigm Shift in Orthodontic Treatment and Magical Line. Please welcome him with a warm round of applause once again. Greetings. I am honored to take part in the third session in Osstem 2025 meeting. So as the president mentioned previously, clear aligners have gained more interest among practitioners, so it's the same with me. Today I want to talk about clear aligners focusing on magical line. Did you enjoy your lunch? So this is the first session, so I want to talk about good change. So let's take a look at a brief video first.
남편이 어떤 분이세요? 내 인생의 로또야. 정말요? 안 나죠? 지금 여러분 안 나죠? 어떻게 그렇게 안 나죠? 하나부터 열까지 안 나죠? 주여! 하나님 아버지 할 수만 있으면 기도라도 하세요. 데려가세요.
구체인지에 관련된
So is this a video really relevant to the topic? Excuse me, technical difficulties are being experienced. So, do you all agree? As a orthodontist, using clear aligners. So we cannot get rid of conventional treatment method, but clear aligners can become an alternative. And in our clinical practice, I believe it can be very meaningful. So let me introduce the contents. Difference in the CAT and fixed appliances, and in cases there are different teeth movements. Conventional appliances and CAT, how we approach them differently will be addressed. First is fixed appliances and CAT and differences in between. There are about 4 amongst many. So applying force, pull and push. In fixed appliances, wire and brackets are used to pull the teeth. So it's the same with locked teeth. In the case of clear aligners, the aligner covers the teeth and it pulls the teeth. And because it pulls the teeth and pushes the teeth, the difference is that we get target tooth movement. I want to go into detail. This is not a very difficult case, but in order to do bracket treatment number 11, the key is putting it in alignment. Then the adjacent teeth can experience action and reaction. And it's a similar case, number 31. We need to align it with adjacent teeth. This is a clear aligner and brace treatment. 2 months, 4 months, 6 months. It didn't take too long, and the result was not very bad. However, as mentioned, number 31, for tooth movement, in the case of bracket movement, reaction causes unnecessary tooth movement and it elongates treatment period. In the case of clear aligners, overall teeth are used as an anchor to align the tooth in question. So it's more beneficial. Third, so individual dental arch form, it can be maintained. So with fixed appliance, I've provided ortho treatment for 27 years, and there are 3 major side effects, and it's quite embarrassing, but I hope you can understand. So
this is a crowding case. Initial wire was done, alignment leveling was done, and while this was done, number 13 and 23 was inclined and sliding occurred. And unwanted treatment period was extended. This is the second case, number 23. High canine was observed, and alignment leveling was done, and finishing detailing and space closure was done. If you take a closer look, you can see there was buccal overjet. Why is that? Number 23, it was towards the labial side, and through alignment, adjacent teeth suffered an action reaction. Buccal object overjet resulted. This is the third case. So upper anterior and lower anterior, there's some space. Orthodontic appliances were used, and finishing detailing was done. I thought it would be fine. It looks okay. Let's take a closer look. Buccal of overjet occurred like this. So these were 3 mistakes that perhaps you may think all orthodontists make such mistakes, but these are just some of the mistakes that I experienced. In general, this was completed. There was slight buccal overjet. In order to do this, additional time and effort is necessary. And in doing bracket treatment, there were some of the difficulties experienced, the dental arch form. So we can differentiate arch form into 3 different types. And most patients do not fall under these three exact categories. And we do not. It's very difficult to get everything ready to provide a treatment. In that sense, the clear aligners, because it reflects individual dental arch form, is more favorable. Treatment planning. There's difference. It's difficult to say whether it's pro or con, but it's just a characteristic. As Dr. Che has mentioned about orthodontics, and in 2026, ortho session can be run by the Vice President Che. I strongly recommend it. And bracket treatment, every 4 weeks, the patient needs to come in, and you need to look at the tooth movement, and you have to be reactive to tooth movement. In contrary, so you can be proactive and you can come up with a plan over the overall duration of the plan. You can simulate the teeth movements in the anterior region from frontal view, and from occlusal view. You can see different tooth movements that probably would occur. And you assess whether you can get a good occlusion using these treatment devices. I think this is quite important. When I give lectures in general, a lot of people say clear aligners, as mentioned. Does it do automatically? But no. Even when you do clear aligners, the doctor's role is very important. Once you send the records in, you need to come up with. The company sends you the treatment plan. The first modification, second modification, third modification. At times it can go up to 4th and 5th. And teeth movement, you'd assess whether such treatments are done properly. And the practitioner makes the decision. I think this today is what that is about. We need to look at the different characteristics, and let's look at the cases. As mentioned earlier, in ortho treatment, there's a lot of teeth movement. So I want to look at various cases and look at the different approaches using fixed and clear aligners. First case, 30-year-old female patient. There is generalized spacing. As you can see, in the upper anterior and lower anterior, there's a bit of spacing. If you look here, there's edge-to-edge bite. And in the lower left posterior region, there's rotation. It's the same with bracket and clear aligners, and in order to provide successful treatment, you need to have considerations. So first, how are you going to do space closure? How are you going to proceed with overjet, overbite, and control the rotation? First, the space closure. So this is a different case, and braces were used. I want to give you a brief explanation about it as shown here. It's a similar case, lower anterior, upper anterior. There's a bit of spacing, brackets, appliances were used to do ortho treatment, and the progress looked nice. This is a occlusal view. So let's take a look at the process more in detail using the images. And the patient has anterior spacing. If you use to fix alliances, you use initial wires for 3 to 4 months, do alignment and leveling, and after that you move the 1 and 2 and 3, and the sequential movements are done, and space closure is done as shown. So this is a basic routine you use when using the fixed appliance. This is not a bad way, but basically there is process and time that is taken. If you use clear aligners, these multiple spaces can be closed all at the same time. The overall treatment period can be reduced. Let's look at treatment strategy. Rather than looking at all of them, I want to focus on a couple. I want to talk about posterior tipping. In the extraction case, we need to do space closure. We use a soft plastic framework, and it moves like this. And it takes a long time to undo. So this is a different space closure case. Clear aligners were used, and this is the process. In the middle of space closure, in number 46, there is mesial tipping. So this is quite difficult in this case. Well, there can be ways to remedy it, but as you can see, there's tendency of proclination. So attachments were applied to prevent it. As shown briefly, you can use a power arm or tip back form on the aligner. Second, so there was open bite tendency. How are we going to provide overjet, overbite? How are we going to improve it? As shown in this patient, if there is open bite tendency, tipping extrusion can be utilized for special space closure. And as you do pulling, this can be considered. Tipping extrusion and extrusion attachments can be utilized. This can be used to improve overjet and overbite. Third is rotation control. This is a different patient. There is mild crowding. The patient came to my clinic. The patient's children also had ortho treatment. Very important. The clear aligner was done nicely. About 12 aligners away, there was intrusion. So it's quite confounding. As you do clear aligners, at times these kind of situations can occur. So as you do aligner treatment, there can be intrusion movement, and we need to intrusive pressure exists, and we need to provide compensatory extrusive force using attachment. And compensatory extrusive attachments were used so that rotation forces can be applied. Based on these tools, clear aligner treatment was attempted. This is the initial step and the panoramic image. Diagnosis and clinical goals were set. As mentioned earlier, this is a very important stage. These teeth movement. We need to look at whether it is feasible or whether it can be achieved, need to be reviewed. We need to understand whether this can be achieved. For 9 months, 36 aligners were used. Edge bite, overall spacing, rotation was addressed in a stable manner. Intraoral image, occlusal view. So this is after treatment, and this is before comparison with before treatment. This second case, class 1 crying, and this patient is 22 years old. The patient whose chief complaint was deep bite. You can see there's deep bite in the anterior, and in the lower anterior there's a bit of crowding. As the same, in order to achieve successful clear aligner therapy, we need to consider 3 factors. How are we going to address deep bite? And also limitation of anatomic structures, as well as relief of crowding. In the case of fixed appliance, in order to do deep bite correction, there can be a bit of limitations. Because there's limitation, you cannot apply in lower anterior additional appliances or tools. Anterior bite plate, bite turbo needs to be applied. So this, I've been practicing for quite a while, so I've used auxiliary intrusion arch wires as well. These days, so screws can be used to pull the necessary tooth to intrude it. In order to address open bite, we need to do leveling of curve of Sheikh. With age, curve of Sheikh can deepen. 2 planes can be formed, or there can be lingual inclination of lower incisors. So treatment strategy of leveling of the COS. We need to intrude these incisors, and if the overbite is too deep, we can extrude the molar extrusions, and anterior teeth can be proclinated. From the company, these are provided. Functional attachments, aligner. So selective pressure area to provide optimal orthodontic forces, and bite ramp are provided by the company. So if you provide the functions provided by the company, does it lead to optimal result? It may, but as mentioned, in proactive stage, there are factors that we need to consider. It may differ depending on the level of deep bite, but we have to make different orders to the setup designer. We need to make heavy contact in the posterior teeth and light contact in the anterior teeth. We need to consider the engineering perspective as well as overcorrection. It's the same as in bracket treatment. We request for full-size rect IR with RCS with night tie. Second is when doing a deep bite correction, there can be anatomical limitations. First is related to the lower. If the symphysis is thin, it's very difficult to intrude the lower anterior. If you do not take notice of it and just apply intrusive force, then you can apply significant force to the root. It's the similar case with the upper. This is lingually inclined upper anterior, and we need to address it first and then intrude it. So I want to address rotation and crowding next. when I was talking about rotation control, I talked about unintended intrusive pressure. So we need to use compensatory extrusive forces. It's the same with bracket treatment in clear aligner therapy. The crowding or rotation needs to be, there needs to be space to address crowding or rotation. And we need to do expansion, IPR, to secure a certain amount of space to address the crowding. In light of this, diagnosis treatment plan was devised, and this is the initial step and the measurements, a panoramic image, diagnosis and clinical goals. Using this, using magical line. So I think this is a very important step, whether this can be achieved using magical line. We need to make a correct assessment on 3D web. Regardless of teeth movement, it can be possible. And it is the part of the dentist to determine whether it is visible. For 11 months, 23 alliances were used. And bracket, compared with the bracket therapy, I wonder whether some similar results would have been achieved. I think this can be slightly more favorable. Crowding was addressed significantly. Deep bite was addressed. This is a closal view. This is a treatment, follow after treatment. This is the last case. It was a slightly difficult case. 26-year-old male and anterior crossbite 23 was impacted. If you take a look, I think it looks quite difficult with the bracket. If you look at the right side, there's a class 3 relation in the anterior. The midline is slightly shifted, and there's spacing and open bite tendency. Number 23, the space is very reduced. It's missing. So I'm not sure whether it's going to be successful, but for successful clear aligner therapy, we need to consider these 3 factors. Consideration on class 3, open bite correction, and space regaining with translation. First, class 3 needs to be addressed. In order to do that, in the lower posterior area, molar distalization was needed. So I'm going to use the upper to show you the example. So we have to move from the rearmost tooth, and if it progresses about 50%, you move on to the next tooth sequentially. And this is how molar distalization is done. In the case of class 2, if you use class 2 elastic for simulation, as you do molar distalization, class 2, class 3 collections are done using the elastics. Class 2 molar distalization, as you do it, there's side effects that are bound to occur, and I want to talk about how to respond to the action-reaction. I use elastics to address such problems. If you look at the manual of the manufacturer, the distal movement of second, it needs to be, the early molar distal movement needs to continue before the second premolar distal movement. And the recommendation is to do it in the earlier stage. As mentioned, posterior distalization, there can be side effects. As we push it, there can be tipping. As distalization occurs, a reaction occurs, and the anterior can move forward. And it's not easy to address it. And if you look at the treatment process of the patient, you'll be able to get a better clue. So this is left. This is class 3. Clear aligner therapy was done. most molar distalization number 7, 6, and there's space between number 6 and 5. If you think like that, that's a mistake. If you look at the canine, class 3 tendency has worsened, as mentioned, because of this is a reaction of a side effect of reaction, and anchorage was enforced using these to address it. Let's take a closer look. To reinforce anchorage attachments in the posterior region was used. Class 3 elastics and screw was used. To distalize the anterior side as well. This is the open bite. There can be many strategies you can use for treatment. We need to consider whether the problem originates from the tooth or skeletal issues. And let's talk about in the sense of teeth movement. This is open bite, so incisor extrusion needs to be done, molar intrusion needs to be achieved, and the incisor inclination needs to be reduced. Tipping extrusion needs to be utilized to improve open bite. This is an approach using fixed appliance, and this is a surgical case, but surgery was not done. But based on the patient's needs, a teeth movement was attempted on the palatal side. So posterior impaction was aimed, and the result was good. It was a quite difficult case. So in the case of clear aligners, optimized extrusion attachments were utilized, and intrusion of posterior region was aimed. In this case, the extrusion attachments were used as shown. As we take a look at these cases, it looks very simple, but not really. It depends on the case. And if you look at the case with a patient who received the fixed appliances, it will be quite difficult to address using only the attachments. Finally, I want to talk about space regaining. Regardless of fixed appliance or clear aligners, bodily movement or translation is not easy. And this was also mentioned by Vice President Sheikh. And a fixed appliance was used to regain space here. Number 12 was missing. Number 22 was smaller. And in order, we need to restore and improve these areas in order to improve overjet overbite. RP1 was used. So I liked bending wires, multiple loops were used in the upper anterior. Labial version and flaring was attempted to be utilized. Open coil was used. Various forces and efforts were put in. The result was not that bad. This is before and after treatment to regain space. In bracket therapy, so it was quite a lot of work. Would clear aligners be more easy, as shown, towards the root? In order to apply moment, these kind of attachments are applied to apply bodily movement of tooth. So FE analysis, if you take a look, this kind of attachment when applied, the bodily movement with attachment was achieved effectively. And similar attachments were used for my patient. So using magical line, this patient will be treated. This is initial stuff and the measurements. This is panoramic image. Number 23, you can see that it's impacted. This is diagnosis and clinical goals. magical line was used. I think this is a very important stage. Using the aligner that I'm designing, would such teeth movement be achievable? We need to look at the side view, frontal view, and occlusal view, and we need to utilize all the knowledge that we have. It took slightly longer. Even if with the bracket therapy, I think it would have taken similar period. 72 steps were utilized over a period of 28 months to adjust occlusion. This is at initial, and this is after treatment. I received help of an orthodontist, and I received help from a prosthodontist and provided Maryland Bridge as well. So I'm not sure whether you were entertained. I've talked about good change. So as an orthodontist who has been practicing for 27 years, I cannot really forego bracket therapy, but I believe that clear aligners do have a standard in the ortho treatment field. Thank you for listening. Thank you for the wonderful lecture. So we will entertain the questions after the third session is over.
Next speaker is Dr. Lee Jong-guk. So he graduated from Korea University, and his specialty is orthodontics and the clear aligner. Speaker is his role. He's going to talk about good chance, a collaborative approach for efficient tooth movement of clear aligner. That's the title of the speech. Dr. Lee Jong-guk is the director of Apgujeong Oracle Dental Clinic. Are you ready? So please welcome him with a big round of applause. Good afternoon. My name is Lee Jong-guk. I'm with Apgujeong Oracle Dental Clinic. Thank you very much for inviting me in this wonderful meeting. Today, I'm going to talk about various clinical tips for efficient tooth movement based on my personal experience. If you look at the video down there, so a very close, very good friendship between those two. As was mentioned, clear aligners are positioned as a good option in ortho treatment. Clear aligners work very well sometimes, but not always. So compared to fixed devices, when clear aligners don't work, treatment time would be lengthened, which increases the treatment cost. The treatment cost is burdensome to the patient, and also it can be a burden to a surgeon. If a mountain of aligners are made like this, if you are using unlimited appliance fabrication under a comprehensive package, it would not be a problem. I'm not talking about the limitations of clear aligners, but I want to talk about the issues that you may encounter clinically. Actually, music is supposed to be played, so in order to lessen the burden, I want to introduce some solutions. The videos were made using AI. It didn't take long, and I'm not an expert, but as an amateur, I could produce the videos, and the music is not playing, but I prepared the very solemn music, but it doesn't work. So this is a remarkable age that we live in. So along with the trend, clear aligners advancement in the future is something I look forward to. Let me introduce some simple cases. I prepared the cases, very simple ones, so that you don't feel threatened by the cases. A 46-year-old female patient, and there was anterior crowding and in and out distortion of teeth. That can be corrected using clear aligners. So I explained that to the patient. The patient lives in the UK, and she comes to Korea a couple of times a year. So 12-step suggestion was made and instructed the patient to wear them. But after 4 months, the patient came back, and the patient was satisfied, and it pleased me as well. There were many variables, but it worked very well, encouragingly. I just met her once. She was compliant. So with one visit, everything was achieved. This is a 30-year-old male. So the crowding was a chief complaint, and the clear aligners they were something he wanted. 25-step approach after about a year, and after 3 years, and I suggested to finish the treatment, and the patient compliance was not very good. So every time the aligners did not fit at every checkup, and I always got his promise that he will be compliant, but he was not compliant, and time passed, and I could have made a different decision in the middle and switched the approach, but anyway, it went like that. Actually, the driver is trying to move forward instead of moving backward. Would have been much easier. So if someone is really specialized in this area, they can do it easily. But using another devices, so we can plan and finish cases much easier. So let me talk about that. So I will show you 2 more cases. Clinically, we can encounter this kind of case easily. 20-year-old male, and clear aligners were to be used, and there was a crowding in the anterior, and he's a soldier. He's a son of my friend. My friend's son is serving in the military. He has grown up so fast. So there may be many different approaches. So in order to reduce the number of visits for the soldier, this can have very good. This can be a very good option. The anterior crowding needs to be resolved, and IPR is to be used for spaces, 3 months and 5 months. Photos, 14 steps were to be used. It went well for the mandible. The maxilla it didn't work. It was not bad, but this was the goal, but it fell short of the goal. And then we could make it again, but it didn't quite meet the goal. The next case, there was lower anterior crowding, a male in the 30s. There can be other options, but the clear aligners were used. The compliance was pretty good, so anterior teeth were to be corrected using IPR and expansion. 2.5 months later, so this is after about 6 months, 20 steps were used for the lower anterior. But this is the objective of the treatment, but it wasn't quite met. This is something we can encounter frequently. And it is important, the reason why tooth movement did not progress. There can be many causes, and there can be 3. Diagnosis can be a problem. The sequence of a tooth movement or lack of IPR amount. So the second factor is the compliance. The patients I showed you in the cases had a pretty good compliance, except 1 or 2. Number 3 factor is there is a plastic aligners limitations bracket. We need to focus on diagnosis for clear aligners. There were 3 factors: diagnosis, compliance, and the material limitations. The first and second factors are important, but they can be controlled, changing the diagnosis. But the number 1 can be addressed easily, but number 2 and 3 are different. We cannot finish early because of factors 2 and 3. So we need to have an option to address that. This is a paper published in 2023, and clear aligners were used for about 500 patients. 6% only was finished at once, and actually 1 out of 6 had to change the brackets, and the treatment required an average of 2.5 refinement scans. So 100% success rate cannot be really achieved. So now the accuracy is about 50%, including the posterior region. So this is not a very stable option. And with brackets, the expanders can be used, and additional wires and auxiliary devices can be used, including a bite block or lingual buttons can be used to finish the treatment successfully. But brackets we don't think brackets have limitations. And for better tooth movement, we use them. The same goes for the clear aligners. What if unexpected tooth movement occurs? So what are the solutions that we have? There are about 4 for your easy memory. A, B, C, D are indicated here. This is the easy approach to remember. D is delay. Delaying the aligner changes. If tooth movement is not achieved correctly, if it is not a big problem, before changing the aligners, the current aligners can be used a little bit longer. Number 2, creating a new set of aligners, which is a routine solution. Number 3, bonding auxiliary devices. Number 4, A, adjust clear aligners using pliers. So these 4 will be explained. Number one is just using the current one and wait and watch. And let's go to C. Create a new set of aligners after scanning. But you need to identify the causes of the problem accurately. So we need to have many guaranteed aligners. 10 steps, 20 steps are set as a goal, but if you used all of them, creating a new set of aligners could be burdensome. So if you can create a limited number of aligners and you have many remaining aligners that can be used, and you need to have a good compliance from the patients in order to get good results. And if the fitting is not good and the fitting in the lateral incisors cannot be achieved very easily. So not from the beginning, but gradually the fitting would be lost. If there is such problem, we need to make a decision whether we will continue to use this approach, whether aligners will be created continuously or attachments could be used. So creating new set of aligners depends on how you can accurately identify causes. Between teeth, you need to check whether there is even slight space. So there's some technical glitch. So if tooth movement are not achieved properly, rather than blaming the aligners first, you need to check whether there is a slight space between teeth. Unlike the fixed devices, if there is no space at all, teeth cannot be moving. And if they don't move, you need to check opposing teeth. One of the reasons why tooth does not move is can be attributed to the opposing teeth. So those two are important to be considered. I believe for your understanding, I need to show you some photos. So in many cases, the lateral incisor area is not fitting very well. So especially when you adjust the rotation, and in the proximal contact should be checked. You can easily check at your side at the existing aligners, and teeth alignment in the mouth can be compared. The aligner is very well aligned, but it doesn't work in the mouth. You need to check whether there's any space between teeth. So for about a month, we used aligners, and the upper lateral incisor was to be rotated, and we set a target to achieve within 3 months, but the aligner, this is something we wanted, but the result was not very good, and we need to check the interproximal contact. The mesial contact was opened a little bit, and using the same method, the aligners worked, and the goal was achieved. soon. So you need to check the contact between the teeth, and opposing tooth can be a problem. Even though aligner is very good, interproximal contact is okay. Opposing tooth can pose a problem, preventing good results. So when we create the new aligners, so we need to identify the causes of the problem. Third, bonding auxiliary devices. There can be many, and the buttons can be a representative device if there is a vertical step during orthodontic treatment. Labial, lingual buttons can be used together with elastic to control them control vertically. Improvement can be achieved within a month, and the devices can be made at chairside, and on chairside fabrication of the devices can be made. How to make a button? Ready-made buttons can be used, but they easily fall off, and metal buttons are burdensome. So O-ring with one side cut is placed on a tooth. So the cutting line should be provided for easy removal, and the resin is mounted and it should be cured. Then on the surface of tooth, there's some anchorage. So the resin should be cured, and the resin is mounted. And because of the cut, you could easily remove the O-ring. And the resin button can easily be attached. They don't easily fall off. You may think it can easily fall off, but it's not the case. For rotation control, buttons and elastics can be connected. The buttons can be attached to teeth, and sometimes on aligners. There are aligner dedicated pliers, and you can use a plier, and then you can heat it up with alcohol, and then if you press on it on the neck, the button form can be created, and there's action reaction. So if the buttons are made on aligners, the side effects can be eliminated. At number 26, it is visualized. And if you're skillful in operating the clear aligners, so with the attachment, the operating is made easily, but it's not in my hand. So sometimes it's intruded because it's pushing. So we need to have various solutions. Buttons can be used, or sometimes auxiliary devices can be used before we move on to the next step. And I believe you use this quite a lot clinically. So operating springs can be separately used with clear aligners, and uprighting of the molar is separately pursued together. And if you look at this case, anterior crowding is the chief complaint. So you may think clear aligners can address the problem. There can be many different diagnoses, but we decided to focus on anterior crowding. So the patient wore the devices for some time, up to 12 months. IPR and the space creating was done. If lateral incisor moved forward, everything would go well, but at month 20, the movement was not made properly. So sometimes we encounter this problem, and do we need to continue to make new aligners until it works? We need to make a decision. Lateral incisor is not fitting in the aligner, and the aligner is aligned, but the tooth did not move, and it can create the vertical step because intrusion effect. So we need to have a solution. In 2 weeks, the step in the teeth was reduced. The devices were attached, and it can create some reaction and relapse in other teeth. So it was opened with a scissor, and we approached it from cervical area. So within a month, the vertical step was reduced significantly, and the patient was compliant. And the patient agreed to my suggestion. So using auxiliary device attachment in 2 months, good results was achieved. I requested Osstem to fabricate the jig for me, and it's not officially provided, but they answered my request, and those were attached, and it was finished in 2 months. Vertical step was resolved. So it took us some time, but it is important that we have a solution. I wanted to use this approach at 1 year, but it was delayed. The lower anterior crowding was something that the patient wanted to address. So clear aligners were used. 14 steps. After 3 months, 8 months, 13 step. As you can see, the patient did not come to visit the office as planned, and was not compliant. So the patient wore the device just 5 hours a day, and we wanted to do it again. So another 14 steps were planned. After about 5 months, this is something we wanted to achieve, and aligners did not fit. So because of ill fitting of the aligners, the patient doesn't want to go on anymore. So a doctor cannot accept the stopping of the treatment. So night-tie wire was inserted, and some results were achieved just within 2 weeks. Not a very precise solution, but night-tie is bent, and because of the recovery force from that, so more specific, night-tie wire. The Vaseline was applied to the wire, and resin was mounted, and resin works like a bracket, and then wire was moving in the brackets, and they were aligned fast. And this can be used at the beginning, in the middle, or at the end, and it can reduce the number of steps, and it is very effective in terms of tooth movement. And this is another option that you can use in your clinic. And lastly, there are pliers for adjusting aligners. If rotation is necessary, there are many options, including devices. And if you bend a little bit like this, the rotation can be achieved. The protruded incisor, clear aligner, can be pinched using a plier that can work. For various reasons, the patient received the clear aligner treatment, and we plan to finish at 8 months. And the patient said that this is protruded a little bit, and this can happen from time to time. What does a surgeon do? We can newly make an aligner or attach a lingual button or other devices. And the dedicated plier can be used to pinch on the aligner. Just in 2 weeks, it is rotated. I applied it only on the lingual side, and the patient said it was okay. It was acceptable. So this is how it was finished. So this is something we can use. The ABCD options can be used to address some problems. That's the options that I wanted to provide. Lastly, we need to plan that from the beginning. A deep bite patient, and there are many entertainment companies near my clinic, and this is a young person who visited the clinic. If you look at the relation between the upper and lower arches, it's not easy to straighten the crowding, and the patient wanted to resolve the lower crowding within 3 months, but it took 2 months, and I used the brackets from the beginning, and in 2 months it was resolved to a certain degree, and after that clear aligners were used that reduced the treatment time, and also it was beneficial in terms of the cost. Time is up. So if I have another opportunity, I will show you the remaining slides. Those are not that important. The take-home message, you need to remember A, B, C, and D options. A, B, C, D. Please remember them. And efficiency, fee need to be considered. And you need to go step by step. This is something I wanted to say in April. If you want to study together, please come to this program. Thank you. The clear aligners are used for effective tooth movement. Dr. Lee, thank you very much. So we are being delayed. Therefore, we will have only 10 minutes for Q&A. First, any questions from the floor? Hello. My name is Park Yong-Bum from Yonsei University, Prosthodontic Department. Thank you for the 2 presentations. I am not familiar with the ortho treatment. For better orthodontic implant treatment, we refer the patient to ortho department. Listening to your presentations, bodily movement using clear aligners for bodily movement, attachments are used. The existing orthotherapy versus clear aligner ortho treatment. Biomechanically, what are the differences between those 2 therapies for implant treatment? Clear aligners, when it is worn, there is no occlusal contact made between teeth. So after clear aligner therapy versus bracket correction, what are the pros and cons in terms of the outcome of the treatment? Thank you. So can you answer regarding the first question? When implants are placed and the clear aligners are delivered and they're worn by the patient, is it the impact of the aligners on the implants? Just like ortho devices, implants are used for anchorage. When clear aligners are delivered, success or failure of an implant is not determined by the clear aligners. The finish detailing clear aligners have been improved at the finishing stage. More things need to be considered for clear aligners than the conventional approach. So clear aligners, they ask whether that creates some ill-fitting device. It is actually, if you use conventional brackets, they are not always perfect in terms of fitting. And clear aligners, there are pros and cons, but there are many advantages of using clear aligners. Thank you for your presentations. My name is Dr. Yu Sung-hoon from Pyeongtaek. One question to Dr. Ji. Digitalization case, it was very good, and I always think about that. Molar is moved sequentially. Number 7 first, and to maintain that, in order to prevent visualization, sometimes we use pin. So pin and power chain, do you attach them directly or indirect method for setup in order to maintain molar? What is the tip that you use to communicate with the lab? Thank you for the question. It can be a difficult question, but I didn't understand your question. Pin, what do you mean by pin? Ortho mini screws. So class 3 elastic, class 2 elastic can be used to minimize the reaction in the molar area is important, and sometimes button can be attached to number 4 tooth. That requires patient compliance. Sometimes a power chain that can be dangerous too. And I believe you understand as an orthodontist, the power chain can be additionally used. In my case, the button precision cut, button cut out was made, and the button was attached in general. If you look at the paper of FE analysis, precision cut is made to connect to class 3 elastic, and class 2 simulation can work better in my experience. And sometimes I specify the buttons when the canine is visually tipping, and up and down elastic sometimes is needed for a tooth, then buttons are used. So we have many questions online, and we are going to entertain 2 questions to Dr. Lee. What is the know-how of attaching the devices? Not special know-how on that. Zirconia crown, I don't think we attach it to zirconia. And attachment can be added, and I use it like a bracket bonding. Dr. Chi, precision cut, you said that is good. How much do you cut for effective force application? First, the fabrication is made by the manufacturing company. Isn't it funny? So it is ready-made by a manufacturer. As Dr. Lee said, precision cut is made. So there is a ready-made plier that is used. I cannot say for all cases, but biomechanically, the direction of the elastic should be considered. and some of that should be controlled. Clinically, more important thing is that when elastic is applied, sometimes that fall off. So for better connection, precision cut should be provided. That's more important in practice. So clear aligner lecture has been provided. And lastly, to the beginners who are using clear aligners, what are the things that you need to be careful? As I said in the beginning, so AI will give us diagnosis, and troubleshooting can be also provided by AI, and we just deliver the device. That would be great, but it is not used in practice yet. We need to do planning, and we need to make adjustments, and we also need to observe at every visit of the patient. So we need to have understanding of clear aligners and orthodontics. So self-driving cars can come out. That doesn't mean we don't need driving license. So at least you need to obtain driving license to use the car. So you need to be a dentist to use clear aligners. Thank you very much. And Ruli and Impochobo are receiving gifts for good questions, and please give them a big hand. So this concludes session 3. Thank you. Dr. Hwang Chung-ju, please give him a big hand who chaired this session. So online best questioners who are chosen will be contacted individually later, and login viewer event, 600 people will receive coupons for this. The lucky ones are
Congratulations. Please refer to the notice board on the dental site for specifics. So we're going to have a 10-minute break from now. After that, Dr. Kim Yong-jin will perform live surgery. Please stay tuned. See you soon.
Introducing the ultra-wide implant. Ultra-wide implants are perfect when placing an implant immediately upon extraction of a molar. Ultra-wide implants with a diameter of 6.0 and 7.0 can be placed immediately without GBR in a socket where a molar has been extracted. Also, 6.0 and 7.0 ultra-wide implants are easy to place without having to wait for an extraction site to heal after the removal of a failed implant with a 5.0 diameter. Try the ultra-wide implant for immediate molar implant placements. Introducing Magic Align. A digital clear aligners can be corrected accurately and conveniently, crowding, space, and deep bite, which are various encountered in clinical. Magic Align can be corrected maximum 5 mm crowding cases within about 10 months using less than 20 step aligners. And maximum 4 mm of space case can be corrected within about 5 months using less than 10 step aligners. Also, maximum 4 mm of deep bite case can be corrected within 10 months using less than 20 step aligners. and maximum 2 mm of open bite case can be corrected within 5 months using less than 10-step aligners. Anterior crossbite cases of less than 2 mm can be corrected within about 3 months with less than 5 steps. Protrusion cases of about 4 mm can be corrected within about 10 months with less than 20 steps. Magic Align uses Magic Foil, an excellent elastic 3-layer composite material. Therefore, more than 15% better orthodontic retention than the 1-layer material and less deformation due to aligners from put on and take off. So, effective orthodontic treatment is possible. Effective orthodontic treatment is possible due to less deformation of the aligners from put on and take off. In addition, the Magic Align is trimmed based on the patient's unique gingival line without covering the gums, so the patient can put on easily and accurately at once. Magic Align provides diagnostic analysis files and 3D setup simulations to help establish accurate treatment plans. In addition, orthodontic treatment can be carried out according to the initial treatment plan by applying the Magic Setup system that checks and supplements the teeth movement every 12 weeks. Start orthodontic treatment with Magic Align that can correct various orthodontic cases accurately and conveniently. Milling machines must be capable of manufacturing precise prosthetics. 1mm 5X is equipped with high-quality servo motor and high-power spindles. Servo motor offers more precise control of position and speed. Spindle with a high power of 500 kW offers stable machinability based on high rotation of 80,000 RPM. For plus and minus 5 micrometer processing repeat precision. Many processing tools are needed for processing of various prosthetics. 1mm 5X is equipped with ATC, a system that automatically replaces 10 processing tools. This allows simple and convenient processing of zirconia prosthetics and PMMA for temporary teeth, as well as hybrid ceramics for inlays. 1mm 5X can simultaneously using 5 different axes during processing for detailed and precise fabrication of prosthetic external shape and internal undercut. This allows processing of various prosthetics from inlays to implant full arch bridges with screw holes. Dental equipment must be simple and intuitive to use for any staff. Using a touch panel, 1mm 5X is easy and simple to use, from starting the processing to changing tools and cleaning. The front LED display on the equipment tells you the processing progress and remaining processing time. Circle LED on the door shows standby processing and errors of the equipment in different colors for easy identification. The white tone design is suitable for dental offices as well as patient waiting room and laboratories. 1mm 5X provides an aesthetic look of modern digital dental clinic. With servo motor and high power spindle, 1mm 5X manufactures high precision and high quality prosthetics. Simultaneous 5 axes and 10 tools offer limitless processing. Touch panel, LED display, and 3-way air blow system provides convenience. Introducing the E-Z series. E-Z is a zirconia block made by Osstem Implant. The E-Z was developed by our R&D specialist at Osstem Implant. Our in-house specialist at Osstem Implant developed the manufacturing process. Each product is inspected and completed through a systematic quality inspection. E-Z is a CAD/CAM compatible material that simplifies the process of creating zirconia prosthetics at the clinic. It can be fabricated in various dental restorations, including inlays, veneers, crowns, and bridges. Multiple prosthetics can be milled simultaneously with E-Z. The disc is in 98mm diameter and has 7 different types of thickness, which means you can select the right disc according to the length of each prosthesis, so that the material can be used more efficiently. Meanwhile, the shape of the block that comes with solid metal mandrel is diversified depending on cases. In particular, if you want to fabricate a long implant or bridges, you can choose block type with the 25mm height. With the E-Z HT, you'll experience natural-looking colors. With 3 different shades, A1, A2, A3, you can replicate the patient's natural teeth color. E-Z T has an excellent strength. Thanks to high flexural strength of at least 800 megapascal, you can fabricate stronger prosthetics for the posterior region that is susceptible to high masticatory pressure. Zirconia prosthesis material with natural-looking colors and outstanding strength. Try the E-Z series made by Osstem Implant. Introducing OneJet LCD, the next generation 3D printer specialized for digital dentistry. A dental 3D printer should be highly accurate. OneJet LCD features an array-type LED that emits light uniformly across all sections and a mono LCD with excellent light transmittance performance. It is also capable of high-precision printing at 100 micrometer or less across the entire output plate, meaning the user can apply the printed output to the patient without a separate adaptation process. A dental 3D printer should be fast. The OneJet LCD has printing speeds of up to 30 mm per hour. It can print a wide variety of prostheses, such as surgical guides, provisional teeth, models, and splints within 30 to 40 minutes. OneJet Cure Plus features a high-intensity light source, which helps cure materials within 2 to 7 minutes. Thus, the user can fabricate and place the required prosthesis on the same day the patient visits the clinic. A dental 3D printer should be easy to use. OneJet LCD offers 4 functions that improve user convenience during dental procedures. First, the user can send prosthesis data wirelessly and print. Second, the build plate is easy to assemble and remove due to its magnetic connection. Third, the printed prosthesis can be removed vertically without the risk of breakage or damage. Fourth, the automatic OneJet support setup function reduces working time. A dental 3D printer should be easy to manage and maintain. OneJet LCD alarm informs the users in advance for replacement of the LCD panel. Furthermore, the LCD panel is easy and simple to replace. It maintains the optimal printing environment, which prevents errors in prosthesis fabrication. Introduce high-precision 3D printing at your clinic with a fast and convenient next-generation 3D printer, OneJet LCD.
올스템 미팅 2025 서울
Now we will move on to the highlight of Osstem meeting, the second live surgery session. This session has been specially prepared by Dr. Yongjin Kim, but first let me introduce the chair who will be leading this session, Dr. Kim Kyung-won, Director of Osstem Implant Dental Research Institute. He has graduated from Seoul National University College of Dentistry, completed residency in oral and maxillofacial surgery at Seoul National University Hospital, former hospital of oral maxillofacial surgery at Chungbuk National University College of Medicine, visiting professor at University of Texas Health Service Science Center at Houston, and research professor in the Department of Bioengineering in Rice University. He currently serves as director of Osstem Implant Dental Research Institute and director of Twin Dental Clinic. Dr. Kim, greetings. Greetings. So this is the highlight of Osstem meeting. This is the second live surgery, which will be performed by Dr. Kim Yong-jin. The surgical case is full arch implant rehabilitation with immediate loading, challenges, and solutions. Please welcome Dr. Kim.
Good afternoon. I'm Dr. Kim Yong-jin. It is my honor to perform this live surgery in this 2025 first half of 2025 meeting. In the morning, Dr. Oh Chang-hyun showed us wonderful live surgery, which I will try to emulate to my best. Let me describe the patient first before surgery. A 67-year-old male who visited in this condition. In the photo, he used RPDs in the upper and lower jaws. All abutment teeth had the periodontal morbidity. The plan was to extract all residual teeth for implant restoration. Number 46 implanted did not have bone resorption and it was unremarkable, so only restorations will be made. Initial visit photo. You can see the occlusal plane is not very good. The chief complaint was the severe fracture of existing PFM prosthesis causing discomfort in both jaws. RPDs. Occlusal view. Immediately after all the upper and lower residual teeth were extracted, dentures were delivered immediately 2 weeks after the extraction. Now the soft tissue is healing properly. Using the existing patient's the vertical dimension and the positions, immediate dentures were designed, which were delivered after extraction. The bite taken for denture fabrication was based on the residual teeth of the patient. After the immediate delivery of the dentures and after the CR guidance of the mandible, a huge COCR discrepancy was observed. When RPDs or prostheses are poorly fabricated, at times, restorations are deviated from the CR position. For long-term stability of the final prosthesis, they should be designed based on a stable CR position. So after CR guidance, the final prosthesis were designed based on that position. Using digital approach, they can have better visibility and can be made much easier. You can see the delivered denture based on the existing patient's bite and the CR guided mandible. Even with the CR guidance pushing back the mandible, we are not sure if the CR is accurate. So CT should be taken to check the condyle position. To do so, a large FOV CT image was taken and the condyle is in a stable position. The position was confirmed as the CR position. Based on the bite and VD, final prostheses were designed and the guided implant surgery was planned based on that position. As you can see, the facial scan and denture scans using the existing dentures that the patient used were made. resin markers were attached to the dentures for merging. This way, for Edentulous patients, much more stable VD and CR can be transferred. Now they are merged pretty well. Then the prosthetic restorations were completed. In today's live surgery, implants will be placed in the mandible first, and the upper implants will be placed later. The mandible implant placement plan, number 37, has a very limited distance to the canal, so 5 by 7 millimeter implants will be placed. A safe distance of 2 millimeters to the canal requires vertical bone augmentation, so the top of the 7 millimeter implants will be exposed. On the panorama, you can see severe vertical bone resorption in the lower left posterior region, requiring some vertical ridge augmentation for the proper shape and length of prosthesis. The same 5 by 7 millimeter implant for number 36, the same plan for number 34 and 33. Number 43 and 44 implants were planned at number 43. It has severe horizontal bone resorption, so the ridge is very narrow, so 3.5 by 11.5 millimeter implant was planned. The guide design, it will be anchored with 4 pins, as the guide was designed with inverted denture image. Number 46 abutment tooth was not registered. So a vertical anchor at number 7 is designed to maximize the guide stability. As the prefabricated prosthesis will be mounted immediately post-op, for guide stability, 4 anchors are designed. This is after the soft tissue healing. The frontal view shows the severe bone resorption on the left compared to the right side. The lateral views show it more clearly. If we place implants in this condition based on bone, the final prosthesis for the left side will be very long. The right upper posterior region also has vertical bone resorption requiring a long prosthesis, so some vertical bone augmentation is planned for implant placement. This shows the benefits of using guided surgery. Prosthetic design can be performed in advance, showing the final prosthetic forms to determine if bone augmentation is required or not for implant placement. So implants will be placed at number 36 and 37 with vertical bone augmentation. Before surgery, let me summarize the surgical plan. First, a total of 6 implants will be placed using a OneGuide template. At number 36 and 37, vertical bone augmentation is planned using Builder, the 3-dimensional freeform customized titanium mesh. Then, the number 3 and 4 implants, transfer abutments, and a prefabricated 10-unit PMA bridge will be connected up to number 5 for restorations. At number 47, then an implant cannot be placed as an anchor will be placed. Number 47 implant will be additionally placed as free end after removing the template and finishing the surgery. Thank you.
Dr. Kim, can you hear me? Yes. I look forward to your surgery. Nice to meet you. As mentioned, I'll proceed with surgery. Soft tissue healing is nicely done, and guide will be positioned. Guide fixation is most important. In the case of full arch, I think this is most important. The order of fixation is I start with the middle and with drilling. You can prevent the tilting of the guide. lateral anchor pin is used, and you have started with the middle one, full arch case. This is almost a full arch case. So guide the pin, anchor screw position would be very important. Lateral anchors are placed to prevent deviation. Dr. Kim is holding it tight, and from the middle, drilling is done. Anchor screw is now placed. The first anchor screw, if you go in fully, then it can drift. So I only put in 80 to 90% first. So the quadrant 4. And if you fixate only one side, there can be tilting on the right side. So I prefer the zigzag fixation method. I think 3 will suffice, but I added 1 more to the design. In OneGuide kit, there's a 3 anchor screw optionally if you can design it further. Anchor screws are not fully fixated. It's about 70 to 80%. In zigzag manner, it's being fixed. So the most important in a full arch case is lateral anchor screw. In quadrant 4, there's 1 implant. In number 3 and 4, regular hole. So I'm going to do drilling. Initial drill is going to be used first. So Dr. Kim is starting with quadrant 4. In the lower, I don't think overriding mucosa is not that thick. So it has not been that long since extraction. And here, transfer abutment will be placed later. So tissue punch is not used. Initial drilling is done first. If the soft tissue is thick, tissue punch is essential, but in this case, the soft tissue is not thick. So initial drilling is done. Subcrestally, the implant needs to be placed, so flattening drill is most important for initial drilling. Flattening drill is used. For these cases, initial drill, flattening drill, so we are considering adding blade to initial drill, so I think it will be improved. Flattening drill, if you use it, at times bone chips can get in the way. The bone debris, if you remove it, then the cutting power will be improved. Initial drilling will be done full depths. So before flattening drill, initial drill did not go in fully in number 43. 44, initial drilling. Using OneGuide drill, you need to do full length of drilling up to the stop. The bone quality is very good. So 3.5 by 10 millimeter drilling is done. Final drilling is done. 3.5 by 10 millimeter drilling. And when you use OneGuide at times, so some people are concerned about bone heating because cutting power is good, and when you do pumping action, the bone heating rarely occurs. In number 44, 4.5 by 10 millimeter. So you doing 3.5 by 10 millimeter. Say out, please. Number 44. Number 34. 4.5 by 10 millimeter. 4.5 by 10 millimeter is planned, so 3.5 by 10 millimeter drill is used to do 43. In number 33 is extraction socket, so the implant was placed deep. 3.5 by 11.5 is planned in 33, so it's slightly longer drill. So number 3 and 3 drilling is complete, and in number 43, bone quality seems very good. So in this case, OneGuide drilling protocol is one size oversized drilling. I don't think it would be good to do full length drilling. 4.0 by 7. I'm going to do countersinking style. So I think this is based off a lot of good experience because the bone quality is good in number 43 to do for over drilling. So 4.0 is used, but full length is not done. And I always look at the bone debris that is that is stuck in the drill to make a determination. 43, 4.5 by 10 millimeter drilling. So drilling is done in all number 4s. Implants will now be placed. Osteotomy is now done. In full arch case, anchor screw, if you place it accurately, you have done it really rapidly. Perhaps preparations are complete. As Professor Kim has mentioned, a lot of people are concerned about the heating, so the assistant continues on with irrigation. 3.5 by 11.5, number 33. So it is placed about 70 to 80% using engine. Hand wrench is used to get the final position of the implant. So it's over 30 newtons, so the stability seems very good. Non-hex transfer abutment has been planned. So for long-term prognosis, the hex positioning is going to be done like this. Implant hex is adjusted and depth control is done as well. Number 43. You can use an implant anchor, but you can use an implant driver to have it serve as anchor. In number 33, implant driver is used like a vertical anchor. Implant position. The primary stability seems very good. Hex positioning and depth control is done. It can serve as vertical anchor using the implant. So implant placed in number 34, 4.5 by 10 millimeter implant. It is placed about 70-80% using engine. Implant driver is placed and hand wrench is used to get final positions. Primary stability seems quite favorable. Number 44, 4.5 by 10 millimeter implant. The 4 implants are almost placed. It's been about 10 minutes into the surgery. Primary stability looks good here as well. I think it will be okay for immediate loading. The antagonists are good. The upper arch is full denture. Number 6 and 7 drilling will be done and implants will be placed. Number 36 and 37, the guide hole is wide. 5.8. Regular gold-coated anodized initial drilling is done for wide hole. Initial drilling is done. Number 37, as shown, because tissue punch was not done, full length is not done. So in the lower, if there's basal bone quality could be good. Number 36. So in this case, a flattening drill is used to remove a overriding bone. Recently, there's the tendency to place the implant more deeply. Initial drill, combining initial drill and flattening drill, we're trying to come up with a prototype and trying it. And if we get good results, we will launch it. Number 36, initial drilling is done full length. Number 37, guide hole is wide hole. Initial drilling is complete. In patients with good bone quality, initial drilling can be tough, but you can see it's going in full length, or else it may be a bit difficult to place the implant to full length. The flattening drill has a shallow flute, so if there's bone debris, the cutting power goes down. You can see bone particles and debris. And if you remove them properly, then cutting power would be more favorable. Number 36. Initial drilling is done full depths. Number 37. Initial drilling. So it's very important that the initial drill goes in up to the stop. I have 3.5 by 7 millimeter drill. 3.5 by 7. Number 36, 3.5 by 7 millimeters. Number 37, 3.5 by 7 millimeters. Initial drilling is full length, so 7 millimeter drill. You can see that with no resistance, it's going in up to the stop. After 3.5, I think it'll be okay to skip to 5.0 by 7 millimeter drill. OneGuide drill has excellent cutting power, 3.5 and then 5.0. It will not be a major problem. Say ah. Number 37, 5.0 by 7 millimeter. The bone debris. It's quite hard. Especially in number 6, bone quality is excellent. So corticoid is going to be used. 5.0 drilling is done full length, and because there's a lot of bone, cortical drill is going to be used to remove cortical bone on the top. So 7mm implant is going to be placed. The cortical drill itself is used not in full length. 5.0 by 7mm implant is going in. It's placed about 80% using engine. Especially in the case the bone is so hard, if you use engine too much, it could cause problems. Number 37, 5.0 by 7mm implant is placed. Implant driver is connected. Say ah. Hand wrench is used to get final position. Countersinking taper cortical drill was used, but the primary stability seems good. Primary stability seems favorable. So now number 37. The number 7, the torque seems quite significant. So I think countersinking may be necessary. Because the bone is quite hard, so Dr. Kim has made a rapid decision. If the torque is excessive, there can be compression. As of late, a taper type implant is used. And if there's excessive torque at the end, the final torque can go up. When you do guided surgery, at times, so you're confounded. These situations are most confounding. So you use your hand tactile sense to remove the implant and do over preparation using cortical drill. So wide hole is 5.0 as option. There's 5.5 drill. So cortical drill is used. In the case of wide hole is 5.8. So you can drill up to 5.5. A cortical drill is used for number 37. The bone for number 37 seems quite hard because the perio was not really good. The bone, surrounding bone may be a bit condensed. So it's placed about 80% using engine, and it's adjusted using hand wrench. The stability seems much better. So previously, the torque seemed quite excessive. Because Dr. Kim has a lot of experience, he made a rapid decision to remove it and place it again. So for vertical GBR, I considered open flap surgery, but that would lead to less stability of the guide. So I decided to use os builder. So soft tissue defect would not be a problem. I decided that. So 6 implants have been placed. It's been about 20 minutes. And 6 implants were placed, and the screws are now being removed. You can see the bone is quite hard, and even when removing lateral anchors, and it seems there's significant torque. So I tend to use my hand rather than using handpiece because I might drop it. If the bone quality is not good, the anchor screw comes out easily, but it seems that anchor screw itself does not come out easily. Implants have been placed as planned. First, as mentioned on this side, vertical augmentation GBR will be done. Number 36 and 37 area, vertical augmentation will be done using Ossbuilder. Incision is now being made. Number 36, I don't think there will be a lot of exposure. Incision is made only up to distal to number 36. Ossbuilder is used in number 37, so vertical releasing incision is made distal to number 37. Number 36 is not exposed significantly, but in number 37, it does require vertical bone augmentation. Number 37, it's not been long since extraction was done. Are you in pain? No. So it's been recent. The extraction was done recently, so soft tissue elevation is not done cleanly, and there's a bit of granulation tissue when doing releasing, or it's not done not easily. It is best to use a blade. If you damage the periosteum, then it can negatively affect regeneration. So there is a releasing tissue. We need to minimize damage to the periosteum. You need to use sharp blade to do dissection. Number 6, as planned, 7mm implant was placed slightly deeply. Number 7. If you look over here in number 7, biologic width, and considering prosthesis, I think we need to increase vertical augmentation may be needed. The plan was about 1mm, so I think there's not that much bone augmentation. We can just do simple augmentation and that'll suffice. Distal to the number 37, there is a bit of exposure, but it does not seem significant. The autogenous bone. If you can harvest autogenous bone, it's best for vertical bone augmentation, especially in the upper area. You can get autogenous bone graft from buccal shelf, and you're using autobone collector. Distal to the number 37 implant autobone collector, there's a cap, so you can control the depths and you can get sufficient amount of bone. Using autobone collector, the harvested autogenous bone is here because vertical bone augmentation is done. Rather than using bovine bone, autogenous bone is being harvested on the buccal side. Increase handpiece torque. The RPM, it's about 500 RPM. auto bone collector, as you can see, when the bone chips are gained, there's a hat. You can get it more easily. Even with one use, you can get a lot of bone chips, 3 to 3.5 of ramus. So even if you do full depth drilling, it's at 3.6 millimeters. So you don't need to worry about bleeding from bone marrow.
Autobone is harvested from the same surgical site. Autobone is easily harvested. So a bone collector is used 2 times. So autobone collector has been used 2 times, and autobone is harvested. And that it should be raised vertically for length and contour of prosthesis. Os builder is to be used. Is 2 millimeter anchor, so that over contouring can be achieved in the mandible, in the posterior region. Bone augmentation easy because the lingually the flap advancement can be made. Mild high reach, so lingual flap can be extended in the coronal side. So you don't need to cut the periosteum. So the lingual side can be pulled and it can be sutured. If necessary, the periosteal releasing incision can be made on the lingual side, so the flap in the lingual side is sufficiently released. At number 6, healing is to be connected. For immediate loading, number 6 and 7 will not be involved for that. Tissue punch is used, and healing abutment is connected to number 6. As you know, the screw connecting the anchor for the os builder is 0.9 millimeter hexa driver. Did you mix autobone and with others? No, just autobone only. The bone regeneration needs to be made quickly. So below the os builder, give me AOS. So at the bottom, where implant is touching the host bone, autogenous bone is used, and over it, by layer, it can be said a layer graft or sandwich graft, and bovine bone is covering over the site. The AOS is covering the site for the maintenance of the space. Os builder. Autobone is the best for bone regeneration, so implant the surface and below the host bone, the collected autobone is used, and over it, bovine bone AOS is used, and os builder is used. So there's a wing in the lingual side, and the cover cap is being tightened. 2mm anchor screw is used, and os builder can be rotated when it is fixated. The cover screw is used over the os builder to cover the site. And when you tighten the screw, os builder can rotate. So Dr. Kim is holding the position so that a final tightening can be done. When os builder is used for the implant, the titanium mesh is very favorable in this case. To prevent exposure, collagen membrane can cover the site below the titanium mesh, so the periosteum can have a very thin thickness. So OneGuide collagen membrane is used, placed over it. The titanium mesh is constituting the os builder. It is not a barrier membrane, so collagen membrane is placed. And the extraction socket also needs the coverage, and if it is sutured, the accidental exposure can be prevented. At number 36, it looks okay. Number 37, using autobone collector, the autogenous bone was harvested and exposed on implant and host bone are addressed. The autogenous bone is placed over the implant, and over it, the synthetic bone is placed. The flap is not raised, so it is not punched site. This is a drilled site, so healing abutments are connected in that site. So a buccal flap is not really released. If it is released significantly, it will be weak in the vestibule side. FGG or keratinized gingiva augmentation can be done in the secondary surgery. So the site is submerged. So lingual flap can be released, and there will be no problem with the primary closure. The lingual flap is released, so without the periosteal releasing, the soft tissue wouldn't pose any problems. Without raising a flap, using drilling, the soft tissue at the top, some of them disappeared, but I don't think that poses any problems. Surgery is being finished, so I will finish suturing, and the provisional also will be connected, and the site will be checked. So he conducted the surgery very fast, no constraint of time. It's almost done. Just a little bit more. So the surgery is almost complete. In the lower posterior region, a lingual flap advancement can be used that will reduce membrane exposure, and you can do it rather comfortably at that site. As you can see, that we didn't open the flap in advance. hardly there was any vertical. So there was some concern about Ossbuilder exposure on the chat. So if there is no tension, I don't believe Ossbuilder will be exposed that much. Suction. So the posterior flap is almost closed. And abutments are to be connected. Number 33. And I believe you prepared the transfer abutments for that site. Non-hex. So after cementation, that's for easy retrievability, so we didn't have to match the hex parts. Number 33 and 34. 43. Number 43, non-hex is prepared. This is not the final abutment. So this is for temporary use. For a guided surgery, as you can see, we can make it all in parallel. So that's a plus of using a guided surgery. So they fit very well as planned. And would you close your molars? And the occlusion is excellent. So the surgery is excellently finished. Please give him a big hand. Thank you, Dr. Kim. That was excellent surgery. And 6 implants are placed. And orthobone collector harvested some bone. And Ossbuilder is used for vertical augmentation, and temporaries can be attached later. Let's go to Q&A. You can see the vertical augmentation. It's a very good occlusion, and there's a denture in the maxillary, and I don't think there's any problem. 33, 34, and the 4 implants are used for immediate loading with the temporaries. So thank you for the wonderful surgery, and you finished within time. And let's go to Q&A session. Dr. Kim, are you ready? I believe he is moving. We open the floor for questions. Any questions? So Dr. Kim is with us. Please give him a big hand again. So he finished placing 6 implants, including augmentation, in just over 40 minutes. If no questions, we have many questions on live chat. As you mentioned during surgery, if you use guide surgery and even using irrigation, some are concerned about the heating. So that's the concern I always use, even with the guided surgery. For guided surgery, I try to use the saline stored in a refrigerator. So when I switch it to another drill, the guide hole is used for holding by my assistant. And we can estimate the bone quality for drilling. I don't increase the length immediately for the one bone, so the length is incrementally increased. That is the know-how. And I believe that is answered. So in the lab of Osstem implant, when pumping action is made, and cell line is inserted into the drill hole, and on the live chat, Janice ID said at number 36 and 37, keratinized tissue doesn't seem to be sufficient when you use a flap lid surgery. How do you handle the disappearance of the keratinized gingiva? So I'm not as skillful as a Dr. One who did the live surgery in the morning. I do one thing at a time. I make bone first, and in the secondary surgery, I use that opportunity to gain keratinize the gingiva. You can open a flap, but keratinize the gingiva is lacking from the beginning. Then the keratinized gingiva would be lacking later as well. So keratinized gingiva increase is also devised. So during surgery, as you've seen, in the lower posterior region, the lingual flap elevation was made with releasing. So some people are concerned about bleeding and lingual nerve damage. What's your tip for that? Dr. Picos said about this. So if you can open the flap widely, mylohyoid muscle attachment needs to be detached. So lingual vestibule can be elevated sufficiently for easy adaptation. And if I use instrument, the curved the blunt part can be used to follow the mandibular contour. I believe the nerve is located 8 millimeters from the mandible. The damage to lingual nerve is not a big concern that you need to consider. To be safe, as you said, the periosteum on the lingual side needs to be maintained, and that will alleviate your concern. And the idea is, 즐겁게 살자 said, what is the instrument that you used in the mandible at the center? That is to increase the visibility. I believe I bought through Osstem. If you look at the retractor catalog, you will be able to find that instrument. You don't remember the name of the instrument, right? I don't remember. Do you have any questions from the floor? Post-op X-rays. Do you have the post-op X-ray? Any questions from the floor? From Dankook University, a dental school. My name is Dr. Song. Thank you very much for wonderful surgery that you performed. I am a prosthodontist, and when I do guided surgery for immediate loading, temporary, there are milled temporaries that I use. Even guided surgery is accurate. The head part of the abutment, sometimes it is cut in the head, and during surgery, sometimes it is harder to grind it. How much gap do you provide? If the gap is too big, it will affect adversely the shape. Dr. Song, a very good question. And I believe you know how it was prepared. Cement space after immediate loading, and if you use provisional, for immediate loading. 0.3 millimeter cement space is provided in this patient. 0.5 millimeter cement space should be provided. That's a request I sent to a lab. And in the anterior, the angular tilted anterior region, cement space is provided, but still the fit would not be very good. In that case, the relining would be necessary, inevitably. So just one more question from the live chat. Alice Well asked, Os Builder, is it adapted to the surgical site, or how do you choose and adapt the Os Builder? For guided surgery, the implant exposure and visual width required should be considered in advance. When you raise a flap, you can see it inside, and I don't like to add bending, but depending on a given condition, proximal wing can be cut off using scissors because Os Builder is connected to implant three-dimensional. It is designed that way, and if bending is provided, the line angle can cause some exposure. So I don't like the bending, but the trimming is something I can use. Os Builder itself has a three-dimensional form, so bending should not be done at the bottom to reduce the exposure. And Dr. Kim covered the site with the collagen membrane, so there's no risk of exposure. Do we have post-OP X-ray? CT is being taken, but I can show you panorama. So due to constraint, that will be shown later. Dr. Kim, thank you for the wonderful surgery. Please give him a big hand. So due to constraint of time, this concludes the live surgery, and after discussion, post-OP X-rays or images will be shown. Panorama review will be conducted after the discussion session, and we will have time for the review. And Dr. Kim Yong-jin and the moderator, Chair Dr. Kim Kyung-jin, please give them a big hand. So the surgery just finished. Let's have a break. So we will have a break up to 4:40. Many people are waiting for the lucky draw. And please stay with us until the end to get some prizes. Thank you.
Have you ever experienced the pressure of reoperation because of prosthetic issues such as screw or abutment fracture? Introduce ESR kit designed to solve a variety of prosthetic issues. In case of screw fracture occurs, the fractured screw can be removed by using ESR kit. Connect the SR drill with the fractured screw. After making a hole for drilling on the fractured screw, turn the SR tip counterclockwise and remove the fractured screw. Also, after using the reverse drill, connect the screw holder on the fractured screw. Then, turn the screw holder counterclockwise to remove the fractured screw. In addition to screw fracture, the ESR kit can be used for removing the fractured abutment, repairing damaged thread of implant and screw hex slip. Try ESR kit designed to solve a variety of prosthetic issues. Smart Guide Kit allows clinicians to fabricate a surgical guide without CT scan. Smart Guide is made of thermoplastic resin. Dipping the Smart Guide in the 70 degrees Celsius water for 1 minute. Then, clinicians are able to manipulate the shape of the guide as they desired. When the Smart Guide is shape-shiftable, it is able to extend or reduce its size up to 1 millimeter when the guide pin is connected. Among 4 different types of 3D guides, clinicians are able to select suitable one for clinical case. Also, the Smart Guide enables to maintain the precise drilling path with 7 millimeter sleeves. Smart Guide Kit allows clinicians to fabricate a surgical guide without CT scan. For your implant placement, try Smart Guide Kit now. Have you ever experienced difficulties in finding a right spot for implant placement? Positioning Guide Kit enables clinicians to find both right spot and direction for placing implant without using a surgical stand. Positioning Guide Kit contains both single guides and bridge guides, so clinicians are able to deal with different clinical cases. The single guide is transparent and cylindrical, comes with a diameter of 5 to 10 millimeter. Clinicians are able to put a single guide next to another single guide or close to an adjacent tooth for drilling. The single guide helps clinicians to pinpoint the spot for placement and direction of the implant. The fan-shaped bridge guide enables clinicians to adjust interval from 7 mm up to 12.5 mm. Bridge guide allows clinicians to adjust the interval by the margin of 0.5 mm and to drill toward the same direction as previously drilled site with convenience. Positioning Guide Kit enables clinicians to find both right spot and direction for placing implant without using a surgical stand. Introducing OneFit Abutment, custom-designed abutment by Osstem Implant. OneFit Abutment has the basic titanium abutment as well as gold-colored titanium-coated abutment for production of aesthetic zirconia and ceramic prosthesis. Manufacturing request is simple and convenient with 3 options of impression body, intraoral scan, and design file through an online order system. The product offers various design options for customization based on patient oral cavity and implant placement conditions. Try OneFit Abutment, custom-designed abutment by Osstem Implant. Introducing the Trios 4, an intraoral scanner which scans and digitally replicates the oral cavity in 3 dimensions. The Trios 4 is extremely precise and offers fast scanning. It automatically eliminates unnecessary areas such as lips and cheeks during the scanning using the AI scanning function. Even the novice users can scan quick and easy. The Trios 4 is an integrated wired and wireless scanner. It is easily used wirelessly at large dental clinics. If the battery runs out, clinicians can continue using the Trios 4 by plugging in its power cable. The Trios 4 helps diagnose dental caries with its fluorescent scanning function. Also, the clinicians can track changes with dental caries over time. The Trios 4 can record patients' occlusal movement. The patient-specific motion function allows clinicians to record occlusion according to the movement of the patient's temporomandibular joint. Experience the Trios 4. It can be used in a variety of treatments. Great unit chairs designed for dental treatment must be convenient for the clinicians to use, feel comfortable for the patient during treatment, and they should also be easy to clean and maintain. I would like to introduce K5. It's both a stylish and convenient unit chair. In case the backrest tilts downwards, the leg rest goes up. The tilting function prevents the patients from slipping down. It is convenient for the clinicians to carry out treatments and provide comfort for the patients to receive treatments. The K5 also has a wireless foot controller designed to offer an even more convenient treatment experience for the clinicians. Handpiece RPM can be easily adjusted by turning the foot pedal left and right, making treatment. The sterile water supply device suppresses formation of bacteria and biofilm in the water line of the unit chair. Always using clean water during treatment makes it much easier to reduce the risk of infections. Let's go over K5's key features again. The patient does not slip downwards thanks to the tilting function. When the backrest tilts downwards, the leg rest goes up. Second, the wireless foot controller makes treatment much more convenient for the clinician. Third, DWCS suppresses bacteria in water line to supply only clean water during treatment. Try the K5, a unit chair designed to add both convenience for the dentist and comfort for the patient. Introducing the SM5, the dental implant surgery engine that provides safe surgery with its accurate torque value and drilling ability. First of all, SM5 provides accurate drilling result thanks to its outstanding chucking force. The implant can be safely placed since the implant is firmly fixed, minimizing unstable vibrations. Moreover, the torque value and rotation speed can be checked with ease on the LCD panel during the surgery. Try the SM5, the surgery engine that has outstanding chucking force and that displays the torque value and rotation speed during surgery. Introducing the upgraded T2 Plus with superior high-resolution imaging, ultra-high-speed scanning, and ultra-low radiation dose feature. The T2 Plus has a 0.05 mm voxel size, which results in superior high-resolution images. This enables a more accurate diagnosis compared to the T2. With a T2 Plus, patient waiting times can be reduced thanks to a faster scanning speeds compared to the T2. Images are acquired in just 30 seconds. T2 Plus low radiation mode allows for safer scanning with only 22% of the radiation dosage compared to that of the T2. The low radiation mode allows scans for children and pregnant women without any concerns. The T2 Plus offers various field of view sizes for facial imaging, implants, TMJ, endodontic procedures, and more. The T2 Plus allows for customized scanning based on the treatment. The T2 Plus includes convenient and easy-to-use 1-2 software, 1-3, and VSEP. Through consultation, treatment and implant planning will help increase patient acceptance rates. T2 Plus is available in 3 colors: white, blue, and red. You can choose the color that best matches the ambience of your clinic. Introducing the upgraded T2 Plus with clearer images, shorter scanning times, and lower radiation dose. Introducing the N1 Portable X-ray, delivering high-quality imaging while being extremely easy and simple to use. A good portable X-ray should produce clear images. At 70 kV and 3 mA, the N1 produces clear standard X-ray images. Clear images relieve the clinician's stress during the diagnosis process. A A good portable X-ray should be easy to operate. The N1 is light at only 1.61 kilogram, which is 30% lighter than a camera-type device. Also, it has a gun-type design which is easy to operate with one hand. This ensures easy alignment and high accuracy when taking images. A good portable X-ray should have a long-lasting battery. With 15% improved battery performance, the N1 lasts for a week on a single charge, eliminating problems with other wireless X-ray units. The N1 reduces the inconvenience of a continuous charging, which helps improve clinical efficiency. The N1 is easy to use and produces clear images. With X-ray images alone, it can be very difficult to convince patients since X-ray images don't offer a complete picture of their oral health status. Fortunately, today's product can help you with this very problem. It's the Snap intraoral camera. One of the most important things you need to consider when choosing an intraoral camera is image quality. To help the dentist explain the condition of a patient's teeth and set the correct course of treatment, intraoral cameras need to take clear images inside the patient's mouth, even though it's very dark inside the mouth. Snap uses a 1.3 megapixel sensor, unlike other regular intraoral cameras that top out at 300,000 pixels. That's why it delivers clear HD images that can satisfy everyone. Another important thing of an intraoral camera, which has to take images as quickly as possible, is the focus function. Snap focuses in just 0.3 seconds when you press an image-taking button and snaps images automatically, which helps produce clear, in-focus images that accurately show the patient's intraoral condition. Some existing products do have an autofocus function, but they have two separate buttons, each for focusing and image-taking. However, Snap has a convenient 2-in-1 button. All you need to do is press the button once to capture fast and in-focus images of the patient's intraoral environment. And finally, an intraoral camera's head and neckline is very important since it has to take images from narrow spaces inside the mouth. Snap has a curved head and slim neckline that gives you a better angle for reaching the teeth when inserting into the mouth, which makes it easier to image not only wisdom teeth that are difficult to shoot, but also female patients and children who have small mouth. From the patient's perspective, this reduces any foreign body sensation and discomfort, while from the dentist's perspective, it reduces stress when imaging the posterior region and makes treatment easier. I was able to actually see which teeth require treatment, and that makes me have trust toward the dentist and left a better impression in my mind. I feel like I want to come back to this dentist in the future, and I'm going to recommend this clinic to my friends and family. Since I saw my teeth with my own eyes, I think I'd be more likely to consent to treatment without hesitating. Intraoral camera Snap helps accurately explain to patients the condition of their oral environment and creates a more credible and trustworthy impression of the dentist in the mind of patients. Introducing Osstem Implant's HySil PLUS. HySil Light Plus is excellent at reproducing fine areas. HySil Light Plus can reproduce 20 micrometer lines without any tears or distortion. The stone model poured from a HySil PLUS impression produces smooth surfaces and separates cleanly. Thus, the user can fabricate accurate and precise prosthetics. HySil PLUS is highly hydrophilic. HySil PLUS has a short intraoral setting time of 2 minutes and 30 seconds. HySil PLUS offers a sufficient working time of 3 minutes and 50 seconds.
Those who
HySil
are
PLUS has a
outside,
high
please,
elastic recovery
kindly move
ratio of
into the
96.5% or more. Experience HySil PLUS for accurate and precise impression taking. For successful implant surgery, it is important to use a membrane that facilitates creating new bone. Introducing Osstem. Osstem is a collagen membrane that offers outstanding shielding performance and nutrient permeability. These functions contribute to new bone formation. Osstem has a porous structure with cavities smaller than epithelial cells. It serves as a barrier to block epithelial tissue growth while new bone is formed. Therefore, it provides optimal space for the osteogenesis. Osstem also allows nutrients to pass through and facilitates the formation of new bone. Osstem comes in 2 types, hard and soft, as well as 4 different sizes. Thanks to its dual-sided use for all sizes, Osstem can be easily manipulated depending on the surgical sites. Try our Osstem that facilitates the formation of new bone and successful GBR. I would like to introduce SlowJect Plus. SlowJect Plus is an automatic anesthetic injection device that injects an anesthetic solution at a constant rate. SlowJect Plus has 3 buttons that allow the user to adjust injection rate from low speed to medium speed or high speed. You can also switch between auto and manual modes using SlowJect Plus's one-touch button system. SlowJect Plus only weighs 80 grams, which is similar to a regular syringe, and has a pen-type grip that makes it easier to use when repeated injections of anesthetics is needed. Try using the automatic anesthetic injection device, SlowJect Plus. Implant prostheses are prone to food infection. Food scrapes stuck between braces are difficult to remove. Removing food scrapes completely from your teeth can be extremely difficult. Use Wapic every day. Thin but powerful jets of water can clean spaces between your teeth thoroughly. You can select between 3 cleaning modes: clean, soft, and massage. You can select any water pressure that feels right for you. Thanks to the massive 320 milliliter water container, you don't have to refill the device with water while you're cleaning your teeth. 99.9% antibacterial silver ion filter keeps the inside of the water container bacteria-free. Once you've brushed your teeth, make sure to finish with Wapic.
임플란트 유명한 게 좋을까?
뭐가 달라도 다르겠죠.
임플란트 세계적인 게 좋을까?
뭐가 달라도 다르겠죠.
치과 의사에게 사랑받는 게 좋을까?
뭐가 달라도 다르겠죠.
오스템 임플란트!
Osstem meeting 2025 Seoul. We are adding heat. Now we are facing the last session. Before we begin, we are going to have a raffle. This is the big event that we're going to have. If you go into the dental site and apply, you'll be able to test your chances. 5 people will get the dental set, and 3 people will get the Beauty's White Light gel set, and the first prize winner will get iPhone 16 Pro. I hope you stay with us till the end. The winners will be announced after the ceremony. Now we will continue on with the final session. This closing session will feature a panel discussion where 3 distinguished speakers will engage in an in-depth conversation on a single core topic. So the topic is comprehensive solutions through an interdisciplinary approach in implant dentistry, and prosthodontic and orthodontic and periodontic professionals will discuss on this topic. First is Dr. Baek Eun-bong and Dr. Chang Dong-wook and Dr. Jo Young-jin will now appear on the stage. Please welcome them with a warm round of applause. Greetings. I am Dr. Jo Young-jin of Seoul, Furi Gipun Dental Clinic, the chair for the 2025 Osstem meeting discussion session. And I am honored that there are so many dentists watching on-site and online. I would like to extend my warm welcome. So the discussion's popularity continues to grow with strong support from dental community. And this shows there have been limited opportunities for practitioners to share real clinical concerns and issues. I am pleased that this session plays a valuable role in filling the gap. Now, let me introduce today's speakers. Greetings. Could you introduce yourselves briefly? I am Dr. Baek Eun-bong, who runs a Smile with Dental Clinic, and I am Dr. Chang Dong of Win Dental Clinic. Nice to meet you. Nice to meet you. This Osstem meeting is held under the theme Comprehensive Digital Dentistry to get a better prognosis. And today we'll discuss the importance of interdisciplinary collaboration strategies. So let me introduce a related journal. Interdisciplinary approach is used in the clinical field from diagnosis, surgery, and the prosthodontic part. It requires a field knowledge and experience of surgical, prosthodontic, and periodontic knowledge. We continue to face more complicated cases, and we need interdisciplinary approach to address these problems. Most practitioners are one-person dental clinics, and they have to serve multiple roles. I would like to share how interdisciplinary approach can help in cases where we can face in day-to-day lives. The contents of the day are shown. The speakers have different specialties, so we're going to look at the cases as we look deeper.
First, thank you very much for inviting me to this significant meeting. Osstem people and Chairman Jayeyoung and Dr. Baek Eun-bong is someone I respect very much, and my colleague. And Dr. Cho is my junior, but I learned a lot from him as well. This is my honor to be here. I majored in periodontology, and in Songbuk the word, I run a small orthodontic clinic. And if I introduce myself, I believe our profession is an extreme job. Sometimes we have to treat patients in a small cave. And let me introduce some cases of mine. This patient had the bilateral jaw treatment, and after extraction, the young patient need to have implant placement. 3 implants need to be placed. here, and rigid splitting is something I chose. That is to chop bone to place implants. So like a lumberjack, I need to chop the bone and then place implants, and then a bone graft should be done, and it is covered with a membrane. 4 months later, the second surgery was done, as you can see. Vestibule and characterized gingiva were formed, and the prosthesis was delivered. And this is the representative case of mine. And a bone is split. And let me show you one more case, a recent case. So another doctor referred that patient to me, thankfully. And her children actually paid for the her treatment to celebrate the son's wedding. And using the fixtures, the bonding technique was used to shorten the treatment time in time for the wedding. So I was thinking about the theme of this meeting, and I sometimes work together with Dr. Peck. I am a surgeon, so I try to solve all the problems with the surgery. And this is the patient, the spacing in the upper anterior, and there's a caries. As you can see, the patient has gap between the front teeth, and she says the money is lost, maybe because of this hole. So patient-oriented implant placement, and the gap needs to be closed. There's an orthodontist here with us, but I try to place the implants palatally as much as possible through surgery. Before and after using the implants, the spacing was addressed. It's not ortho treatment, but the space was closed. And if I look at all the cases, many difficult cases are sent by other doctors, some beyond imagination. And there are many dentists who want to increase my capability by giving me this challenging case. The reach is very thin, so there's no way that I can address the problem, but I cannot refuse refer the patient. The patient in the 60s and has been wearing denture from the 50s, and I promised the patient to improve the face. And class 3 is something we see. The mandibular protrusion is to be made. So using a titanium mesh, broad bone augmentation was done. So sometimes I feel like I'm a farmer who is engaged in horticulture by building the greenhouse. So membrane was covering the site, and it was sutured. Fortunately, the surgery was successful. And during 6-month healing period, CTs were taken, and based on the data, Osstem OneGuide was used to perform the surgery. Luckily, when the flap was raised, the hard tissue was very well formed and the volume is abundant. And luckily, there are some teeth in quadrant 2, and then with the retention from the teeth, the OneGuide was applied. So unlike from the initial plan, number 13 was a plan for implant placement, but it is close to nasal cavity. So the positions of implants were changed like this, and they were properly positioned. And I wanted to make a palatal hole in the prosthesis, so they were placed and submerged. After the surgery, you can see implants were properly placed. At the time of the second surgery, vestibule depth and keratinized tissue were to be addressed. So at number 23, FGG was performed. For about 1 week later, skin abutments were connected, and 3-shape trios was used. ultimately, recently, temporaries were delivered, and in the process, after the scanning, provisional had some unfitting, ill-fitting pontic. So it took less than 30 minutes to mount the temporaries, and digital dentistry helped us a lot. I don't know much about orthodontics, so I try to resolve problems with the surgery as much as possible. So you two collaborate with each other using. We will look at the case. So you are very good at using knife as surgeon, and you address the problem very easily with the surgery. Let me introduce myself. I am Dr. Jayeyoung. I'm moderating this session. I am a prosthodontist. For implant treatment and prosthodontic treatment, I feel comfortable, but we don't have many good cases. In many cases, we need help from other departments, and I work alone in my clinic. But when perio or ortho treatments are required, a simple ortho intervention is provided by myself.
So I tried to do interdisciplinary approach. Let me introduce you a case. This patient is in early 40s. And in quadrant 2, posterior treatment was required. And if you take a look, if you just use a prosthodontic or implant treatment, the remaining space seemed quite odd. Number 22 implant was placed a long time ago, and provisional was there, but the treatment did not continue, and without moving the teeth, it required further adjustment. In the area, implants were planned here, but we had to gain more space to do that. And this is a sleeve and open coil sleeve in between number 3 and 6. It was applied, and if you activate it using springs, the space could be secured. With gradual increase of space, the coil was replaced, and once the space for implant placement can be secured, the implant placement can be done from the side using this appliance. A space for implant placement was secured, and mesial to number 3, the space is being closed after a series of these treatment in premolar area. The implant prosthesis was made like this, and in a conventional way, implant prosthodontic treatment was completed as shown.
Before and after the treatment, the target teeth, the 2 teeth, were moved a little bit for easy and successful long-term implant prosthetic treatment. Before and after X-rays, the narrow spaces existed, but enough spaces were provided for implant treatment. For implant or prosthodontic treatment, even though you do not provide orthotherapy without the brackets, we can use these 2 devices, sleeves and mini tube appliances. And as we do not use brackets, the entry hurdle is rather low, and we don't have ideal site before we provide the implant restoration. Perio, ortho, and other therapies should be done for site preparation, and orthodontic treatment is something we absolutely need. So horizontal or vertical movement of target teeth is required for preparation of implant restoration. That's why I include the ortho treatment in my treatment. But if it is more complicated, I need to refer the case to a specialist, Dr. Peck.
So I run a Smile with an orthodontic clinic, and so I work across the street from Dr. Chung. And we always say, go to the dental clinic across the street. I majored in maxillofacial surgery, and then I learned about orthodontics, and I only currently provide orthodontic treatment. In providing comprehensive interdisciplinary strategies, there are simple and complicated cases. Simple cases you can do by yourself, even if you have not majored in orthodontics. And for complicated cases, you need to refer to a specialist. This is a simple case, forced eruption. In the fractured teeth, you do not need to extract it. You can erupt it and then add post and provide prosthesis. On the other hand, there are many cases where the posterior molars are missing, and there can be screws to prevent the upper molars going down. You need to place the screws not only on the buccal but on the palatal side. This treatment is not very difficult. You just need to add screws. Even if you're not a major orthodontist, you can provide treatment, and this is quite beneficial for the patient. What is important is that when the tooth moves, the alveolar bone, you wonder whether it's going to come together or the tooth alone will move. According to Salama, who is very famous, if there's root rest, it's hopeless. You need to do extraction rather than just doing extraction. Maybe you can do forced eruption. The hard and soft tissue can be pulled at the same time. If you look at orthodontic textbook Profit, when teeth erupt or are moved, they bring alveolar bone with them. If you look at my patient in number 38, there was no antagonist. So eruption occurs. And not only the tooth, but alveolar bone, like a volcano, has come up. It's very noticeable. If you look at the patient on the left, the gingival level is not aligned. If you remove a temporary and do forced eruption, alveolar bone followed and gingiva followed. Therefore, aesthetic result was achieved. On the right side, I suggested it to the patient, but they did not accept it. The patient does not accept 100%. They have their own thoughts, but they do not tend to have good results. So this is a prosthesis not provided by myself, but it's very difficult to get aesthetic results with this. Complex cases, you need to refer to a specialist. Molar protection and third molar will be addressed. The lower number 6, both of them are missing. I pulled the number 7 and 8 to close the space using molar torsion. Number 7 and 8 look like number 6 and 7. The teeth parallel movement is very important. After 11 years, it looks very stable. And earlier, it was in 2012. In AJODO, this was case of the month, and this, if you take a look at this literature, number 8 is horizontally impacted and is close to the nerve. If you extract number 8, no matter how skilled you are, there's still a risk of nerve injury. If you do molar protection of number 7 and you pull number 8 using orthodontic forces, alveolar bone can be formed nicely and occlusion can be improved. So this patient on the left, quadrant 3, endo treatment was done, but the pus continued to come out. So I recommended pulling teeth. So we tried to pull 2 teeth. Parallel pulling was attempted, and we pulled the number 7 and 8. Looked like number 6 and 7. In the upper, such treatment is possible. Number 6, once extracted, the sinus pneumatization can be a problem in the upper. So if you pull using orthodontic forces, the alveolar bone comes along with it, so sinus problems can be avoided. On the right, on the other hand, number 6, it was not it was pulled. Sinus problems can be reduced, and it's very easy to do implant in number 7. And after 12 years, even without sinus graft, it was nicely maintained. It was without sinus graft. The patient came in with pain in third molar. We see these kind of patients very frequently. It's not a problem with the third molar, but it's number 7. Number 7 endodontic treatment was done, so pain is gone. how should we proceed? The number 8 needs to be extracted, and in number 7, crown endo needs to be done because there's distal. It's difficult to provide prosthesis, and these kind of results can come to be. In this case, number 7, why not extract it? And if we pull on number 8, it's quite difficult. If you pull on it, it's possible, as shown on the right. No, upper number 7 and lower 7 was extracted and 8 was pulled, and upper 7 was easy. In most cases, they just come out, and in the lower, it's a bit more difficult, but it's still not impossible. If you upright the number 8, alveolar bone and the parallelism can be achieved. The cases that I've completed is about 420, and 97% or so of success rate was achieved.
So the ortho cases are very interesting, which is beyond the normal scope of orthodontics that we imagine. And your cases have been published by AJO, so not only me, but Americans also agree with me. So another case, and this is the case introduced and included in the text message for survey. A 58-year-old female. In the Ceph, the anterior protraction is observed, and spacing. There's a spacing and the perio problem and the flaring. The arch is wide, but the tooth size is small. A panorama. There's a missing area in the posterior region, and the flaring spacing in the anterior region, and hard to chew, and discomfort were the chief complaint. What treatment plan would you create for this difficult case? There can be many options, and if you look at this case, what is the treatment option that you are thinking about? So, Dr. Chang, what do you think? Treatment plan can vary from dentist to dentist depending on individual's philosophy. But in general, let me present some of the options. First, overall, the perio condition is poor, so this may be rather aggressive, but full mouth extraction is made for full mouth implant restoration. And number 2 option is that the implant and the prosthodontic treatments are used together, and the implant restoration is more focused, and the hopeless tooth and the mobile teeth are extracted to solve the problem with implants. So many implants are used here. And the third option is focusing on prosthodontics, and a small number of implants are used. That's the option 3. For cross-arch stabilization, the stabilization is used. This is more conventional option. Prosthodontic approach is used only without using implants. So there are 4 options, and you already saw this, and I believe you voted on this. I wonder what the result is, but even though you are curious about the result, we will talk about this at the end. If you have not voted on this, please participate in the survey. So these 4 options, maybe you have other options in mind, but please choose something very close to your option, and please imagine the treatment option that you would like to pursue. Going to the main topic, interdisciplinary approaches. Let's have a look at the cases. As far as I know, Dr. Cho majored in prosthodontics, but he is a very good surgeon, and I believe he has many skills. And sometimes, actually, he doesn't cause any bleeding when he does surgery, so I call him Dracula sometimes as a joke. So I run my clinic alone, So at the outskirts of Seoul, so I don't have very good interdisciplinary partners. So I provide interdisciplinary approaches by myself. So one or two teeth are moved, the orthodontic intervention for implant or prosthodontic therapy. So if you look at these cases, the implant treatment they cannot achieve a very good results. Vertical, horizontal spaces are lacking in many cases. Of course, due to the problem of time, I address the problem on the prosthodontics only. So due to secondary caries, the crowns fell off, number 35 and 37. The angles are not very good. On the one-piece conventional approach would not work. So two-piece prostheses were made separately. Hidden key and keyway were designed. So when they are attached, they were attached separately, but eventually they become one piece. So vitality of the teeth can be preserved. Sometimes I use this approach. Number 7 was uprighted before prosthodontics, and that can bring some good results. So for more ideal results, 1 or 2 teeth can be moved vertical and the horizontal problems can be addressed. Space loss of space can be regained during implant therapy. Horizontal problem. So commonly we meet this kind of problem clinically. So preventive molar uprighting, the spacing is created something like this. So sleeve and open coil spring can be used. This device can be inserted. So in a short period of time, the space can be made. And the space between premolars can be closed. And 5 years later, you can see it is very well maintained. If brackets is not something you are not very unfamiliar with, wire open coil spring brackets can be used for the same uprighting. This is a very simple approach that you can use for vertical problems. As Dr. Beck said, this is the forced eruption for number 11. There's a perio problem with the fistula. So regardless of the cause, the tooth should be extracted, but without extracting. And using the adjacent tooth, the forced eruption is applied, and the tooth was mobile, and the tooth can come down, reducing the pocket depth. And you can see the improvement. And the bone lost is being recovered. So after that, the tooth is extracted and an implant is placed, and the result is pretty good. And the bone loss healed pretty well during implant treatment. In my clinic or in other clinics, the treatment sometimes is being delayed, and implant is placed, and no space for the prosthesis because the distal tooth is tilting. So second surgery is done in the narrow space using screw-type temporary abutment. The temporary crown is provided. A channel is created, and sleeve and coil spring can be used. So without the concern for the unexpected movement of the adjacent tooth, the tooth can be moved as I wanted to place an implant and for the prosthesis. The smallest healing abutment is used for the second surgery, and then a temporary crown is made, and they move like 1 millimeter per month. So 1.5 millimeter space was created within 6 weeks, and the prosthesis was provided later. On the right-hand side, before treatment, the space was very narrow. After the treatment, enough space was created for prosthesis. So a couple of teeth can be moved in the desired direction and in the desired amount. So simple disciplinary approaches can be applied by yourself, and that this can be done if you're interested in there. But if it is of broader scope, but not just a couple of teeth, a secondary TFO or flaring alignment, poor alignment is observed, then we need to refer the patient to specialist. So Dr. Peck is going to introduce the interdisciplinary case.
This patient is a 45-year-old female patient. There's spacing on the anterior and there's flaring. If you take a look at the patient, said it wasn't like it originally. The origin was the perio. With worsened perio condition, there was bone loss in the posterior region, and the posterior stop was gone. A mesial drift occurred, and the vertical dimension decreased. The bite collapsed, and the lower anterior hit the upper anterior, so flaring occurred. This is chronic periodontitis. Patient's a typical case, so we need to treat the perio first. So we have to refer the patient to periodontics, and because the patient does not have posterior stop, we need to form it. So I worked with Dr. Chang on this patient's case. The implant placement position is better decided by the orthodontist. The way to do it is we need to close the space, and the anterior teeth goes back. It's slightly protruded. We need to calculate the amount that it goes back, and we need to calculate the amount of retraction of the canine. We need to, in quadrant 1 and 3, we need to retract the canine and premolars by 2 millimeters. And after implant placement, when prostheses are provided, if there is 2 millimeters of space in between, it'll be okay. In quadrant 4, I talked with the patient, and the original plan was to close off the space.
Okay, the patient was sent to me by Dr. Peck. So diagnosis included a perio disease, acute or chronic, moderate, severe. Classification was established in 1999, but this is the recent classification. So periodontitis, the generalized disease, local disease, generalized disease. The severity, complexity are the criteria for the classification. Based on that, I established a perio treatment plan. The overall goals, treatment goals on the left-hand side, treatment goals, those are the strategies that we can use to achieve the goals. And on the right-hand side, these are tactics that we use. Periotherapy, extraction of hopeless teeth, endotherapy, strategic tooth extraction, and implant therapy, maintenance therapy. So I evaluate the patient overall. In this case, rather than extracting teeth early, a perio treatment should be provided. So slowly, by consulting with the orthodontist, I provide the treatment. There is no posterior stop, so ortho cannot be done. So we began treatment in the first quadrant, and there's a small residual bone, and loading should be applied, and the provisionals were provided, and we had to take enough time. In quadrant 3, I placed the implants manually, not using a guide, and the positions of implants were normal. But I am a curious person, so I used the synthetic bone. Recently launched there. I don't know whether this was the cause, but after removing a suture about a month later, fistula developed, so I had to remove it. After enough healing period at current one, healing abutments were conducted, provisional also were provided. And after some time, number 37, implant was placed, and a little bit later, in the meantime, Dr. Peck provided ortho treatment.
The patient came back within 10 months, and deep bite treatment was necessary, and we can do rotate intrusion of the anterior or extrusion of the posterior. The posterior region, there needed to be prosthesis. We can add the temporary bite raising. Space was closed, and the retraction of anterior was done. Deep bite was improved.
So number 26 had caries. So prognosis was not very good for these teeth. After ortho treatment, the spaces need to be closed. But I had to extract the teeth, and residual bone was not sufficient for crystal approach. 1 millimeter of the bone was reduced, and you can see the Schneiderite membrane. So I wanted to finish the therapy quick. The crystal approach was used and raised about 10 millimeters, and implant was placed, and it healed pretty well. And post-op X-ray radio opacity is observed, and there was no perforation, and elevation was successful. About 7 weeks later, the implant tilted, and jokingly I asked the patient whether the patient was lying on the left-hand side, and the patient said exercise. So this kind of world heritage is observed in the implant, slanting. So this is how I treated. About 5.5 months later, ISQ was good, and provisional was provided, and I sent the patient back to Dr. Peck.
Orthodontic treatment was towards the completion stage. In quadrant 4, it widened. The patient received implant treatment. And because there was a tooth missing, the patient wanted to have tooth. And if the patient allowed time, we decided to place the implant. If this was incorporated in the original plan, the treatment period would have been reduced. However, I think if the opportunity arises and the patient wants it, we can do adjustments accordingly. And then for final restoration, I sent the patient to Dr. Chang.
And the patient changed the mind, and thankfully the patient came back to me at number 45. Implants was to be placed, and number 26 was checked, taking CT, and the sector view shows a very stable graft. The space was rather narrow, so the implant was placed, and after that, prostheses were delivered. And number 27, the root was short, and during chewing, the crown fractured. So I had to extract that, and one more implant was placed for the patient.
If you look at the overall flow, the patient was referred to. If you look at after significant treatment period, it looks quite stable. If you look at the treatment results, the conclusion looks nice. As mentioned before, digital orthodontics could be utilized. If we could use it Just like using guides for accurate implant placement, we will get better results. Dr. Beck, I heard you experienced some difficulties. Do you feel like something that you would have done better? Dr. Chang placed implants nicely. So when we provided provisionals, because ortho treatment period was extended, there was dislodgement and fractures. So once a bracket dislodges, the tooth continues to move. The tooth moves somewhere else than intended. So it was a bit of a problem and headache. And in doing interdisciplinary approaches, so we need to make the provisional harder and the bonding harder. That's something that I wondered on.
So when we work together, I feel more burdened because I don't. I want to give a patient in good condition to the partner. When we provide the provisional, and even though I try to attach the temporary provisional firmly, sometimes the patient chew on very hard stuff like almond, and the provisional falls off. But I did my best to attach the provisional as firm as possible. I'm a prosthodontist, and the custom abutment or stock abutment can be used to attach a PMMA. And you don't use the temporary as the final final prosthesis. So to save cost, the screw type PMMA can be fabricated. Resin can be thickened, so less fracture. So the block can be milled when it comes to the PMMA. So when orthotherapy is provided, that should be used not just a couple of months, but for years. If I knew about that, I could have saved some efforts. As a non-expert, the interdisciplinary partnership doesn't look easy, but with the development of clear aligners, ortho treatment can be provided much easier. So clear aligners, I believe you have interdisciplinary cooperation for the case.
This patient is a 54-year-old female patient. It's a very similar case. So there's anterior flaring and there's spacing. There's no teeth in the posterior region. Vertical posterior stop was absent and vertical dimension was reduced. The patient had to receive periodontal treatment, and the priority was to form a posterior stop. So I refer the patient to the Dr. Chang to create the posterior stop. Implants, when placed, the orthodontist needs to determine the position. That's my opinion. The way to improve it, by reducing the space, the anterior protrusion would be reduced. If the patient has no protrusion, that we need to stop, and the patient fell into this category. Number 3, in this patient, we need to make sure that it doesn't move AP. Number 44, there is space. We need to pull number 44 forward. In quadrant 4, we need to place the implant close and pull number 4 to secure appropriate space there.
So in this patient, the posterior teeth are lost, and regarding the implant placement positions, I received the guidance, and number 23, and there was hypersensitivity, and I told the patient that the crown may have to be remade. The patient had some panic syndrome before, and the patient has a lot of fears, so a conservative approach was used. So in accordance with the conventional approach, the therapy was provided. If I work with Dr. Park, I don't know why, but sinusitis occurred, and the usual graft material was used in quadrant 1. The bone graft was removed completely, And in quadrant 2, sinus lift was done. In quadrant 4, the implants were placed close to 44. And the sinus lift was done again for quadrant 1 and quadrant 3, 2 implants. The stability is very good. Why I didn't mount healing abutments? There's no teeth on both sides, so they should not be loaded. Therefore, all implants in the lower was submerged, and the second surgery was performed. And I provided the provisional restorations. Number 16, ISQ value was rather low, and the single implants and provisionals were provided for the rest of the implants. As Dr. Cho said, the custom abutment and PMMA were used to provide the provisional before I sent the patient to Dr. Pak.
So the patient came back with implants. Occlusion-wise, it looks okay, but when you do orthodontic treatment, the anterior teeth needs to be retracted. The bite becomes deepened. If the bite is like this, it's okay, but to do ortho treatment, we need to increase it. Because ortho treatment is extended, the posterior wear can occur because the bite continues to deepen. And if we make the bite a bit high, it's something that I can grind off. So I always ask to bite to be raised. Bite was raised and orthodontic treatment was initiated. The clear aligner utilizing digital orthodontics was used. Orthodontics was to intrude the upper and lower anterior. The prosthesis in the posterior region should not move. And digital orthodontics can have many strengths. And the brackets that is used in the conventional orthodontics, the individual teeth are not just straight, they have each angle. And the average of the mean value of 3D value of individual teeth are evaluated. In this case, we can take impression and cut the teeth and create a model and use passive bracketing. We can do this, but it's quite cumbersome. Digital orthodontics, and we just need to scan, so it's quite easy. About 4.5 months later, the space is closed, and you can see there's two major problems. There's a black triangle, and I wanted to close it. And the cost of orthodontics. And if we ended within 4.5 months, the patient may feel flabbergasted, they may feel overcharged. So we did scanning once again, and applying the appliance is not very uncomfortable. So the patient's perspective, it's not a loss. So the black triangle has decreased significantly, and final prosthesis was requested. If you look at cephalo, you can see a bit of retraction, and implants were placed nicely. If you compare, this is the initial state and final state, and after 1 year. If you look at this kind of patient, you may be at a loss as to where you should start. But as in orthodontist, it's a more simpler case. So if you use digital orthodontics, at face value, it may seem difficult, but once you work on it, it's not that difficult.
So I am doing implant and prosthodontic treatment mainly. So the posterior region doesn't really have teeth, and the aligning is done again for the anterior only. And retainers. Do we need to provide the retainers the fully like orthodontists? What do you think? So when we mount the retainers, lingual fixed wire would be attached to that. So removable retainer can be used. So from 3 to 3, I attach that. And number 4, prosthesis is added, but that it can be fallen off. So in that case, removable retainer is made together. So fixed retainer and removable retainers are provided simultaneously. So that is a safer way. Clear aligners. So interdisciplinary approach. And I don't do ortho treatment that much, but when absolutely necessary, and sometimes I'm not sure whether attachment can be used, then I use clear aligners. There is a missing teeth in the mandible. This is my case. No central incisor, and at 2 and 2, there is a distal gap, and I'm not sure whether attachment can be attached there. So a clear aligner was used, and about 4 weeks, 2 aligners were used. So that implant space can be provided. One MS kit, MS implant was used to perform surgery and prosthesis. Simply, just a slight movement of tooth can be made, and it is difficult to use very complicated procedures. Then a clear aligner can be the answer for implant therapy. Simple tooth movement can be made without using brackets. So discussion is coming to a close. Before we close, as I said, the survey results. Let's look at how actually the treatment was provided. You saw this. This is the initial and panorama images. Roughly, what option would you choose? Some are rather aggressive treatment plan, and the survey result is something like this. Number 2, plan. So implants are focused on in the anterior and the posterior regions. 64% chose that, and plan 3, and the fixed prosthesis in the anterior region using natural teeth, and in the posterior region, implants are used. That's 22%, and plan number 1, 13%, and the full mouth restorations using natural teeth received the smallest responses, 1%. And what was your actual treatment plan used? When the patient came, treatment plan, Amolang is indicated at the bottom in yellow. That means I don't know what to do. I'm not skilled at ortho treatment, and I'm not very good at the space alignment. And I can agree with the option 1, 2, and 3, but can it satisfy patient? So the patient reared the children, and the purpose of receiving this treatment is that she wants to attend the son's wedding with a full mouth. So I tried to preserve teeth, so perio treatment was provided, and I persuaded her that all the treatment is absolutely necessary to preserve the teeth. So brackets were attached in the mandible first.
Leveling was done, and the upper anterior was retracted. TFO occurs, so we need to retract the lowers first. And then it was done in the upper number 14 and 27. Forced eruption was commenced. If you look at number 27, the crown cutting was done intentionally, and pulling occurred. In the anterior zone, retraction was done. Bite was improved. There's spacing, as you can see. It's not tooth missing. There's number 2 nearby. But because of the space, the midline in the upper and lower, it's slightly deviated. We originally need to correct the midline. But as mentioned earlier, the patient needed to go to a wedding, and we decided to go on an implant. So having one more tooth, other problems aside, I thought that it was not a major problem. So orthodontic treatment, the midline is deviated, but the upper and lower, they're in line. So prosthesis was, lower implants were referred.
So according to his plan, I placed the implants at number 36 in the mandible. The ridge was very thin and crystal width was 2 or 3 millimeters. So on the 5 millimeter diameter implant was placed. It healed well. The advantage of splitting, it has very short healing. So 3 months later, the second surgery was done. It healed very fast. So that's the advantage of the splitting. And number 36, the same splitting was done. Membrane was used. 3 months later, in the second surgery, as you can see, it healed well. So abutment prosthesis was delivered.
Implants were placed in the lower and the upper. In number 27, after extraction and implant placement, it was as shown. In number 42, which is the extra tooth. So I gave up on the midline and decided to secure more space, and that is why the treatment became extended. And referral was done again. If you look at the bottom, it's after about 5 years. It looks stabilized. Occlusion-wise, it's not ideal, and midline is slightly deviated. And we added number two teeth, but the patient was very satisfied, and the overall conditions was improved. The forced eruption, number 14 and 27. Number 27, there's crown. We cut it out and added wire and pulled it. If you look at the X-ray, the alveolar bone level was very low, but you can see it has improved, and I think that helped with the implant placement. Forced eruption was done, and after removal of number 27, we increased the space for number 6. That's the way we proceeded with treatment. This was so I requested perio treatment when the patient first came, and the leveling was done from the lower, and then a forced eruption was done along with leveling of the upper, and the lower implant was referred. After that, upper implants were referred. 42-1 was opened, and it took 2 years and 2 months. When reviewing this, when we were leveling the lower, there was no reason to delay the forced eruption in the upper if I had done it at the same time. Maybe the treatment period would have been reduced by 5 months. And that is something that I think I could have done better. So if you compare the patient with the initial visit and the result, I'm sure the patient was extremely happy. Dr. Chang?
So I sympathized with the patient, and I tried to preserve the teeth as much as possible and provide minimal treatment at the beginning. The patient was not speaking much, and now she's wearing lipsticks very often. So it is rewarding to see her that way. And the first eruption effect, I know about it, but I was obsessed to reduce the treatment time, so I was kind of avoiding it. Number 15 or elsewhere, the bone grafting was not done, but we can take some time to be more efficient. In the front 42-1, I provided a quick treatment, and one more implant was added. I named it 42-1. It is not exactly 42, so that's the additional implant that was provided, and I believe I'm satisfied with this.
We looked at different cases as we looked at interdisciplinary cases. In the end, there are patients that require interdisciplinary approach, and patient selection is very important. Detailed interdisciplinary cooperation method needs to be devised. I think it affects the long-term success. Detailed treatment plan needs to become up first, or else we need to make compromises along the way. Through team approach, we need to manage patients who require implants, and by doing that, fewer compromises will occur. Dr. Cheng?
So when I prepared for this discussion, I reviewed my approach for my patients and I reflected on that. In the survey, number 1 and 2, 3 received a lot of votes. And number 1, I thought number 2 or 3 would be the answer, but in many cases, I would choose them. But through this kind of treatment, more satisfactory treatment can be provided for me and the patients. And a very troublesome patient comes to me. It's an ambulant case. That means I don't know what to do. It is a headache, but my headache can be transferred to another expert. That relieves my burden. So when pain is shared, the pain would be reduced. And that is the personal experience of mine in reviewing this case.
I agree 100% with Dr. Cheng. And while I was working together with Dr. Cheng, I felt really rewarded. In terms of treatment option number 1, removing all teeth and providing implants. So when we first talked amongst ourselves, we thought that we had to have 4 options, but realistically, the survey results surprised me that a lot of people opted for number 1. By doing interdisciplinary approach, we can save as much teeth as possible for the patients, and I'm sure it's the same with other dentists. But when I train my staff, the principle of treatment is we need to go into the patient's shoes. So that's the approach we need to have. It's number 1 really feasible. Do you think you would do that to yourself? By doing interdisciplinary approach, I think we would be able to save as much teeth and provide a good occlusion. And it will benefit the patient, and that is also a good thing for our dentists. So I agree.
So we can start with a simple one and progress to more complicated ones through interdisciplinary approach with other experts for good outcome. Thank you very much for engaging in discussion for a long time. This concludes the discussion session, and let's go to Q&A. Thank you very much for staying with us until the end. If you have any questions, I'm going to open the floor for questions, and we have many questions received from online. Thank you for the presentations. So my question is, the ortho treatment for perio tooth. So you can cause mobility in normal tooth, and in perio tooth, significant mobility can be made, and we have to extract the tooth. Dr. Chang, do you determine whether the tooth needs to be preserved or extracted? What is the criteria? So I have seen the perio patients for more than 20 years. Ortho approach and prosthodontic approach are different. So I am more aggressive when it comes to the prosthodontic focused treatment. And when perio condition is very poor, when I talk with Dr. Pak, and Dr. Pak is treating the patient pretty well. takes some time. If you do not apply excessive force, if you take time, many teeth can be saved. As you said, TFO can be caused during the movement of teeth, and if you use the perio treatment together, as you heard in the morning, the antibiotics can be used. Then I have never seen extracting a tooth in the middle of the treatment. For RPD, as you may agree, we usually extract a tooth. Only solid teeth are saved, but in ortho treatment, the situation is different. If I may add, it's a very difficult situation. There's no criteria, and it depends on individual patients. One thing that we need to be careful about is that the pathologic mobility, the cause of that, is it due to secondary TFO or others? If it is related to TFO, tooth movement can help, and the mobility is drastically reduced with that therapy. So if you are not sure, provisional restoration can be used as a potential treatment therapy, and the definitive therapy can be provided later after some observation. Thank you for good presentations. I'm an orthodontist, and I refer patient to periodontist, and it is not easy to determine when to send the patient, and it is difficult whether ortho treatment can help, and there are the first stages, the periodontitis, just scaling can be sufficient for some, and surgery may be required for some. And when do you determine that the ortho treatment should be performed at some stage? So orthodontists needs to determine whether the ortho treatment can help the patient. What is the criteria in determining the timing of referring the patient to an orthodontist? My decision is very important to send the patient to orthodontist. Non-surgical treatment, the root planing, scaling, and curettage are performed first, and local surgery is sometimes done, but that's done very rarely. Non-surgical treatment is repeated in short cycles in many cases, and bacteria control in the mouth should be done, and if scaling is repeated, often a lot of improvement can be made. Then I can send the patient to orthodontist. We persuade the patient to receive ortho treatment, and sometimes we have to remove a certain tooth from occlusion. And if I may add, interdisciplinary approach, it is different from multidisciplinary approach. The leading clinician's role is important. If a case is periodontist, perio, and prosthodontic approaches are usually done by the same dentist. And in the field, rather than the timing of referring, who makes the decision is more important. In the survey, we talked about the orthodontic patient, and when the patient should be sent to a dentist for implant therapy. Clear aligner patient is patient for restoration. So in practice, who makes the decision for referring the patient to orthodontist? That's made by a leading dentist. From orthodontist perspective, I'm not providing the permanent prosthesis, so I tend to take time. And a certain patient, a hopeless patient, needs to be extracted, but for orthodontic treatment, we need to keep the tooth a little bit longer. And it can be used as the hopeless tooth can be used as an anchor. And I usually tell Dr. Chen to keep a tooth unless it's excessively swollen and problematic. And after ortho treatment, to extract it or not, it can be decided by Dr. Chen. Many difficult questions have been received, and to answer some online questions. Contact loosening tend to be generated more for implant and prosthetic treatment after ortho treatment. And number 7 is uprighted. And between number 5 and 6, an implant is placed in between. I do not provide retaining if it is uprighted like this, and you don't need to be concerned about this tipping. So that kind of loosening doesn't occur that often. And another question, sleeve and coil spring uprighting, how do you resolve the opposing tooth interference? It is a tipping, not bodily movement, so opposing tooth interference would be present. So occlusal adjustment should be checked for the upper and lower arches. In my case, final prosthesis, clear aligner case. So 4 posterior teeth were single implants, so spacing occurs only in one place. They are not connected, so they are all individual single ones, so the problem is not severe. Actually, many questions have been already addressed during discussion, but do you have any more questions from the floor? The last question. Thank you for the good discussion. This question goes to all 3 of you. And I do the treatment alone. Orthodontics and implant and other therapies need to be provided when there is pocket depth. Intrusive force, it can be applied, worsening the pocket depth. Actually, if we are considering extraction, extrusion can be applied, or intrusion can be provided even with a deeper pocket depth. There are many different options. So there's complicated cases, especially for the anterior region. What kind of choice do you make? That's a very broad question. Of course, based on the treatment plan, whether to preserve or extract a tooth should be considered. If the tooth is to be extracted and implant restoration is provided, then forced eruption can be applied without using in order to gain some soft tissue or hard tissue to substitute the bone graft. If there is a perio problem and intrusion is necessary, before intrusion, massive basic therapy should be provided. After that therapy, after periodontal control is provided, orthodontic treatment should be provided. Is that right? So a lot of papers have been published on that topic. When periodontally poor patient, intrusion is prohibited, contraindicated. So I talked about the intrusion of the upper teeth when there is a perio pocket that is contraindicated, that will create a vertical pocket, and you need to cut and forced eruption should be made. Alveolar bone would follow. The root length would not change in the alveolar bone, and if you cut the crown root ratio would be changed. So for vertical movement, if there's pocket and perio problem, you need to do extrusion, not intrusion. And Dr. Melson used intrusion using attachment. The conclusion is that with intrusion, if you do intrusion, it is a risky approach. And I believe we need to have a different approach for anterior versus posterior regions. So intrusion should not be made for the posterior region, difficulty of brushing. If there's massive problem in the anterior region, and if intrusion, slight intrusion can be made with the wire retaining, and good results can be made. It depends on the anterior versus posterior regions. And then active perio treatment should be made as well. From my perspective, if anterior region is mobile and elongated, and deep pocket depth is observed, the forced eruption can be used, but the problem during the forced eruption, provisional can be a problem. It looks ugly, so people who are working would not like that. So in my case, I extract them, and if immediately cannot be made, alveolar preservation would be made, and through surgery, hard and soft tissues can be made for the recovery. That's more practical approach as a periodontal perspective. So that's an easier approach that we can use. So it depends on the approach. Maybe you have further questions, and you can ask him individually later. So thank you for the questions. So this concludes Q&A. And the first questioner and the last questioner are chosen as best questioners, and they will receive some gifts. So the Q&A of the last session is finished. Thank you very much for staying with us. Thank you. I would like to thank my colleague doctors who participated in this session. Thank you.
네, 마지막까지 수고해주신 백운봉 원장님,
Dr.
창동욱 원장님, 조영진 원장님께 다시 한번 큰 박수 부탁드립니다.
Please give them warm round of applause once again.
네, 이번 시간은요, 오늘 있었던 오상윤 원장님과
So we are going to look at panoramic review of the live surgery. Let's have Dr. Oh first and look at review the live surgery case. Please welcome him with warm round of applause. So I will proceed with the first live surgery review. This is pre-op image, and the most difficult part was in number 42. So it's been cut off, number 42. And the cortical side, how much site preparation are we gonna do? In general, 1.5 is good. In my case, I did it. I tried to do sufficient drilling, but there was some difficulty regarding this end. A lot of questions are surrounded here, whether it required a root coverage. So after removing Pontic, this area, recession worsened significantly. If I had left it, gingival recession would have worsened and long-term stability would not have been ensured. But with the root coverage, if we made a gingival phenotype thick, then it says a lot of literature says that it ensures long-term stability. A lot of people asked whether it had to be done at the same time. There's pro and cons. So you can do it at once if you do it simultaneously. And the cervical line can be adjusted. The downside is that it's very difficult to do healing, especially in this area. Coronal position can be very difficult because you need to press it for GBR. In the recessed area, you coronally advance the flap as well as GBR. It needs to be apically positioned, so it's slightly conflicting. If you do staged approach, perhaps if I had done a staged approach, it would have been better. This is post-op CT and panoramic image as planned. The implants were placed. So one question is, should I have used OneGuide? Yes, I think that way I have chosen is correct. The cervical line, buccolingual cervical line needs to be addressed properly. You cannot do it freehand because you would slip, especially in the case of one body. In my opinion, the using guide was the right option. Palatal was harvested, and then it was very severe here. Connective tissue graft was done. Non-submerged GPR was done. I used this for the first time, Osstem hard. Space maintenance is very good. By putting it in, space maintenance was possible. Cervical line, up to a certain point, it's quite difficult to make this area, but we were able to make the cervical line quite thick. Another point, temporary here, it's been fit. It didn't need almost no adjustments, so it was a major plus. Thank you. Thank you, Dr. Oh, for a wonderful comment. Let's look at the panoramic review of the Dr. Kim. So please welcome Dr. Kim with a warm round of applause. So this is pre-op image. And after surgery in number 36, it was planned quite deep and healing abutment 6x5 millimeter was used, but we changed to 5x7. And after removing guide, implant was placed because when we made it guide, we reversed the denture, so I was not able to get the support of the guide. In number 6, when planning, number 47 guide hole was not made. So For number 47, I placed the implant of freehand and transfer abutments were connected. And for number 37, distal side, it required a vertical bone augmentation. And in a pre-op treatment in number 37, I thought the crown would be too elongated, so I wanted to increase the soft tissue. 2 mm anchor was used. If bone augmentation, soft tissue augmentation, either that would be achieved, that would be good. If you look at CT, quadrant 4, this is 44, 43. In 43, I was most concerned about 3.5 if it is slightly slipped towards the buccal side, because the buccal wall, if it is less than 1.5, even if you do flapless surgery, labial plate can be resorbed. So I tried to do precise surgery, and that is why I designed 4 anchor pins. This is number 33. It's been about 1 month since extraction, so there is a labial plate, but it's similar to immediate implant placement. It was positioned lingually. Number 34, 36. Number 7, there was quite proximity to the canal, so you can use a 5x6 or use extra short implants. You can use 1 or 2 mm of bevel, but in this case, I decided to use 7 mm implant, and because the implants will be placed in the antagonist, I chose to do vertical augmentation. And number 8, graft material is nicely maintained. Thank you. Thank you, Dr. Kim, once again. Please give him a warm round of applause. The Osstem meeting 2025 Seoul is coming to an end. Before we conclude, let me introduce the lecture satisfaction survey at Osstem meeting 2025 Seoul. We conduct a satisfaction survey to gather feedback on our speakers' presentations. A text message will be sent to all on-site participants with a survey link. By clicking the link and completing a simple survey, you'll be entered into a lucky draw. A total of 200 participants will win a chicken gift voucher. Don't miss your chance. Participate and be one of the lucky winners. Next, we will proceed with the recognition award ceremony and on-site lucky draw. First, we will present the recognition award. Let me briefly introduce the previous participants. In 2013, Dr. Jayeyoung, in 2014, Professor Jong Chang-mo, 2015, Professor Cho Kyo-sung, 2016, Lee Kwang-hun, 2017, Professor Jo In-ho, 2018, Professor Kim Myung-rae, 2020, Dr. Kim Ki-sung, 2022, Professor Kim Young-gyun and Professor Lee Jong-yeop, 2023, Dr. Oh Hee-gyun and Dr. Park Jong-woo, and in 2024, Professor Yoon Kyu-ho. For the 2025 first half of recognition award, Chairman Shik will present the award. Please welcome him. The winner is Professor Jang Bum-seok. Please come to the stage. Please welcome him with a warm round of applause. Professor Jang has graduated from Seoul National University School of Dentistry in 1987, completed periodontology residency at Seoul National University Hospital, and he is former professor of periodontology at Gangneung Wonju National University, visiting scholar at Pennsylvania State University, and he is currently an emeritus professor at Gangneung Wonju National University. He has made outstanding contributions to periodontal research, mentorship, and community service, and through industry and academic collaboration, he has also played a key role in helping Osstem Implant become a global leader. In recognition of his contributions, Osstem presents him with the first half of achievement award.
Chairman Takeo will now present the plaque, prize, and bouquet to Professor Chang. Please give him a warm round of applause. Professor Chang, plaque and 10 million won research grant will be given. Now we will proceed with the photos. Please look at the cameras in the front. Please give us a big smile. Please congratulate him once again. Professor Chang, can you give a word? We would like to ask him a word. Professor Chang, speech.
Thank you for giving me this wonderful award. I don't speak a lot in Osstem implant meetings. I don't like make speeches, and I barely retired as an emeritus professor. My encounter with the Osstem implant, actually, we had the same advisor professor in a university. I believe I was at the first year in the dental school. And I was surprised that he attended other school before he joined the dental school, so he was older than us. I don't exactly remember, but he had practice, he had a clinic. I believe he made some program named Dupone, and I was impressed. And it was a long time ago, and I went university, and he acquired some company to make Osstem implant company. So the rumor at the time said that the company will go bankrupt, that the Osstem implant will go bankrupt soon, the following year. But looking back, he was a pioneer in implantology. Mostly the implants were imported from abroad. We used the Bronnemark implants quite a lot at that time. And Osstem implant grew quite remarkably. I watched its growth at the sideline, and it has grown tremendously. And I'm really happy to watch its growth. And the Chairman Che is strong-willed. He has the power of pursuing his goal, and I believe Osstem implant will become world-class #1. And I believe he made the company about 30 years ago, and it was when I became a professor, and he made really tremendous achievement in business, and it's a really impressive achievement, and I believe he will make more achievement. And once again, thank you for this award.
Thank you. Congratulations, Professor Chang. So we have had Osstem meeting 2025 Seoul, as well as Osstem staff meeting. We are now heading towards the end. How was the experience for all of you? Do you feel sad that it's ending? To wrap up, we have prepared a special lucky draw to thank you for your participation. We'll start with the online lucky draw, followed by an on-site lucky draw exclusively for attendees. We'll select the 9 winners. The third prize, a travel dental set. The second prize, Beauty's White Light, the teeth whitening set. First prize, an iPhone 16 Pro. After online lucky draw, we will hold an on-site lucky draw for those physically present. So stay till the end. The online lucky draw is exclusive to participants who stayed until the end. We will announce the middle four digits of the winning phone numbers. If there are duplicate winners, an additional number will be drawn. Let's start with third prize winners. First, the third prize winner. The first winner is number 3741 and 2. 37472. Second winner is third place winner 52202. 52202. Third winner 27068. 27068. Fourth winner 45731. 45731. The final winner 21352. 21352. Congratulations. We will move on to the second prize winners. There are 3 winners. First is 80615. 80615. Congratulations. Second winner for second prize 93678. 93678. This is the final winner for the second prize, 98993. 98993. Congratulations. iPhone 16 Pro winner. First prize winner. Who will be the first prize winner? 92613. 92613. Winners will be reached out separately. The Osstem Dental Staff Forum and Osstem Meeting 2025 held over February 22nd and 23rd have now come to an end. How was the experience for you? Thorough, insightful lectures on life surgeries by leading experts in the dental field. I believe many of you have had meaningful and valuable time. We extend our sincere gratitude to our chair speakers and all participants who stayed with us until the end. With that, we officially conclude the Osstem Meeting 2025 Seoul. I'm Inamul, your MC for this event. Thank you.